just like an angel. Your skin makes me cry. You float like a feather in a beautiful world. I wish I was special. You're so very special. But I'm a creep, and I'm a waiter. What the hell am I doing here? I don't belong here. I don't care if it hurts. I wanna have control. I want a perfect body. I want a perfect soul. I want you to notice when I'm not around. You're so very special. I wish I was special. But I'm a creep. I'm a weirdo. What the hell
ready? Thank you so much. Good to see you. Thank you for coming this way.
Nice to meet you. Jim Freeman. Very good, thank you. Can you introduce him? Yeah, he's also our Ricks Fellows. Is that right?
So, good morning, everybody. Please take your seats. I think we're ready to start our first session on LAAC and EP-oriented considerations. My name is Tondo. I'm very happy to chair this session together with Jim Freeman. And as you're all getting ready, it's also my pleasure to introduce our first speaker, an old collaborator of ours, Davide Fabbricatore, a native Italian but now working in London, who will present AF burden and rhythm management relevance. Davide, please.
Good morning, everyone. The slide work, yes. So thank you for the invitation. Of course, this is a very relevant topic, especially because very recently has been published a consensus on the AF burden. So for the first time, we have defined the AF burden, which is basically the proportion of time spent in atrial fibrillation defined as a percentage of time over define time monitoring. So when I read this consensus, the first question that I asked myself is, okay, so we have a consensus, so now we can clearly connect the atrial fibrillation burden with the necessity of anticoagulation. Unfortunately, the reality is not this. How we measure the burden? So we have different technologies. Of course, we have the pacemaker and defibrillator, but they are only a minority of our patients, and also in that case, the importance of the burden needs to be clarified better. But the technologies that we have available at the moment are basically three: the loop recorders, longest data. The specificity is not that great. Most of the time we have to reanalyze the episode ourselves. There is a lot of false positive episodes, as you can imagine. The Holter ECG is the best data that we can have, of course. So high specificity. Unfortunately, the sensitivity is not that great, because if the patient is having one episode per week and we're screening the patient only for 24 hours, you can imagine that we can miss the episode of atrial fibrillation. And in fact, the consensus statement that I showed you before states that we should screen our patient for 28 days. Now, I work in Royal Brompton. It's quite a posh hospital, but even then, we cannot do Holter ECG for 28 days. I would rather prefer maybe screening one patient for 28 patients for a day, or 14 patients for 2 days, more than one single patient for 28 days. And nowadays, we also have the wearable devices. They are very useful, great devices, but they are very expensive. I never recommend this to my patients, but I mention them. Of course, they are based on photoplethysmography, and when there is a suspicion of atrial fibrillation, they are able to collect trace, a single lead trace. So even in this case, the false positive acquire a lot of episodes. Why the burden has become more important? Because we know that the atrial fibrillation is not binary. It's not an entity like a paroxysmal yes or not. You know that we have a patient with paroxysmal atrial fibrillation who have a burden of 1%, and patient with paroxysmal atrial fibrillation who have a burden of 100% if they have an episode of 24 hours and we are screening the patient for 24 hours. So you can't really treat these two patients in the same way. We know now that we have a pre-fibrillation status and then a diagnosed area of atrial fibrillation itself. And also our knowledge in terms of rhythm control strategy has changed. Yesterday, Tom has discussed about the AFFIM trial, the ALONE trial. So the AFFIM and RACE trial taught ourselves for many years that the rhythm control strategy is not superior to the rate control strategy. But of course, there were so many limitations. The anticoagulation was stopped. It was a very old generation of antiarrhythmic therapy. And so we knew that something was wrong there, right? But the paradigm change happened with other two studies later on, the CASTLE-AF trial and the EAST-AFNet 4 trial, with which for the first time we treat soon enough the atrial fibrillation, we reduce the burden, and this translated in reduction of heart endpoint, cardiovascular death, heart failure, and stroke. And then the paradox now is, in fact, the ALONE AF and diversion trial, where we, again, are thinking of interrupting the anticoagulation in patients who have a very low burden after our ablation strategy. Of course, these are very low-risk patients. So the question that we have to ask ourselves is, does the burden predict the severity of the disease? This is a patient with atrial fibrillation, persistent atrial fibrillation. This is another patient with persistent atrial fibrillation. For the one who are not used to electroanatomical map, pink means good atrium, so good EGMs. Not pink is disease atrium, is a scar atrium. So you can imagine that I can do whatever I want with this patient, ablation, medical therapy. I will probably reach the sinus rhythm, and also the management beyond that will be different from the other patient. Even if here I keep this patient in sinus rhythm, I'm not sure that I can interrupt the anticoagulation. This is something that we have to acknowledge. Is the burden a modifiable risk factor? Well, is modifiable? Yes. We know that we can manage well the risk factors, physical activity, alcohol, obesity. With the arrest trial, we know that if we act enough, soon enough on the risk factor, we can reduce the burden of the atrial fibrillation significantly. Medication and ablation works even better, but is a risk factor? For what I've said before, probably not at the moment. So what the guidelines on the atrial fibrillation say in the management of the patient, we have to focus on two things, basically. We have to reduce the symptoms of our patients, and we have to reduce the risk of stroke. So I ask myself, okay, does the burden represent, well, the symptom of our patients? From this meta-analysis, you can see that basically a quarter of our patients with episode of atrial fibrillation are not symptomatic during this episode of atrial fibrillation. And the asymptomaticity increases if the patient has diabetes, or they have clinical kidney disease, or they have a previous stroke. They become more symptomatic if they have heart failure. We also mentioned that before yesterday. If they have had a catheter ablation before, most likely because I've changed the burden from persistent to paroxysmal, and so now the patients are more symptomatic. They feel more the episode because they are not all the time in atrial fibrillation. And also the use of antiarrhythmic, most likely for the side effect derived from that. Stroke prevention. Oh my God, this became even more confusing. Yesterday, Tom has mentioned the ASTRET trial, right? So in which we screen the patient with the devices, and there is no time in correlation between the episode of atrial fibrillation and the episode of stroke. But what the other studies that we have done more recently say? So the more recent trial that I want to mention are the LOOP trial and the stroke stop trial. I think that they're very interesting, and they represent the same aspect of the same disease, different aspect of the same disease. So basically, in the LOOP trial, we were screening the patient for a long time. And in the stroke stop trial, they were doing ECG, 30 seconds of screening basically, 2 times per day per 2 weeks. What happened in the LOOP trial is that the patients were found to have atrial fibrillation 3 times more often, but the episode of atrial fibrillation which require anticoagulation were considered beyond 6 minutes. But if you do anticoagulate this patient, you don't have a reduction of the stroke. In the stroke stop trial, actually, all the patients were found in atrial fibrillation with this intensive screening were started on anticoagulation, and there was a minimal but statistically significant p-value 0.04 of reduction of the stroke. What it means that the burden is important, because in the stroke stop trial, if you found the atrial fibrillation, that was over 60 seconds per day for 2 weeks. In the LOOP trial, 6 minutes of atrial fibrillation spread in such a long time, probably they have clinical relevance a bit inferior. So the take-home messages from this consensus is that the binary classification of the atrial fibrillation is definitely inadequate, is a useful tool for the treatment to see if the patient responds well to the therapy or not. It's insufficient at the moment to guide us on the anticoagulation. We can discuss about that later. We need continued monitoring, optimally for 28 days. I don't know if it's feasible in your hospital. And the threshold need to be clarified a little bit better. These are probably the two things that we are studying. It is important to standardize our approach also in view of future studies. So potentially the burden beyond 11% and episode of atrial fibrillation lasting longer than 24 hours are important for the stroke, for the incidence of stroke. And this is just the final provocative slide of mine. So this is a patient who came to my lab like 2 months ago for a redo atrial fibrillation ablation. So it's all red. It means that the atrium is so scarred. There was nothing to ablate. The only thing that I wanted to do here, despite this patient had paroxysmal atrial fibrillation, so very low burden, we checked the appendage after, and you can see that with the contrast, there is probably, you can tell me better, there is probably a pre-thrombotic status in the appendage. So in this case, patient with symptomatic short episode of atrial fibrillation, so low burden, nothing to ablate, paroxysmal AF, but we decided to close the appendage anyway because we don't treat only the numbers, we have to treat the cardiomyopathy. Thank you very much.
Thanks a lot, Davide. We have time for a few questions. I can start by asking you your thoughts on burden and wearable. So you showed us very nicely the evidence and the lack of evidence currently on AFib burden to guide anticoagulation strategy. What are your thoughts on AFib burden and specifically on continuous monitoring to guide intermittent anticoagulation therapy? So there's a lot of theories about that and ongoing studies. Given the data you showed, do you think it makes sense? Do you see a future where some of our patients will take anticoagulation for a week if their watch tells them you're in AFib?
Yeah, I do that, in fact, especially for patients who don't want to stay on anticoagulation for lifelong, basically. I think that the difference is if the patient can afford that, the cost is quite high. At the moment, we can use also the Alive core, which is quite cheaper, £100, and so they can have these strips of atrial fibrillation. I think that the difference is that I told you that 25% of our patients with AF, they don't have symptoms of AF, but some patients do have symptoms, and you can correlate the symptoms well with the atrial fibrillation. So in that patients, I also educate my patient to feel their pulsation. If I feel that the symptoms correlate well with the atrial fibrillation, I do intermittent anticoagulation based on that. Otherwise, I think that the optimal strategy would be definitely the wearables. But nevertheless, you have to base your consideration also on the Charles score. For some reason, it works, even if it was done in a previous era.
Very nice talk. I'm fascinated, or actually was fascinated by the potential of an iWatch to detect AF and maybe also after ablation try to help if anticoagulation is needed. But the specificity that you showed here, 34%, is extremely disappointing. So can we forget about watches for monitoring for AF, or what is your thoughts, or is it a question of getting better technology, or?
Yeah, I think it's a good idea. I think that they are a good tool. The fact that we have 34% of false positive doesn't mean that they don't work well. They probably work too well, and so sometimes you have to reanalyze the traces, but it doesn't mean that they don't work well. So you can recognize the episode of atrial fibrillation. The problem is more like if the patient is having also atrial ectopies or other things that can confound confuse the algorithm. But I think that, yeah, they are a great tool for sure. There are many things happening. I think that in the ESC conference last year, they were talking about all these AI algorithm, new devices to use, stethoscope, iPhone itself. So I think that the future is there.
I mean, I think a lot of the wearable technologies can also be really useful once you have a diagnosis and once you kind of clearly establish when people are having it, and then you can use it for surveillance. So, you know, we often use it for after ablation rather than establishing a diagnosis that way. You have to confirm it with something more sort of, I guess would say medical grade. Can I ask, so you throughout the number of 11% burden as being important, and where did you get that? And
it was a meta-analysis, but they are all retrospective data.
Okay.
So it's not, as I say, the consensus say that we should focus on the burden as a percentage and probably try to understand the new thresholds, and this could be potentially one of them. But it's not that has been, you know, validated in randomized trials yet.
Yeah, that's a high burden. And so, yeah. I mean, for those not in the EP space, Jason Andrade's made a huge push for this AF burden metric, just to try and understand when we should be intervening symptomatically and otherwise. But I think we still have a lot of work to do to understand burden and how, kind of what our thresholds are for stroke intervention.
Yeah. I think that the burden becomes more important. The burden is higher also because you should document the longest episode of atrial fibrillation. Having a burden of 5% with one single episode of atrial fibrillation is different than having a burden of 5% with many episodes of atrial fibrillation. Yeah, most likely that's also the reason why.
Great, thank you.
Thank you.
All right, so I'll introduce Tom. So Tom will be talking about imaging the left atrial appendage, the EP perspective.
Thank you. So, imaging in EP procedures, I didn't choose this title. Someone else was on the program, but we look at the appendage the same way everybody else does. But there are some considerations, I would argue, within EP procedures, which I'm happy to share with you if the clicker feels like cooperating. You just use this, right? There we go. All right, so if we think about procedural steps in our EP cases where we might be doing LAA closure and something else, I don't think it's anything spectacularly different from what you might imagine. We do groin access transeptal puncture, we size the left atrium, the left atrial appendage. We do something else potentially because nowadays if we do LAA closure, it's not necessarily only LAA closure. Of course, we might be doing an ablation meanwhile concomitantly, and then we deploy the device. The first step, imaging, although it's not related necessarily to imaging of the left appendage, I do want to stress that it's critically important, and I think the entire field of EP has moved to the vision that doing a procedure without echo-guided vascular access is no longer a defensible position in 2026. I hope this is the same in the IC space. I don't know, I'm guessing it is. But obviously, the lower risk of vascular complications is the key driver, as we have seen, for example, in closure with AF. The vascular complication rate is not negligible, is in my perspective, a missed opportunity. Same, of course, for the transeptal puncture, echo-guided transeptal puncture, where I think in the LAA closure space, everybody was doing echo-guided transeptal puncture from day one, because obviously you need the echo anyway to image the appendage, to size the device. And then there's discussion about GA versus sedation, which I'm not going to go into for the purpose of this discussion, but we do use GA for pretty much all cases we do. So the vascular access, as already mentioned, we have a consensus document out about this, strongly supporting, next to a lot of management strategies for difficult access, strongly supporting the idea to use ultrasound for all percutaneous vascular access based on good solid data. There's been a randomized study published last week, I think, which again was supportive of the idea. And the other thing in terms of access is the transeptal puncture, of course, and there we always discuss about location, just a bit like in real estate, location, location, location. In EP procedures, the reason I mention it and the reason I highlight it is that if we are doing concomitant procedures, it's of course not necessarily the transeptal puncture for the LAA closure we're trying to optimize. We're going to do a transeptal puncture that is useful for everything else we might want to do in the case as well. And for example, if you want to aim for a particular lido and especially for very particularly posterior puncture, as has been advocated for many LAA closure procedures, then you might get into trouble accessing, for example, the right inferior pulmonary vein. And so we'll aim typically for something that's a nice compromise, and this means we'll need devices that accommodate, for example, a potentially suboptimal transeptal access from the point of view of appendage closure. For example, the devices that allow you to push a little bit against the wall of the appendage to reposition the device, ideally using steerable sheets as have been introduced to the market recently. And again, the reason this is a reality is because we are, especially in the US, seeing an incredible uptake of concomitant procedures, concomitant LAA closure procedures based in no small part on data from the option study. So back to imaging, what do we do in our lab? In our lab, we have developed a very standardized workflow for AFib ablation, which we've called the conveyor belt, which is based on imaging. And depending on the technology we use, this may differ a little bit. We may use 3D mapping systems. We may use more angiography-based methods, but the common element is we build a 3D model of the left atrium and we work on that. And the nice thing, of course, is that this 3D model is often also useful for the purpose of appendage closure. And this is one approach we've worked on a lot. We've been using it for 15 years, which is 3D rotation angiography. 3D rotation angiography, which will give us a CT-like model of the left atrium, of course, with the benefit of having the 3D model integrated in the fluoroscopy and real-time available for analysis in the lab. It allows you to do everything you would expect to be able to do from a CT scan. You can segment, you can build a 3D model, you can rotate it any way you see fit. And you can, for example, one of the nice things about it is you can use it to identify your ideal workflow using the X-ray. For example, due to the fact that it's integrated in the X-ray system, it's a simple matter of moving the X-ray tube and the model will rotate together with your X-ray tube and you will understand what the ideal visualization angle of the neck is. You can, of course, measure the diameter in any orientation, as you can do with CT, as you can usually also do with 3D TE, provided the image quality is good enough. And then you can choose the device size based on 3D measurement rather than conventional 2D TEE. And finally, what it may allow you to do, and what we've done and validated in the study, is it may allow you to do procedures without TEE, using only this rotation angio workflow. So here are some examples of measurements of the left atrial appendage. And again, the scenario where 3D measurements really shine are, of course, scenarios where the appendage is extremely eccentric, where the shape of the appendage is such that standard measurement planes may underestimate the true dimension of the left atrial appendage, and using 3D measurements allow you to truly understand the proper dimensions and allow you to choose a device, for example, not on the maximum or minimum diameters, but on the average diameter of the appendage. Finally, something we don't do in clinical practice, but something you might imagine doing research on, it also allows you to fuse 3D imaging modalities, allows you to, for example, visualize how a device might look in a particular appendage. So as mentioned, we did study this approach and to study the accuracy of 3D imaging compared to TE and to study the feasibility of this workflow for performing procedures without TEE, again, without going into the specifics. What we found, as with other 3D imaging studies, is that there is a bias, a predictable bias, a systemic bias of higher estimation of diameters on 3D measurements, which is about 3 millimeters if you compare it to 2D TE. Finally, before I show you some examples, so the standard workflow, let's say, the treatment path of our patient, as shown already, echo-guided access, groin and transeptal puncture. Then if we do a PV isolation, it will be ICE or TE guided PV isolation. And then we do the LAA closure, depending on the image modality we have, supported by ICE or TE, procedures under GA. And importantly, if we do concomitant procedures, we measure the left atrial appendage, ideally, of course, before the PV isolation, because as you know, there's some data out there, especially with RF ablation, indicating that RF ablation can cause edema formation of the appendage and can distort your measurements. We studied this also in the era of pulsed field ablation, and to our enjoyment, we found that pulsed field ablation did not seem to affect the appendage a lot. So what we found was that probably you can use the measurements even after the ablation of the appendage to size your device. And then just some examples from real life. This is from a live case we did a while ago. A very famous Belgian intervention cardiologist here. I don't know if Lisbeth is there. She is. So a case Lisbeth and I did about a year ago, I guess, to show you the rotation angio approach. So what you see there on the left of the CT of the imaging screen are the segmented images showing the MPR reconstruction, showing the device measurement. And here you will see the live overlay, and what you will see and hopefully appreciate is the nice match between the angio that I will inject, so the contrast injection, there we go, and the reconstructed segment model. You can see that it's almost a perfect fit, so you can perfectly well imagine that such a 3D model may be suitable to guide your device implant even without using TE. Here's another example from a live case showing deployment of the device. We put a line there on the 3D model where we would like the landing zone to be, and we will deploy the device. I think this is still Watchman. This is a pretty old case already, where we deploy the device and we can appreciate that our device is where we want it to be. And finally, another example or another approach is to use ICE. And ICE, of course, is also not unfamiliar to all of you. One of the unique applicability or applications of ICE in the EP space is that we can have integrated ICE in our 3D mapping systems. And this allows us to do things like you see here is machine learning based automatic segmentations of the left atrium, which is using the ICE images to generate a 3D model. And then, and what you see there on the screen is the 3D representation of the imaging plane of the ICE probe. You can appreciate and understand the anatomy easily, even without necessarily having a lot of ICE experience, by integrating this in the 3D mapping system. Can we go to the first marker? Yes, there we are. So you can go to the second marker, please. So here, for example, is the end of our PV isolation procedure. We finished the 3D model is there. We switch over our access to the Watchman delivery system. And then we'll go to the next marker, please. We're already a bit out of time. Yeah. So here, now I can use this 3D model and I can scan around using my ultrasound, using the ICE catheter to understand the geometry. Let's go to the next marker to do the measurements, using the ICE to do ICE-based sizing of the appendage. And then to do ICE-based deployment, delivery of the appendage occluder, and finish the procedure. Let's go to the next marker. And there we put the device and we can finish our case. So take-home message in our lab, our EP procedures, including LAA closure, are echo-guided everything, which eliminates access complication risks. Transeptal, as indicated, depends on what else you might need to do, and I think the availability of steerable sheets have dramatically influenced our reluctance to use, let's say, suboptimal transeptal positions. Depending on the device design, for example, using Watchman Flex, which is a device I use a lot, we size, but then I use the maximum reasonable diameter I can think of to fill the appendage. And then, as shown already, we tend to use the anatomy of the appendage a bit to position our device. Thanks a lot.
Tom, that was great. Thank you. So I'm curious what the practice is in Europe. In the U.S., there's new universal use of ICE for AF ablation. And then I've been interested to see, we thought that there would be rapid adoption of ICE-only left atrial appendage closure procedures and concomitant procedures, and we've seen that actually kind of hasn't been the case. There are a lot of people still using both ICE and TE. Is that commonplace in Europe as well? So the numbers are about 20% of cases, left atrial appendage closure cases involving ICE. But about half of those are ICE and TEE. So in our lab, we'll do these cases. We'll get a CT in the week prior to clear the appendage and clearly understand the anatomy before ablation, so we understand the size of the appendage. And then we'll do just ICE-guided only procedures. So like how much is that taking off here in Europe?
Well, first of all, ICE-guided procedures in general, PV isolation or LAA closure is not that pervasive in Europe due to budget concerns and budget constraints. And second, your observation is correct. I also see operators, even those that are using ICE to guide the PV, to consider TE for their LAA implant. For me, it's a matter of being inside or outside the comfort zone. So if you're doing PV isolation using ICE, typically you can use the right-sided axis only. You can stay on the right side. You do what you are already trained for. You visualize the atrium, you visualize the veins. But then if you want to go and do the LAA closure with the ICE, ideally you want to the ICE probe in the left atrium, and you need to learn a little bit new angles, new stuff. So that's why I thought the 3D integration was so useful. It helped me a lot, for example, to understand how to manipulate the ICE probe, because the images are not images you're used to seeing. And if you have the option between somebody doing the TE for you and showing you what you've been seeing for the last 15 years, and it's super straightforward, or having to relearn something new, I guess most people tend to stick to their comfort zone. At least that's my interpretation of what's happening.
Yeah, I mean, I love it. I like having control of the imaging myself. It's sort of made a procedure that's become a little much more interesting, but there's a bit of a learning curve. We actually did overlap for about 6 months to try and figure out how to get the images. And of course, with 3D, and our industry partners here are working very hard on 3D technologies where you don't have to have quite the expertise. But.
Yes, James, I think your comment is right. I mean, just probably one of the more fortunate in Europe, because I use ICE all the time, and I use ICE and not just for catheter ablation, even for appendage closure. You need just to at least, I mean, just in my view, to place the probe in the left side. I mean, just you can use the same hole. Or maybe you can even, do the two transeptal, puncture, just to have, much flexibility, and you're free just to move the two sheets. But I think that ICE, even though ICE, can give you just less views as a TE, but at the end of the day, if you look at the, clinical outcome, the result, I mean, just the success rate is still the same. I mean, just you have, almost all the time with perfect sealing and a perfect placement of the appendage closure device.
Yeah, we've actually had cases too where I wish we had an ICE probe in. We're doing TE guided where the imaging is not ideal from the esophagus, and I don't know. We've gotten facile enough with it that I think you can really get remarkably good imaging from inside.
The other issue is the cost. I mean, just and remember, this is what probably prevents people from adopting ICE currently in daily practice.
And I guess the other element, and maybe Erik you'd like to comment, is that potentially, if we forget about cost for a second, potentially upcoming improvements in technology, high-resolution imaging plus for the ICE may allow right-sided imaging to be done by ICE again.
Exactly. Those catheters are expensive. I mean, that's the challenge, and so I think it's really important that you
I would
that.
say, Tom, you have very easy access to GA, and that is definitely not the situation in many centers. So, for instance, in the Nordic countries and also in Italy, I think ICE-guided LAAC is the dominating workflow. and it makes things logistically much easier. I think it's also very convenient for the patient just to have the procedure done in local anesthesia. You don't have all the post-anesthetic recovering and things like that. And there is a learning curve for ICE, and as pointed out, we go to the left atrium, but we now have the 3D ICE probes, and that will allow us to do less manipulation with the ICE catheter. So in many cases, you will be able to be in more or less one position in the left atrium, and from there, by digital steering the image planes, you can get all the relevant views. So the technology is being advanced, and I think it will be easier also to do ICE. And then there's the issue, of course, of economy, but if you make the calculation that you don't need a full GA team, you don't need a separate T operator, I mean, it can be, at least when we did the calculation, it was cost neutral to go for an ICE-guided approach, so it is possible. But of course, if we could bring the prices down and have also re-sterilization of the probes, that will facilitate that.
I agree. This strongly depends, of course, on how reimbursement is organized. In your experience, does 3D ICE allow RA imaging, or will it still be too much of an issue with certain septa or whatever?
Not at the moment. We have not tried. I think that's something that should be looked on systematically, but I would still I mean, going to the left atrium, you get extremely good images, and of course, in the beginning, it's a challenge to cross with the catheter to the left atrium, but it's also a matter of a learning curve. So I'm not sure that this will be around the corner just to do imaging from the right atrium and get very good images, but let's see.
I mean, our imaging partners are definitely working hard on it. It's challenging, though, with the membranous septum. The image quality definitely degrades, and it's just not quite as good. But I should say, too, the outcomes when we've looked at ICE versus TE in the NCDR registry, the outcomes are very similar. We've seen a small signal towards increased risk of pericardial effusion, likely with the crossing over and the manipulation of the left atrium, but that was from kind of early ICE use, and that's all 2D. So.
Can I just one short question? Now that you have moved to PFA mainly, I think, isn't that a reason again to go back to GA, to general anesthesia, or not?
Well, there are some challenges with PFA, but many regions have successfully implemented sedation workflows also with PFA, so it's certainly manageable. It's certainly doable also with PFA. You're talking, of course, about muscle contraction, diaphragm contraction. It's doable. It's manageable, and I don't think it will be prohibitive for the use of sedation.
100% use of general anesthesia, essentially, in the United States. So just different. Assess necessary. All right. Well, we should probably move on.
Yep.
So our next talk will be EP-specific considerations in device evolution by Claudio Tondo.
Good morning. Thank you, Jim. Thank you, Tom. I think that we're going to discuss how just to manage a patient, in which we need to ablate atrial fibrillation and even concomitant the atrial appendage closure. In the last few decades already, we have quite a robust data showing the feasibility and safety when you want to combine the catheter ablation of atrial fibrillation, preventing stroke and reducing the risk of bleeding. In the majority of cases at the very beginning were just, a one single center experience, but, different operators have, confirmed the trend that you can reduce significantly both the bleeding risk and the stroke risk, and by using in the past, and then we can to discuss the role of PFA, radio frequency, or cryoablation plus appendage closure. So let's move, into the PFA world, which is really a revolution in the EP field. So what is the hypothesis to combine PFA with the left appendage closure? We have a different, PFA devices, and I think this is not the issue because you can easily and properly isolate the pulmonary veins, or maybe just, walk outside the pulmonary veins if you deem that it's beneficial to patients, especially in persistent AV patients. Usually, PFA can reduce the procedure time compared to RF or even with cryo. PFA has the potential to reduce complications related to energy source, especially compared to RF, and this is probably one of the major advantages of using a PFA. This is, could be really useful for frail and older patients. We have discussed yesterday, especially the category of patients included, for example, in a closure AF. And therefore, if we have the chance to use a much more safer modality of performing catheter ablation that will taken. And obviously, this patient population usually are the good candidate for the concomitant. There are also some, technical reason behind this. Apparently, PFA, if you go for a PV isolation, is not completely dependent on vein occlusion, like cryo, for example. And the single transeptal puncture probably can be more, easy just to do for suitable appendage cases. As we discussed before, you also can do the dual transeptal puncture if you use ice and guide the catheter ablation and the subsequent appendage closure. Another debatable issues concerning the potential edema that can arise after ablation, especially the left superior pulmonary vein at the common reach, which was one of the issues concerning the concomitant. That means in a single procedure, catheter ablation plus appendage closure. Apparently, PFA reduces the entity of edema. It's not zero, because it's still there. But at least probably this, cannot lead to a change in the sizes of appendage. But one of the suggestions, anyhow, regardless the energy source that you use, it's, to reassess the measurement after PV eyes isolation. Apparently, PFA might reduce the PV device leak, and this probably suggests that you also can electrically isolate the appendage, reducing obviously contractility, and one of the potential secondary trigger for atrial fibrillation. If you compare the main energy sources, this is one of the first investigational studies by comparing the PFA with cryo as a historical data and RF. At the end of the day, the success rate are almost the same, but the procedure, time is overall just less. We have the initial experiences concerning the concomitant use of PFA. The majority of these experiences are related to the use of the pentaspline PFA catheter. You can also appreciate at the right end of the slide that you might have a slight increase in procedural time, obviously, as compared to the appendage closure only, and a slight increase in fluoroscopy time, at least, if you use eyes for the majority of time. So the potential advantages of using PFA are there, and probably the future will tell us that this approach is, safer than the previous experience. Already we have heard about option trial, as in the US, this, was a boost to increase the concomitant. That's not the reality in Europe still. And obviously, this is something that probably is related to the reimbursement, again, in the majority of European countries as compared to the US, unless you have a local agreement to have a sort of increase of the reimbursement just because you use PFA and not other energy sources. So the option trial, already mentioned that was non-inferior to oral anticoagulation with respect to the composite of death from any cause stroke. So this is something that probably needs just to be mentioned, especially in Europe. This has been accepted last year in our rhythm. There's a combination of left atrial appendage electrical isolated plus the closure, and the PFA might create again less edema in the left superior pulmonary vein region, reducing the risk of peri-device leak. So after propensity matching with historical data coming from RF, that actually it takes us, almost 10 years ago, we published the BELIEF trial in which, we demonstrated the superiority in terms of clinical outcome if you electrically isolate the appendage and then you close, as to compare just the simple occlusion of the appendage. The procedural time, again, is less with the PFA, and although, at least in this experience, the overall PDL data incidence was lower with PFA, the clinically significant leaks were rare and comparable, especially in the range of 3-4 millimeter. So this suggests that you can safely use PFA, and please note that this was an experience in long-lasting persistent atrial fibrillation. So we, beyond the PVI, we extend ablation of the posterior wall. And, I think that you can perform this safely with the PFA. Just the last slide, I think, we mentioned the 3D probe eyes for the procedure. And this is just one of the examples. We have the privilege to use the 4D. And let's see, the future obviously can help us to simplify and, giving us the better view, not only the left atrial, but the appendage ratio. So in conclusion, PFA has the potential to overcome traditional challenges associated with other AF ablation techniques, such as procedural efficiency, energy-related complication, and maybe the post-procedural leaks. Long-standing, persistent AF patients who are, the most difficult category of patient to be treated and ablated, but probably if you extend your ablation procedure with the PFA, you can also safely occlude the left atrial appendage, hopefully with a lower rate of PDL at the follow-up. Thank you very much.
Thank you very much, Claudio. While we wait for Domenico, please.
Thank you for the presentation. So 2 comments. First of all, the edema on the ridge. So this is not our experience with less edema. I think we see quite a significant amount of edema after PFA, and also other studies. I think Tom also reported a certain degree of edema, although the message in the paper of Tom is that the edema that you see doesn't match with the landing zone. So, so you see edema on the ridge, but then it doesn't impair the deployment of the device, especially for certain devices like Watchman. Then the second consideration is about durability of isolation of the appendage, because we have this paper showing that 5% of isolated appendages remain durable during follow-up with PFA. And so I feel that it's for sure easier to isolate the appendage with PFA, but then I don't know how the impact is going to be in the long term. And then once you put a device in the appendage, it's not going to be that easy to re-isolate the appendage unless you approach it from anterior, Bachman, and so with an extensive ablation of the anterior wall. So just your comments on that.
Yeah, thank you, Domenico. I think that concerning the electrical isolation of appendage, we need to take into account also the different catheter design, because I'm not sure that we have the same effect if you use the pentaspline as opposed to the balloon in basket catheter, for example. And we just started to use it. Actually, next week for HRS, I do a live case by using the Volt with the new AMOLED 360. So let's see, just if this can obviously offer a much higher success rate. I completely agree that we still have a resumption of the electrical activity after an apparently acute effect on electrical isolation. But again, it depends on the device. If you use a dual, for example, the dual energy sources device is not the same if you use the pentaspline. The pentaspline probably is not the best catheter design to promote isolation of the appendage.
Can I just add too? I think how you do the pulmonary vein isolation matters probably. So in the U.S., there's a lot of discussion around not doing the sort of deeper lesions, the olive lesions with the pentaspline catheter to avoid edema in the landing zone. So trying to kind of modify a little bit how you do things for concomitant procedures. And I couldn't agree more. There's big differences between catheters in terms of the ability to deal with some of these anterior structures like the left atrial appendage and the mitral line as well, where we've seen very variable results depending on catheter.
Martin?
I'd like to touch a different aspect of what you've shown, and that is where do we see the future if we combine LAAC with rhythm control by PFA. And I would like to advocate the idea that it's not just the EPs learning how to do LAAC, because I think the more complex procedure that we have here is actually closing the LAAC successfully, not necessarily doing the PFA with the 4 veins. And we all accept automatically that the biggest clinical problem for these patients that we're talking about is actually keeping them in sinus rhythm. That's not my clinical experience. There's sort of an optimism now, like once we say rhythm control is the way forward for this 80-year-old patient, he goes for a second or third ablation. We talk about isolating the LAA, whereas if you ask the patient if he is in frequency control, probably his most worrisome idea is how can I prevent stroke, and possibly without NOAC. So I think these fields have to merge, and it's just going to be workload. If you see the perspective of how AFib will rise with the aging population, everybody is involved here. And we've done that at my center because we work closely together. And I think we need to be much more involved with the whole pathway of these patients. And we need to optimize LAAC, particularly in this field, with the CT planning, with the edema issue that we have, with the work process to build CAS labs that can do structural EP, and also for us as interventionalists, learn from the EP to do the PFA of the 4 veins and then have an optimal LAAC. I don't know if anybody in this room also has started that way, but we always talk about this separately, huh? And LAAC is a more complex thing here.
Yeah, no, I completely agree. I think one of the problems we are talking about persistent, long-lasting, persistent AF patient. Probably we need to intercept them, much earlier, just preventing patient just to, increase the likelihood to become persistent. This is just one of the issue. And I agree. I mean, just those kind of patients quite frequently come back to the office just because of recurrences, and then EP having obviously a different approach, a different view. We try just to repeat ablation just with the aim to keep the patient in a sinus rhythm, and sometimes quite a frustration. I mean, just because you try just to get rid of atrial fibrillation just by doing mitral isthmus, reflying, posterior wall, and then appendage electrically isolated. I understand that probably not more than 3-4% of cases there are secondary triggers from the appendage. So probably it's not really one of the main anatomic locations that we need to look at. But still there, I mean, just one of the problem that we need just to face.
Okay, so I do believe we need to move on. A thought-provoking idea from Martin, but we're running a bit late already. So well, I was in a debate, Martin, in 2024, and I said before the end of the year, PFA will allow non-EPs to do PVI, and I think you proved my point. I defended that position. But we do need to move on. And for the last speaker in our session, I would like to invite Laurent Roten, who will discuss integration of LAAC with ablation strategies. Laurent.
Okay, dear colleagues, dear Elaacc committee, thanks for inviting me to this session. So I have to talk about strategies in AF ablation and how to implement this with LAO occlusion. So I'm an EP, so at the center of my procedures probably is ablation, and so if thinking on how to position LAO occlusion with regard to ablation, we can do it before ablation, we can do it after ablation in concomitant procedures, but we can do the same with sequential approaches. And then also keep in mind it's not only the first ablations where we may do LAO occlusion together with, but quite often it's also during redo procedures and things may also be a little bit different in those kind of procedures. So first thought is what should we do first, LAA occlusion or ablation? And I think probably the best role model of doing closure first is this kind of patients that have a thrombus that keeps being there and doesn't resolve despite anticoagulation, and you want to go for ablation, and of course you should not do it as long as the thrombus is there. And so that's where you could do the thrombus trapping procedure. And I just want to cite here the French Trappeur Registry, 53 patients who had a LAA thrombus, and with a kind of a no-touch workflow, this appendage was closed with different devices. And they had quite decent results with very few adverse events. There was just one stroke among these 53 patients. So that's, I think, one thing where you can do LAA occlusion first. But then if you have already occluded the appendage and you go for an ablation, that's what may happen. And this is from a small also registry from Switzerland, 17 patients who already had a LAA occluder in place when they went for the ablation. So the majority, 70%, was a disc and lobe LAA occluder. And during pulsed field ablation to isolate the vein, in about 1/3 of patients, there was this kind of interference on the catheter, which also led to abortion of PFA delivery. And that's something you can manage. You can reposition your catheter, or sometimes you need to take another catheter. But in what actually happens during such interference, that's what you can see here. That's an in vivo study, and you see you have arsing and formation of bubbles, and that's something that happens with different PFA catheters, but also with different types of occlusion. It's a class effect. And what's the sequence of this clinically, we don't know. It's probably something that you should avoid, to have this kind of arsing in the left atrium with bubble formation. Now, going more into details about occlusion first versus ablation first, there's actually one trial who randomized this in 100 patients each. And the primary endpoint was stroke, TI, DRT, significant bleeding, or death and rehospitalization. And you can see here that clearly occlusion first was the better way to go in that trial compared to ablation first. If you go into the supplement and look why this is the case, you can see that those who had ablation first had a higher rate of DRT and strokes numerically, which triggered the difference in the primary endpoint. And actually what happens here is the ablation first group, the peridevised leaks were much more frequent numerically, acutely, but also during long-term follow-up. And we already talked about this. There was a rich edema in the majority of patients, which you can also see in that picture here. But keep in mind, this is an earlier study, and all these patients had radiofrequency ablation used. And we now have moved, the field of EP have moved to pulsed field ablation. And with pulsed field ablation, there is still some kind of edema formation. We heard about that, but it seems to be a little bit less extensive. And in particular, it doesn't maybe affect so much the landing zone where we go for the ablation, for the implantation of the occluder. And very recently, there was that from Deviner's group. They have looked into this after concomitant procedures with PFA ablation, so ablation first and LAA occlusion second in over 200 patients. And they used a very elaborate workflow with CT imaging, AI planning, and again, ICE imaging just before deployment of the LAA occluder. As you can see here, they didn't have any significant leak during, in all those over 200 patients, so seems feasible. And then that's another thing that makes me uncomfortable. So if I have a case where I do LAA occlusion first and then manipulate in the left atrium or have to do cardioversion, I always have the thought that that may risk a device embolization. It didn't happen yet, and I didn't find anything in the literature, but that's something that you may also keep in mind when you do it this way. The next coming to concomitant or sequential sequence of the procedure. I think the best data we have so far is clearly the option trial. Just keep in mind 40% were concomitant and 60% were sequential in that trial. And in both of those approaches, the success rate of LA occlusion was extremely high, no difference here. If you then look into the adverse event rate of those that were kind of stratified into the concomitant arms, so in both arms, in the combined ablation and LAO and ablation only, there was a concomitant stratification arm. If you compare the adverse event of those two here, you can see that these were very low. It was even more pulmonary pericardial effusions in the ablation only arm. So it seems to be very safe. Of course, if you do it sequentially, you have a second ablation procedure or a second occlusion procedure where you will have all the risk of adverse events because you need a secondary access and secondary transeptal puncture. With regard to efficacy and safety in the option trial, that's a sub-study. Either way, with concomitant or sequential, you have the same effect, so there is no difference regarding these endpoints. Now, we talked about this yesterday already, which patients are the best where you will choose maybe a sequential approach. I think if we do ablations in AF patients, our goal is to get rid of AF, and we're quite successful, especially in paroxysmal AF, and we talked about alone AF and ocean AF. That's the most recent meta-analysis, and you can see here that obviously you can probably stop anticoagulation in apparently successful cases, and overall the ischemic stroke rate here in events per 100 patients is very low at 0.23. And just a remark here, in those patients with higher CHA2DS2-VASc scores in those trials, it was very similar. So these are probably the patients where you can do a sequential approach in those in which ablation is going to fail. A concomitant procedure maybe is something that you may envisage in patients that have a high risk of bleeding or for lifestyle or other reasons want to avoid anticoagulation as soon as possible. And that's, I think, where Option and Champion AF inform us very good on what to tell the patients and what they can expect. Now, the last thing I want to cover, we already talked about this, is isolation of the left atrial appendage as part of an ablation strategy. And there are different ways how you can do that. You can just selectively isolate the left atrial appendage. You can do an anterior and a posterior line to isolate a larger region. Or that's what I prefer to do in desperate AF ablation cases, is to isolate the complete left atrium. And here's such an example of an isolation of the left atrium. So if you look at the uppermost tracings, that's the ECG. It's in AFib on the left upper side. Then in the middle, that's the artifact of pulsed field ablation, which isolates the left atrium. And on the top right, you see that the patient is now in sinus rhythm. But if you look more closely, you see that it's still AF behind the sinus rhythm. So the right atrium is in sinus rhythm, and the left atrium is now still in atrial fibrillation, which you also can see on the tracings down there in the coronary sinus. So electrical isolation of the left atrial appendage, something that we do sometimes intentionally as part of an ablation strategy. It can also happen unintentionally. If you mistake the appendage for a pulmonary vein, should not happen, of course, but it can happen. Or for other reasons, when you apply just the last conducting fiber to the left atrial appendage. And importantly, these patients, after isolation of the left atrium, are at a high risk of thromboembolism. And I think we should always close the left atrial appendage in these patients. And if I do it intentionally as a part of an ablation strategy, I try to do it beforehand, so occlusion first and then ablation. Of course, if you do selective isolation of the left atrial appendage or unintentionally, you probably have to do it sequentially. So that's my summary slide. So these are my thoughts on how to implement ablation strategies into the sequence, how to do LA occlusion together with ablation. And I'm happy to take questions. Thank you.
So how frequently are you using concomitant procedures now in your practice? Is that occurring frequently? So just for context, in the US now, the Boston's saying that about 40% of the left atrial appendage closure cases are concomitant, and we have reimbursement for the combined procedure. although physicians get paid only half for the left atrial appendage closure, the hospital gets paid full boat for both. So the reimbursement's there in the U.S.
Yeah, thanks. That's a very good question. Obviously, it's not the same situation in Europe. So we have reimbursement in Switzerland, but I think Alone AF and Ocean have kind of tricked it the other way again. So we're doing maybe 2 to 3 cases a month at the moment. So it's not something that we do on a larger scale like in the US.
I'll be curious to see if it pulls back a little bit in the U.S., particularly for some of the lower risk patients and whatnot in the wake of Ocean and Alone.
You showed nicely, Laurent, these scary visual images of interference of a pulsed field with metal structures, not only LAA occluders, but anything metal, ICD leads, occluders, whatever. Do you think there is an argument, if you do LAA first, even if it was done historically, do you think there's an argument to move away from PFA again in those patients, switch back to RF, maybe even regional RF, if you have dual energy catheters, to consider in the anterior region to avoid using PFA and then maybe only do PFA on the posterior wall? What is your practice in these patients?
Yeah, it's a good point. I think we don't know really what the clinical effect of this is. And actually, it also happens with radiofrequency ablation. They can also have interferences, and we don't really know what happens in those cases. So I think it's the same situation. So I try to really avoid ablation very near to an occluder, or also sometimes if you have a septal occluder and you ablate the right pulmonary veins, the same happens. Or if you have a patient who has a mechanical mitral valve and you ablate an anterior line, it's the same issue. So whenever that's happening, I try to avoid ablation when I see artifacts on the EGM before ablation. And for example, if I have a catheter that enables me to toggle between radiofrequency and pulsed field ablation, I'll probably use radiofrequency instead of pulsed field ablation if it's possible at that anatomical location. So it's definitely something I want to avoid, yes.
Adel?
The option trial, which is the only randomized comparison between concomitant therapy and the medical treatment, it was done with cryoablation mainly, I think, and a little bit of, but no pulse field. So we have no randomized comparison between concomitant with pulse field versus, I would say, the standard of care. So do we need more, a new randomized trial? Do we need, how can we certify the safety of combined ablation with the pulse field, since we don't have a randomized trial with this technique?
Yeah, it's true that we don't have any randomized trial using pulsed field ablation, but I think in option it was radiofrequency and cryo, and it was always ablation first and LA occlusion afterwards. So I think you just need to isolate the pulmonary veins, and that has been proven that we can do that with pulsed field ablation better than with thermal energy, so at least as good as with thermal energies. And then I think the only issue is regarding the formation of edema, and it seems that it's probably more favorable after pulsed field ablation than after using thermal energies. So I think, for me, I think it's okay to use pulsed field ablation in those procedures.
I do think more trial evidence would be of real value, though. I completely agree. And I mean, we've published on this question also sequential versus concomitant. Is there an advantage to doing it all in one? Are there risks? And we've shown that the risks are slightly higher with a combined procedure compared to either alone. But when you combine the risks of the sequential procedure, we basically have vascular access complications, and we have a lot of the anesthesia-related things. So not surprising at all, right? So, but we need to, I think, establish that more definitively with trial data.
Sorry, with regards of these concomitant versus sequential strategies, we have a talk this afternoon, which is a research proposal focusing on this topic, which is concomitant versus sequential, and see your thoughts.
Okay, so I think it's time to wrap up our session. Once again, thanks to all our speakers, and we move on to the next session. Thank you.
Thank you.
Yeah, so welcome to the next session here, which will be on new LAA devices. And we have a new iteration of the AMOLED device, the AMOLED 360, and there's a study already published, the Veritas study, and Xavi, you were part of the study, and probably the European implanter that has most experience with the new AMOLED 360. So please tell us about your experiences.
Thanks, Erik. So you're right. I mean, like the initial results have been published. But anyway, like this session, it's a case-based session. So I will focus more on practical stuff and more device features, which I think that it's interesting. You know, you can just check the results of the Veritas study at 45 days. They're really good with, you know, extremely, you know, good safety and efficacy outcomes. So basically, what's new and what's the same in, you know, AMOLED 360 compared with the standard AMOLED? So it's the same. So we have the same, you know, mechanism. It's a dual sealing mechanism with lobe and disc. The lobe, you know, needs to be sized and needs to be put in the landing zone, so that disc will cover, you know, the ostium. And the objective of the device is just to achieve complete sealing. We have this flexible waist that it's the same between lobe and disc, and we have the same sizes, 8 sizes, from 16 just to 34. And then we have the ability to do, you know, like some different techniques, implanting techniques like the sandwich. We will see a case with AMOLED 360 of this. And we can use the steerable or the fixed curve sheath. What's new? So basically, like things that probably we were all requesting in AMOLED. So now we have an inverted distal end screw and a marker band. And we will see that that allows, you know, just to steer freely. And of course, it's atraumatic. Then we have the distal shape of the lobe. It's more rounded. So this will allow, you know, just more forgiveness when implanting. It's more, I would say, reliable, and you can anticipate the position. It's very stable. Then we have, instead of 1, 2 rows of stabilizing anchors. Like those anchors are a little bit, you know, just more distal. So when we form the ball, we have just to keep in mind, instead of 12 and 14 French, now we have, you know, always to use the 14 French sheath. And of course, there's going to be like a steerable or fixed. And that, you know, sheath can be reused for different devices. If you need to change for any reason, or you're doing 2 recaptures, you know, according to the IFU, you had to change. Now you don't have to change, so you can just use the same sheath for different devices. And the sizing chart is going to be different, and that's probably, you know, another, you know, relevant information. So again, and going, you know, just point by point, which I think that it's interesting. So that probably it's one of the major changes. So now, you know, we don't have like distal screw, protruding distal screw. That, you know, can be seen like a safety issue, which is a safety issue. But for me, other than that, which is very important, that allows, you know, to rotate, especially to counterclock, you know, in a more coaxial position. I don't know if, you know, for the ones that use AMOLED, sometimes if you're a little bit distal, or if you're not so distal, make that counterclock. It's not so easy because that distal pad gets trapped into the trabecula. And then you want just to rotate anterior, and you cannot rotate. So with this, with AMOLED 360, that's going to be like really easy. Second thing, it's this, you know, doming, this rounded distal lobe, or distal part of the lobe, which, you know, will adapt more to the anatomy of the appendage. Then we have safer, you know, redesigned anchors, are shorter and, you know, just more rounded. So in theory, less risk of having pericardial effusion. and we have a double row just to, I would say, ensure stability. So now it's a more stable device. And you can tell also, because, when you deploy the lobe, it stays, in place much better than the standard amulet. So I will show, and I put case 2 because that means that it's our actual case 2 with amulet 2. Just to, I would say, to show that there is, for an amulet user, there is no learning curve. I mean, there are some considerations in terms of sizing, in terms of choosing the device, but to me, there is no learning curve. It's actually, easier to use amulet 360 compared to standard amulet. So this is a standard appendage, let's say Elaacc. I don't know, what do you think about the Elaacc? It's Elaacc 1, I think. With Laura, we always make that exercise. Apart from sizing, we always measure the Elaacc in the table, and then we put it in the report, because I think it's a good exercise to integrate, the Elaacc score in our minds. But this would be more or less Elaacc 0, maximum 1, but I think it's 0. And then here you have a landing zone of 17-18 and ostium of 22-27. Now measuring the ostium will be much more important with amulet 360, because we were going to be able to select probably 2 or 3 sizes. So sometimes if we have like a large ostium, we will go, for the largest, because the lobe will adapt just to different sizes. So here is the transeptal. After the transeptal, in our institution, we always measure the LA pressure. In that case, the LA pressure was good. So then we don't remeasure, and the landing zone is good. It's in a normal, fluid condition. And here you can see the way that we work. We always work with MPR for, the approach of the appendage, and also for the implantation of the appendage. Always, in the bottom, you see that you have the 2 planes where you can just advance and rotate to get the perfect coaxiality. So this is the delivery sheath, and then the pigtail. We don't usually do injections, but this was part of the protocol, so we did it. And you can see, you can confirm that this is a standard appendage. Landing zone, it's a mean. Now, we size based on the mean diameter. So the mean diameter is 17.5. So here we have 2 options. I'm pretty sure that for the amulet users, if you have a mean diameter of 18, you would go for a 22. Because it's 4 millimeters, of oversizing. So now with amulet 360, we can go, beyond that, and probably we need to oversize a little bit more. Amulet 2 here, it's amulet 360. 25 would be probably not the right option, but like a good option, especially because we're going to have a disc that we're 100% sure that will cover. The disc will cover, because it's 32 the disc, and you can see here that we have a maximum diameter of 27. So 32, a disc of 32, I think that would be like really, really good in this case. And here you can see like the way that we open, we unsheath. Now the ball, it's not, like just an actual ball. It has to be a little bit less than a ball, because, like the first row of anchors will show up, and then very, soon. So in this case, maybe this is just too much ball, and we will, maybe just generate less ball, like a pre-ball, and then we'll start to rotate counterclock. You can see how easily it rotates, because there's no distal end screw, and there is no contact of the hooks with the wall, and that's one, for me, of the main advantages of amulet 2, just the capacity of rotation. And then the deployment, it's extremely controlled and has to be extremely slow. As you can see here, it's not moving at all. Now the rows of anchors are engaged, and now you see it's not moving at all. And this is something that doesn't happen with amulet 1 or amulet, standard amulet. It will generally pop out. So here you can see that it stays stable. So always with MPR checking, the formation of the disc. And here, the stability test. Here, the signs of stability are the same: close, circumflex, lobe orientation, separation, and ellipticity. But there are like 2 other signs. That is the distal doming of the lobe, and then the disalignment of the distal marker and the waist. when you see that they're not aligned like this is, like an indirect sign of stability, because that means that, there is some tension inside. So here you can see the result is very good. We inject, no leak at all. This is one of, the good things about the device. The sealing performance, showing Veritas study, it's really, really good. And then we discharge the patient without any problems. And going, just to the second case that I'm showing, it's a third case, the actual third case. So the third case was a chicken wing. Chicken wing probably that required a sandwich technique. So we test the device, in a more challenging situation. Here, the standard, as you know, in the sandwich, the standard measurements of the landing zone maybe are not appropriate, but in this case, the landing zone would be more or less the ridge area. So we need to go more into the chicken wing. So the ridge area was around 15, and inside the chicken wing, so we had diameters of 17, and like just the space, of the chicken wing was quite large. So again, we check, for LAA pressure, which was good. So the landing zone, again, it's, I would say, like 15. So we went, for oversizing of 4, 5, 6 millimeters. And in this case, so this is the chicken wing, and this is the injection, as you can see here. And we, make this counterclock rotation. And in this case, we went for amulet and 22. Okay, and you can see that we are doing the rotation. Again, I want just to highlight the easiness of rotation of this device, so you can just counterclock like really easily. And again, you will see how, nicely opens and how stable opens. Like no much change here. Slowly, always, you need to go slowly, and you can see that will open, and it will stay inside the appendage. Look at the echo, the bottom right, how, the lobe stays inside the chicken wing and, beyond the ridge. So here we open the disc. The best sign of stability is the distance between, the lobe and this. You see that distance is telling you that the lobe, it's inside the chicken wing, and the disc stays outside. So, this is probably the most powerful sign of stability that you can tell. And again, in the injection, there was no contrast at all and no complications. Just to me, Amulet 360, it's, a better device compared to Amulet, a much better, I would say, device. It's atraumatic, it's more conformable, and requires probably larger oversizing, so that it's more forgiving, and we can just select different sizes. The lobe keeps the intended position. There is no pop-out effect of the Amulet. 2-3 sizes fit. Seems to be very stable, double anchoring. And the concern with Veritas was the roll for DAP for 6 months, but in the first 45 days, it behaved very well. So thank you very much.
Thank you very much, Savi. Questions for Savi for the new? Yeah, Joe?
Yeah, excellent, Xavi. I have a question regarding sizing. So do you modify your sizing chart for the Amulet 2? You recommend to size based on the mean diameter. So is it different than with Amulet 1, especially in eccentric appendages?
It's a different sizing chart. So the official sizing chart is different. So, and actually they offer like almost 3 sizes for each measurement, no? And then you put in the diagram, in your selection, diagram, also the size of the ostium. And then, based on both, you end up selecting. But you use the mean diameter, not the maximum diameter, and that's a difference compared to Amulet. Yeah.
Xavi, another question about the anchors. There are 2 rows of anchors, and how many anchors are in each row? 8 in each row? How many?
I think that it's the same number. I don't know. Maybe the engineers of Amulet. How many? It's the same, no? The number of anchors. It's double, same number. Yeah.
Yeah. And what about there is a funny shape of the anchor that there is a loop? in that anchor, and then there is, because on one of your pictures it was that there is a loop and then the distal part of the anchor. Why it's like that?
Well, I don't know if, like that picture, it's actually telling you, the reality. The thing, the global concept, it's like really very similar to Watchman flex. So it's like the typical anchor that it's rounded, parallel to the lobe. And, in theory, more automatic. Instead of amulet, that the angle was towards, like I would say, like just external structures. Now it's more parallel to the lobe. And, in theory, that would be safer. I don't know exactly
Marek,
the angulation.
I think what Marek means, it's you have these hooks, yes, but it's not laser cut as a Watchman flex, for example. So this is sutured into the, correct me if I'm wrong, but it's sutured into the lobe, the nitinol structure of the lobe. To be honest, I still dislike that a little bit more than laser cut hooks, which is really even more atraumatic. I think they did their best to make it as little traumatic as possible. But indeed, it's still a woven in structure, a sutured in structure in the nitinol. It's not a laser cut structure.
Can I just add to this? I think one of the issues with the amulet so far was that it was not possible, or at least I was reluctant, as many others, to give NOAC afterwards, because you had this increased sign of pericardial effusion, particularly in that combination in the amulet IDE. Now, do we trust this new design to also give these patients NOACs? For example, if we are in fear of DRT?
Yeah, definitely. I think that well, honestly, I was not, like just withholding the NOACs with amulet in any situation. So we have the Adala, and it was almost, like most of the patients amulet, and we have those. It didn't show, like an increase, but definitely I think that the redesign of the anchors will impact in a lower rate of pericardial effusion. So yes. Yeah.
I don't have that data yet.
I mean, this is maybe common sense, because my biggest concern was always we had the hooks at the amulet at the level with the highest radial force. So I think the concept of making it a little bit more bowl-shaped in the distal part and having the anchors a little bit more towards the inner side, I think this is a really good concept, because, I mean, it's a big concern. Yeah, we shouldn't have perforations. And I think it's not always because of the device design, but if the implanter is not taking care of that, it's getting even worse.
Okay,
I have a question for you, Xavi, because I feel that with a disc-based device, it's extremely important that the disc ends up in a very good position and really do the job of sealing. And now that we have a lobe for the 360 that is more soft, it's more conformable, rounded, we don't have the distal screw, why not go completely from the ostial measurements and imagine where should my disc be, and then start the sizing from there, in order to really be confident that your disc ends up and really seal in a good way?
Well, I like your approach. It's a very extreme approach. I would be happy if, like in the sizing chart, they, integrate the ostium, just to make that decision. And that would be, the first step. But I think that might be an idea, no? Like just to go from outside to inside, yeah.
But at least to bring it into the consideration about device sizing, because we always talk about the landing zone, and as you already said, there can often be 3 different sizes to choose for a given landing zone with this device.
The only thing that, well, like just that measuring the landing zone, it's just not only for the size itself, but it's also for the orientation. It changes a lot, if you put it more clockwise or counterclock. So you will always have just to consider, the landing zone as probably, one of the most important things. But I fully agree that we should integrate both, because it gives power, to the message of dual sealing.
Yes. Okay, thank you. I think we have to move on. Thank you, Xavi. And I'm going to introduce Jens Erik. He's going to talk about the Watchman Flex Pro device.
I think the Watchman Flex Pro is probably familiar to many of you already. It has been launched in many countries now, and I guess you have, most of you, experience now with the device. The problem that we have with LAAC, or one of the challenges, is still DRT, and it's not very easy to treat DRT, and it's also difficult to prevent DRT, and you know all the regimens that are out there, and the dilemma is, of course, if we do a heavy post-procedural antithrombotic treatment, we will just increase bleeding rates in the patients that we have already that are at high risk of bleeding. So the idea with the Watchman Flex Pro was to try to build in some of the anti-thrombotic properties or resistance in thrombo resistance into the device itself, and for that there was produced or investigated a new fluoropolymer coat in order to try to increase the resistance here, and that's the main idea with the device. But at the same time, we also saw an expanded range of devices, so we now have the 40 millimeter device, so we can cover up to at least 36 millimeter landing zones with this device. And they also added some fluoroscopic markers, so it's easier for us to see the shoulders and where the maximal diameter of the device is. The whole concept around reducing the thrombogenicity is related to the properties of the membrane that makes albumin bind to this coating very rapidly, and by having a cover of albumin of the membrane that will reduce platelet binding to the surface of this coating. And from animal studies, it has been shown that this also reduces inflammation, thrombus formation, and also it enhances ingrowth of endothelial cells. So when we put in a device, there will be activation of both platelets and of the coagulation system, and in some way we will get a microthrombus layer, which is the normal course. And I mean, if we then have risk factors present for DRT, and we know a lot about risk factors now, then we risk the development of having device-related thrombosis. It's also important to be able to discriminate between this initial ingrowth or this initial microthrombus layer or thrombus layer and discriminate to real thrombus, and based on studying post-implant surfaces of the Flex and the Amulet device, we have come up with this classification where we can accept up to a layering of 3 millimeters. That is something without treatment will regress and be flat again. We believe this is completely beneficial healing, opposed to when we have large masses on the device and pedunculated masses. So we talk about those gradings of head and of real DRT, that is grade 2 to 3 head, and I think you're all familiar with this classification now. So is this new coating actually working on the Watchman Flex device? And we do have some data out there, but not the full data yet. But this is also NCDR data on Watchman Flex compared to Watchman Flex Pro, and it's 45 days DRT rate, and you can see that there's actually very little difference, actually a little bit more DRT with the Flex Pro device, but on the other hand, you can see that also the antithrombotic treatments were different between the two devices here, with more anticoagulation for the Flex compared to the Flex Pro device. But there is a systematic study there evaluating head DRT, which is the HEAL LAA study, which is a 500 patient post-market
study of the Watchman Flex Pro, and the data will be presented at HRS in few weeks, so we'll have the full data set, and we'll be able to see if the Watchman Flex Pro really also works in real life with a reduced DRT rate. We did some small studies also both on the Flex and Flex Pro by evaluating what was going on the surface very early at day 14, again at day 45, 3 months and 12 months. And we kept those patients on a very minimalistic regime with only single antiplatelet therapy with aspirin 75 milligrams per day. And in this way, we could in some way study the natural history, what's going on when we put in a device. And for the Watchman Flex Pro, this is the very typical healing response that we saw. At day 14, yes, we had some kind of layering on the atrial surface, probably a microthrombus layer, and with time we saw resolution of this layering, and from animal studies we know what's going on is initially fibrin thrombus, and then it's gradually exchanged with ingrowth of cells, and in the end a single layer of endothelial cells. We did also use the 40 millimeter device among this patient series, and this is a case that is interesting both because we used the 40 millimeter device, but also this was a patient having a very high risk of DRT. He was 81 years old, having a hematological disorder with thrombocytopenia, and he actually before LAAC demonstrated that he could form LAA thrombus in the LAA that we had to treat with low molecular heparin, and he was part of our study. Due to low platelets, he got infusion prior to the procedure, and you can appreciate here on CT the very large dimension and also a lot of slow flow in this appendage, and this is early and late acquisition CTs, and even on the late scan you can see there's still some shadowing in the appendage, and we did an extra here transesophageal echo to be sure that it was not thrombus, and it was not thrombus, it was just extremely sluggish flow. And the dimensions here, maximal diameter 35 millimeter, and this is just quickly showing you this very large appendage here, and the 40 millimeter device chosen to cover this landing zone of 35 millimeters, and the implant control angio before, and you can see here also the use of the radiopaque markers. Of course, on the CT you plan where to put your C-arm, and you can do the final adjustment so you are completely sure that you are perpendicular, I'll go one back, that you are perpendicular to the device. And here you see a small shoulder inferior posteriorly, and it's helpful to have this C-arm readjustment so you can precisely measure how much your shoulder is protruding out to the left atrium, and here it's within an acceptable range. And just all our cases are done by eyes, and this is the appearance of eyes with this patient. And also interesting here, you can see at the early scan, 14 days, there is a quite extensive layering, which is not smooth on its surface. So this is grade 2 head, so this is something that resembles real DRT. But due to this patient's bleeding ability and the very early scan, we chose not to treat and just kept him on kept him on low-dose aspirin, and you can see on the serial images here, it just resolved over time, just having aspirin on board. I cannot publish or give you all the results from this Flex Pro CT study because it's going to be presented at EuroPCR. There are data out there, a small series with a 40 millimeter device, 9 patients from an American center, and actually 3 of the cases were failed cases with the 35 millimeter Watchman device, and with the Flex Pro 40 millimeter device, they obtained successful closure with this in 9 cases, including the 3 failed cases, and only very small leaks here in this series with the large device. So it is a new option for us to also be able to close those very large appendages. And again, this coding also made Boston do this trial on post-procedural antithrombotic treatment with the Watchman Flex Pro device, the simplified trial, where we in one of the arms have aspirin only. This is SAPS, and then we have half-dose DOACs, and then we have the third arm with DAPT. So it has really changed the regimen for a Watchman device, coming from all anticoagulation plus an antiplatelet, and now we are down and comparing with the Watchman Flex Pro here, aspirin with half-dose DOACs, and all patients have been enrolled in this trial, and I'm not completely sure, but I hope we see the results already at TCT, maybe at a little bit later stage, but that will be very exciting for us and have guidance on post-procedural imaging. So. And this is the result with the 40 millimeter device here on the CT. So thanks for your attention.
So thank you, Jens-Erik. Any questions from the audience first? If not, then I want to ask you how to use these markers indeed, because I think most people in the room, if they have the Pro, I bet they hardly use those markers. So you show there a little bit how to use it, but I think that's maybe the key also. Then you almost need your CT info. You can calculate your best fluoroscopic angle, or can you guide us a bit how you use that, how it could be useful?
Yeah.
And what do you do if these 3 markers are not in a line?
Yeah.
What is your conclusion then?
If you really do the pre-planning and you completely predict where the device will land, you will already have chosen a C-arm where you see them aligned, so that is very good. But that is, of course, not always the case, and if you don't have that situation, you can readjust your C-arm so they are in line. Instead of, without the markers, we had to look at what we call the big bubble inside the sheath, and it could be some way a little bit difficult to see exactly where's the big bubble. So instead of looking at the big bubble, less defined, now we can look when we backsheet or push forward, we can have a good measure on where is actually the shoulders and when will they land. So that's one advantage. The advantage also, when you have this shoulder protrusion, you can get a reliable measurement if it's less than 1/3 or more than 1/3. And then I think there's a new option with the steerable sheet, because the steerable sheet can be used, I think, in 2 ways. First of all, you can, before you deploy the device, you can align the sheet to the axis of the appendage, so you get very coaxial. But in some cases, you can also use this we call mid-deployment steer. So you partially deploy the device, and when it's partially deployed, you adjust. For instance, if you want to have a more steeper angle to your device, you clockwise rotate or you steer the steerable sheet in a clockwise direction to get another angle of the device. And there the markers are helpful, because they will, when you reach, you should start your steering just before you have the markers deployed. So when you start to see the markers being very near to the tip of the sheet, that's when you can start this mid-deployment steer.
Okay, that's very handy. I mean, it's really true. Look, I'm training all the time fellows. I'm hardly standing with my hands as a first operator doing my cases. So the thing is, with that steerable sheet, I learned that if a new beginner has the steerable sheet in hands, he has so much focus on that finally he can flex or unflex the thing that he loses a little bit the focus on having just a simple counterclock on his sheet itself. And that's still the primary thing to do, to be honest. And it's good what you say there, also there, so these markers are indeed useful to look, is there parallax in my device, yes or no, but also that I even didn't have so much focus on myself, so it's good to hear that. So when the markers are getting close to the tip of the sheet, that's indeed, you do it almost as a two-step. So you have your counterclock, your typical counterclock on your sheet, which you shouldn't forget to do. And then you deploy your device, and it's kind of almost midway, apparently then when the markers are almost to the tip of your sheet, then you can start of thinking, do I give a little bit of flex or unflex on my steerable sheet? Yeah, so that's a good tip, I think, and it's important. I'm going to have more focus on that myself too. Okay, thanks. There was a question, I thought, from Marek, no?
You have already said what I want to say, but even if you are not doing pre-planning of a CT, these markers are extremely helpful because I adjust my C-arm angle to these markers during the procedure. So even without pre-planning, it's extremely helpful, these markers to be like in TAVI, well, Marek, if you want to avoid parallax, yeah?
True, but on the other hand, I agree, but you do your implant and you correct your C-arm to get them in line. But of course, it could be that your device is completely out of axis, and then you correct your C-arm, and then you inject and you say, yeah, it's an axis. But whereas, I know not everybody does CT, but if you have the CT info, you really can get into that angle where you think my device should be in axis, and if it is in axis, it confirms your really perfect coaxial with the appendage, in a way. Okay, thank you, Erik. I'm going to introduce here myself, it seems. No, I'm going to start by disclosing that I have no experience with the device, but I will still present. And I'm going to keep it relatively short. I think it's going to be more interesting to hear maybe, again, I have no experience with the device, so to hear on the audience and I guess there's people from the company here also in the room, to hear some feedback, what is the idea about the concept of this device. So this is the Zenith LAO system, and what is it about? So it's a 19-hole braided scaffold, as you see on the top, which should be very compliant, apparently. And then it has independent anchors, which can be deployed in a second step of the procedure. You have a self-closing pad-covered conduit, so there should be no exposure to metal. That's for the DRT rate to keep it low. And then you can actually also conformal, like you can do a contrast flush channel, so you can have the device in place, give contrast internally in the device, and see whether there is a leak going into the left atrium, yes or no, before the release. There's currently, they're working on 3 device sizes, 22, 28, 35. There was only use of the 28 millimeter in this first-in-human small series of 10 patients, where I'm going to show you the results from. And then apparently, I have not had it in my hands, of course, but it seems like a TAVI-inspired handle and steerable sheet for precise controlled placement and deployment. So here this is an animation, so you can bring this scaffold or deliver this scaffold on the position where you want, optimize it as many times as you want. You see it's anchor-free, so you can really automatically reposition this device, and then when you're happy about the device position and when you've confirmed there's no leaks, you kind of come in the second part of the procedure with the anchors. So here you can see it again, it's controlled scaffold delivery. And then when you're really happy about the position, if you confirm there's no leak, you can deploy these independent anchors. So here you see this is in a bench. You see it on the left side, how it's deployed. So this is first this scaffold only, yes. You can reposition this. And then you will come out with these anchors as well. you will see it, I think, on the fluoro image. Or it's on the next one, yeah, here. So this is then the contrast flushing inside in the device. You see here, for example, on the left-hand side, you see you inject the contrast in the device, you confirm there's no leak, and when you're happy, then you deploy the anchors and you release. On the other hand, keep an eye on the right-hand side, so you give some contrast within the device, and you clearly see there's still some remaining gap and some leak. So then you have the possibility to reposition your device and try to get a more optimal position. So this video should also run. Yeah, here you see very clearly how these hooks come out, these anchors come out here. So when the device is in place, they come from the central tube and they deployed. Yeah, here you will see it. Yeah, here these anchors come out and then you anchor the device safely into the appendage. So they've done 10 cases. This is a prospective multi-center open-label single-arm trial done in Australia and New Zealand. You see the people involved in there. One of my former fellows, Matthew Brooks, I see, is also involved in this. And then they've done, as you see, the regimen on the right-hand side, post-procedure, DAPT or oral anticoagulation, 45-day TEE, and then a 6-month DAPT to aspirin, and a 12-month CT. So, of course, 10 cases. This is the selection of cases. You see there was prior cerebrovascular events in 9 out of the 10 patients. 6 patients were actually breakthrough strokes, and then 2 patients with intracranial hemorrhage. Of course, you see here the results were very good, 100% safety. There was no events, to be honest, in this small series of 10 patients. No DRTs as well. And then this is maybe, if I go back here, you see also the device implantation time. Of course, it's the first time they do it, a small series of 10. Device time, implantation time is 35 minutes. Fluoroscopy time, maybe a little bit long, 22 minutes, but okay, it's for a first in human series, maybe, yeah, understandable. So 11-minute fastest deployment time. The other things, yeah, the range of compression is like the other devices. I would say you aim typically 10 to 35% kind of compression, which is normal. These are all the 10 anatomies, so they were not too hyper-selective, it seems, in their, they tested in different anatomies. And then these are the longitudinal follow-up outcomes. So at 45 days, all implanted patients had closure of the LA, no DRTs were seen, and at 1 year CT imaging, no changes from these 45-day echo images. Device was stable, there was neo-endothelialization and no DRT again. There were 2 bleeding events, but these were bleeding events in patients who had a previous history of blood transfusion dependent anemia. So this has nothing to do with, I think, the post-treatment even. And then the anticoagulation status, that was all patients were successfully transitioned to single antiplatelet therapy. So this is the final slide on it. You see also the echo image, how it looks on echo. So successful first in human results, same-day discharge was feasible. 2-stage deployment, which they say enhances repositioning and flattens the learning curve. So as you saw the device, it's a braided, very conformable scaffold, and then these 2nd-stage dynamic anchors to adapt to diverse anatomies. There's no exposed nitinol. They also didn't have any DRT in this small series. And then they have that contrast flush check, whether before final deployment and before anchoring the device in, which is really nice. And they're planning, I don't know the real plans, but larger 2026 trials in the US and outside US is planned for FDA pivotal trial approval. So, thank you.
Thank you, Rune. I like actually the concept where you can put in the scaffold and you can struggle to get a good position without having the anchors exposed, because with most of the devices when we recapture, we risk trauma to the LAA wall, but with this it's very soft and there's no hook, so you can really work around and get the very nice position. And the other feature I like is that you can do intra-device angio. and you can be quite confident that you have a completely seal before you come in with your anchors. So I think those features are quite nice.
Yeah, absolutely. Yes.
But I believe that the length of these anchors are fixed in each size, and if you have more compression of one device, then the anchors will protrude a little bit more in the LAA wall, or?
I don't think so. I had that same question to the company, but it seems like they are actually pretty flexible as well. So they must have some power, of course, to get out. But I mean, if there's more or less compression, indeed, it's a correct question. If there would be 10 or 30% compression on your device, whether these hooks are, but they seem to be similar, sticking out. Yes, they adapt. They're flexible, so they will not protrude more normally when you have more compression on the device. Shouldn't be.
Because they
can bend even a bit. They are relatively flexible. I don't know if there's somebody from the company here present. They maybe are willing to comment on it. I had it in my hands once. It seems relatively flexible. It seems not to protrude more if there's more compression, no?
Yeah, no, that's absolutely correct. So probably 3 years of work was done just developing the anchor system alone. So there's probably 1,000 prototypes before we've gotten to that final one. But there's actually a stop on the anchor system. So the anchor system can only protrude to 0.8 mils into the left atrial appendage tissue, no matter how much force is put on them. Mm-hmm. So you can actually physically press it with your finger and it can't penetrate any deeper, because there's a physical barrier stop on it that interacts with the braid to prevent it from going.
Yeah, because it comes from inside the nitrinal braid, and then I don't think it can stick further out. So it will always be the same kind of distance sticking out. The anchors will always have the same length, seems. Yeah.
I also have a question, regarding the anchors. So, because sometimes, we cannot be coaxial because the line of hooks are at the same point. So these anchors are coaxial to actually the device itself. So I mean, in one side, the anchors anchor more proximal to the lobe, and maybe on the other side more distal. So are coaxial the anchor line and the device itself?
Yeah, so it's one of the, so with the device that we'll be bringing forward now, it's a steerable sheet system. So, and the anchor system allows for coaxial alignment. So once you're positioned within the left atrial appendage with the scaffold, it automatically allows for coaxial alignment of the anchor system using the steerable sheet system.
Can you give us oh no, there's a further question.
Yeah, it's also concerning the anchors, because obviously this is a very new concept and interesting. So I had the impression the anchors are pretty long, and my concern would be that the anchors have fractures over the time. Did you observe something like that?
No, we haven't seen that. Obviously they've been tested to the same protocol that we test every other part of the element of the device, so 100 million cycles, and we haven't seen any damage to the anchor system.
Maybe I also wouldn't be that concerned. I mean, even let's say after a year there would be a fracture. Normally that thing should be grown in a way. Yes, so I don't know.
So we've seen in our preclinical studies at 45 days, there's been pretty thick pannus across the face.
Can you give us just final question, a very realistic timeline? Now we show it here. When do you think, and honestly a realistic thing, when do you think we may see this in Europe? Not first maybe in study, but also then commercially. What is a realistic timeline you have?
Realistically, we're aiming to be in studies in Europe early next year.
So early 2027, yes. And then you're going to run a pivotal trial. You will need a trial of 1,500 patients, I think, roughly. Yeah, so that's okay.
But that'll come obviously after. So the next stage will be a large feasibility study, OUS, and an early feasibility study in the US.
That's going to cost you 1-2 years, 1 year follow-up. So then earliest 3 years or so, 3.5, 4 years before commercial, if everything goes well.
It's not a short process.
No, okay. No, but good. All right, good. Thank you. And I think then we invite Sergio Berti, yes? No? Oh, Luigi. Okay. So yes, please join for the conformal the class device. Yes.
I am Luigi Pastormello and come from Massa, and I will present you our initial experience with the Conform class device, and I will show you a nice guided case that we perform in our CAF lab in Italy. Briefly, some technical points about the device that make it unique and that can account for some specific use. The first one is about the composition. This device is made by a foam matrix body on which is embedded a compliant nitinol endoskeleton. On the atrial surface, we have a polytetrafluoroethylene dual-layered cover that is connected with a flexible tether. So the consequence is that we do not have exposed metal on the left atrium. And this has two main objectives that are to reduce the thrombosenicity and to make a perfect sealing, since the foam has a perfect conformability into the left atrial appendage. From this point, we derive another point, that is that the sizing is very simple, because we have only two sides of this device, and one size, the regular size, that is 27 millimeters, covers for about 90% of left atrial appendage anatomies, because it covers an ostium range that go from 10 to 33 millimeters, and we need just to have a mean diameter that is less or equal to 25 millimeters. And given the foam conformability, we can cover a very elliptic anatomies for the left atrial appendage, ostium and landing zone. The third main advantage that we have with the use of this device is related to the delivery sheath. We have a delivery sheath with two steering planes, two orthogonal steering planes that have the main objective to gain the best implant orientation and to permit us for a perfect implant into the left atrial appendage, as you can see in the cartoon. At our institution, we use intracardiac echocardiography, usually two-dimensional intracardiac echocardiography, and this has two main objectives. The first one is to avoid general anesthesia. The second one is to have a perfect imaging, because the nearest you go to your target of interest, the best imaging you may have. To perform left atrial appendage with intracardiac echocardiography, above all if two-dimensional intracardiac echocardiography, we think that pre-procedural three-dimensional evaluation better if with CT scan is mandatory to have a full evaluation of left atrial appendage anatomy. In this specific case, we have a whole tail about morphology, whale tail left atrial appendage anatomy, and from with a circular landing zone, a mean diameter that is that permit us the implantation of the regular size of the device, because it is 23.5 millimeters, and we have some trouble about the shortage and the functional depth of our left atrial appendage, because it is 11.5 millimeters. So we have a moderate, difficult case according to the Elaacc classification, as we have short depth for implantation. We perform transeptal puncture in a common inferior and posterior position, guided by the intracardiac echocardiography, and then to get a perfect imaging of left atrial appendage, as mentioned in the morning, we have to go with the probe inside the left atrium, and we usually use this technique. We place two guide wires in the left upper pulmonary vein. We align our probe with the two guide wires on the same transeptal transeptal point, and then we get in the left atrium. Once we are in the left atrium, it is fundamental to have at least two different orthogonal views of the left atrial appendage. The first view is from the left upper pulmonary vein. It resembles a cranial fluoroscopic visualization of the left atrial appendage, and it approximates 45 to 60 degree projection of transesophageal echocardiography. The second view, that may be a little more complex to obtain, but you can obtain after a moderate learning curve, is the so-called supramitral view. So you are on the anterior leaflet of the mitral valve with the probe, and you see the left atrial appendage from down to up. And as you can see, this view resembles a caudal view from fluoroscopy and approximate 135 projection from transesophageal echocardiography. Then we place the probe in the mid-left atrium, and we follow all the steps of the procedure. We selectively enter the left atrial appendage with the pigtail, and then we start with the release of our device. You can see the orientation of the delivery sheath. We push the device inside the left atrial appendage. The distal end of the device is very soft because it has a sort of a foam bumper, and we follow this with echocardiography. This was the first release. It's a bad orientation, two proximal device, no sealing of the left atrial appendage, as you can see also from the echo visualization with Elaacc. Then we move for a different orientation of the delivery. We move more forward with our implant, and we release, we place the device in this position. At this stage, we check also from an orthogonal view. So this is the supramitral view, color and without color. Then at this stage, you have to release the tension. So you have to release the tether from the pusher, and to assess the position and the stability of the device after this release, in the echocardiography, echocardiography, you can see the contour of the tether and the detail of visualization from the supramitral view. Then, in this condition of released tension, you perform the tag test, so you check for the stability of the device, and you evaluate all the criteria that in this case are with this acronym: P for position, O for orientation, S for sealing, and T for tag. And then you release the device with this magnified final result, and with this result at echocardiography, when you have completely released the device from the tether that kept it attached to the delivery, to the implant system. So the device is very interesting because it has a high conformability to different anatomies. It may give a perfect sealing. The delivery may be simple, and the orientation with the delivery catheter is very, very useful for this. And the imaging of this device is very good, also with eyes and with no need for general anesthesia. And the promise to reduce thrombosenicity has a clear background by the total absence of metal exposed to the left atrial surface, to the left atrium. Thank you so much for your attention.
Thank you very much, Luigi, for a very, very nice case. We have only time for one or two questions or comments because we all need coffee now.
Yeah.
One quick question to any of you. I mean, 3 of the 4 devices that we have presented here are single lobe devices. What do you think is going to be the future, this type of devices, or still disc-based devices? Any of you?
Yeah, I don't know. I mean, look, I like to make the comparison with TAVI field. I mean, a single device is like the sapien of the devices. Yes, it's super easy, it's simple. I mean, it's teachable to everybody. It's very easy. Whereas a double component device, it's like a self-expanding TAVI device. There's just more learning curve. To become really, really good at it, you have to have more attention to more things, so it's less forgiving in a way. So that's how I look to it. Single device is easy. Double component is always a bit more difficult, I think, to get the optimal, perfect result. Everybody can put it in, but to get the perfect result.
Yeah, I like that comparison because sometimes we talk about flow, dynamics, these kind of things, and I mean, maybe it makes more sense that this for the flow, but finally the results are this, so I don't know, to be honest.
I believe this concept of having a very early complete seal might be actually very good. Maybe also in terms of looking on the speed of cell coverage, because I think if you have this washing in and out of the device for a prolonged time, it's something that can disturb that. So that's something that could be nice to investigate more. Is an early complete seal also something that really can facilitate healing and reduce the risk of DRT? And that was what we saw with this device and also with the former Zenit device, very early rapid occlusion.
Yeah. A question by Martin. So.
Well, just a short comment or idea. I think what we see with all these devices is that they will struggle to really do large-scale comparative trials because that's a big investment. And we know from what has happened that really this space of LAAC is complex because of the variability of the devices. And we've seen devices where we think they were good and we're discussing this and then they didn't work because some issues like pericardial effusion. It could be a role of Elaacc actually to set up a registry where from the beginning we collect all the data with the existing devices and the other devices you know, I mean, we will not make obviously the comparative prospective studies, but at least one could fill the space because it will be interesting with the growing evidence that this is a standard therapy for AFib patients to get more data on all of this.
Yeah, possibly. I mean, my only question there is, I mean, it seems the device occludes, if you get it in place, it occludes really well. That's very good. But what is the rationale to work with that tether? I mean, maybe also from the company here. I mean, that tether, I mean, there was a good idea behind it, but doesn't it complicate the procedure because you're completely dependent on your implant from your sheath, yes? If you can't get your sheath in a good position, you cannot get your device in a good position because it doesn't hang on a cable like we're used to use with other devices. So, I mean, maybe there was an initial good idea, but in practice, does it really turn out to be practical? I don't know. Like, well, and do you still hold on that tether?
Well, the concept of the tether, as you said, was allow you to be able to see how the device really lives before you release it, and that our updated delivery system allows you to have a cable-like delivery and then be able to see what the tether does or how it lives before you do the final release. So what we're really working for to have the ability to deliver cable style, but then to evaluate the device on the tether before final release.
But there's one more argument, and that is that the surface of your device is completely free of any metal component that should hold a cable. So that's one advantage, I think.
I should let you answer the questions going forward.
Yeah, everything has pros and cons. But okay, time for a break, I think, coffee break, and in 15 to 20 minutes, we'll be back. We will not start later than 11:05, I think.
Just too good to be true. I can't take my eyes off of you. trust in me when I say, oh pretty baby, don't bring me down, I pray, oh pretty baby, now that I found you, stay and let me love you, baby, let me love you. You're just too good to be true. I can't take my eyes off of you. You'd be like heaven to touch. I wanna hold you so much. At long last love has arrived, and I thank God I'm alive. You're just too good to be true. I can't take my eyes off of you. You want to do, 'cause you're what you gonna do? Make the change, let's start today. Get out of bed, get out your way. Don't be scared, your dream's right there. You want it, reach for it. You've gotta live your life and do what you want to do. 'Cause you're free and do what you want to do. You've gotta live your life and do what you want to do. 'Cause you're free and do what you wanna do.
Every breath you take, every move you make, every bound you break, every step you take, I'll be watching you. Every single day, every word you say, every game you play, every night you stay, I'll be watching you. Can you see you belong to me? How my poor heart aches with every step you take, every move you make, every bow you break, every smile you fake, every claim you stake. I'll be watching you. Since you've gone, I've been lost without a trace. I dream at night, I could only see your face. I look around, but it's you I can't replace. I feel so cold and I long for your embrace. I keep crying, baby, baby, please. this. I can't believe this could be the end. It looks as though you're letting go. And if it's real, well, I don't want to know. Don't speak, I know just what you're saying. So please stop explaining. Don't tell me 'cause it hurts. Don't speak, I know just what you're thinking. I don't need your reasons. Don't tell me 'cause it hurts. Our memories, they can be inviting, but some are hard to get in mind. Frightening, and as we die, both you and I, with my head in my hands and sit and cry. Don't speak, I know just what you're saying. So please stop explaining. Don't tell me 'cause it hurts. Don't speak, I know just what you're thinking. I don't need your reasons. Don't tell me 'cause it hurts. It's all ending. I gotta stop pretending. We You and me, I can see your signs. I will. Don't speak.
Where are you going to say? On the chair?
We need it on the
Okay.
podium.
Is that for the chair?
Should we start? Yes, no?
Just wait 1 minute.
It's right on time, so it's good.
Yeah, maybe we should stimulate a little bit that the people are coming in because we have to continue. We wouldn't like to have too much overlay or
Yeah, exactly.
or delay.
So I think that we should maybe.
Yeah, but I don't even see Ole, who's the first speaker in the room. So we definitely need at least the first speaker.
We start with Sergio, no? So basically, we were, like in the previous session, we were just showing new devices, occluders. Now we will show you new tools, from sheaths to, more, software things. And well, Ole.
Yeah, the first
You're
speaker.
the first speaker.
The first speaker is Ole. And Ole, you'll give us some insights in 3D intracardiac echo and the European experience at 1 year.
All right, good. Yes, indeed, about the Philips 3D eyes, which we have now since when? Since July, wasn't it? July last year, I think, since almost a year in Europe. And there's some people here in the room who also have experience with it, I know. So first, a little bit more theory, the potential benefits. You have this on the patient level, hospital level, benefit cost discussion. So first on a patient level, I think there's still a little bit in some operators, maybe suspicion that maybe ICE-assisted or ICE-guided LAA closure is maybe less safe as TOE or TEE-guided LAO. But I think in the meantime, there is good data on this, that in literature, that it is as safe. This is about procedural success. The other one is about the complication rate. You even see there in pure absolute numbers, lower procedural complication rates with ICE than with TE. I would say, of course, it's always difficult to interpret this. This is from the literature. I think you should really look into real practice. It's all coming down on experience. I mean, if you have good experience with it and you build it up in a safe way from in the start and you do enough of these cases a year, you have enough volume of it, I think you become good at it and you can do it in a safe way as it is with any other cardiac intervention. And then also, which is maybe even more important, you see here ICE-guided LAO, the outcomes of it. So here you see on the left-hand side, this is outcomes of routine intracardiac echo used to guide LAO occlusion, peri-device leak, minor leaks, major leaks, because that could be the critics from some that you say, yeah, well, if you use ICE-guided LAO closure, you can get the device in place, but maybe you will end up with much more leaks. I don't think that's supported by the literature, on the contrary. And then on the right-hand side, that's for the Watchman device only, also similar outcomes. Does the surplus ICE LAO data suggest caution? I don't think so. I mean, again, you see here on the left-hand side, the composite of adverse events with ICE was 5.2 versus 4.6. No difference there. Mortality, of course, no difference. Pericardial effusion, not really a difference. And also on the right-hand side, successful LAO implant, complete seal, and general anesthesia use. I'm still surprised to see in 61% of ICE-guided LAO closures that they're using general anesthesia. That's my whole point why I use ICE, is actually to do these cases in complete just local anesthesia. Just a patient where we're talking with and who's completely relevant and awake. That's the whole point of doing ICE-guided LAO closure for us at least. Sorry, I will go further here. Also, this is then again with the specific VeriSight Pro, that's a Philips 3D ICE. There's also there some reports, small reports with small numbers though, but again showing that it's a safe approach to do 3D ICE-guided LAA closure. Also, eliminating general anesthesia in structural heart procedures has of course resulted in patient benefits as such that yeah, you can avoid complications which are maybe related to the general anesthesia. And also here the patient comfort. So you see here esophageal tears, aspiration pneumonia, stomach laceration. I mean, this is maybe really seldom, but on the other hand, with ICE-guided LAA closure, I never have seen any of those in any of these complications. So I think it's an extremely safe approach for us, at least. It works really well. And also even just the flexibility, I can plan my cases. Sometimes I can plan an LAA closure on any day, just in the middle of 2 TAVI procedures. I can take it on top of another cases on my list on another day. So the flexibility I have of planning in my cases, I'm not dependent on anybody else. It's just if I'm there and I have 2 nurses and I have a fellow, we just do the case. I mean, I'm not dependent on an imager or an anesthesiologist. I mean, this is extremely easy for me to do my scheduling. So on the hospital level, this is then also again focused on the VeriSight Pro 3D ICE. So it was suitable alternative to TE. Here it says in 89.5%. I don't know why they write 100% because in my hands it works in, to be honest, in 100% of patients. And there were 0 peri-procedural adverse events in this series of patients where they used the VeriSight Pro 3D ICE probe. And you see here, that's indeed what I said, the simpler scheduling. So you cut out really a lot of people you need. On the other hand, I have to say, if you go to 3D ICE, there I think I really need an imager again, because it's for me, maybe it's doable, but on the other hand, it becomes too complex. I think the beauty about 3D ICE is that you have the possibility to do MPR imaging, proper sizing, and that's not something I can do. Maybe I can do, but I don't do. I don't do it at the same time while I have catheters, delivery catheters in my hand. So I typically have an imager again, then who controls the console. I control the ICE probe, and so in these cases with 3D ICE, I have an imager on board again. Also, Everett, that's about how quickly you can change your patients in the cath lab. For me, at least in a university hospital, I mean, changing a patient with general anesthesia, that costs me a tremendous amount of time. I mean, it costs me more than an hour 15 in between patients, whereas if it's in local anesthesia, typically you can reduce this to half an hour, 35 minutes. So I lose a lot of time with general anesthesia, to be honest. But that's maybe very site-specific, of course. This slide I showed before. And also, if you have to anticipate, that's maybe more for the American market, but hopefully also for the European market, if there's increasing numbers of LAA closures, then you have to be able to do more cases on a shorter time span. For example, I'm limited to maximally 1 day a week or 1 day every 2 weeks where I can plan LAA closures. Of course, I want to squeeze in as many cases as possible on that one single day. And then cost-benefit, I don't want to go into that discussion because that's very different for the European context. Many of you will argue that, yeah, okay, but the anesthesiologist is in the hospital anyway, or the imager is in the hospital anyway, so that's not a cost, whereas my ICE probe cost me maybe 4,000 euros. Well, I mean, in the US context, it's different. Even in the Danish context, it's different. My heart center has to pay to get an anesthesiologist in my cath lab. So for my heart center, it's indeed a cost reduction if I don't need anesthesia or I don't need an imager. So we can cut in personnel costs. So for me, in the Danish or US context, it's of course attractive to have ICE and less personnel costs. So this is kind of a summarizing slide here. As you see, I think there's a lot of potential benefits on the use of ICE and specific also 3D ICE. The great benefit about 3D ICE for me is really that 2D ICE is purely a tool to guide me, to do a proper transseptal puncture, to do a proper execution of my LAA procedure, closure procedure, as planned on typically CT. So I have a full 3D imaging up front, whether it's CT or 3D TOE, I don't know, but you need proper 3D pre-planning if you're going to use 2D ICE only in the procedure. I do use 3D ICE. The benefit of it is that in a way you could potentially skip, I don't at this moment, but you could potentially skip your 3D planning up front. And what is definitely true is that you can do a proper and reliable sizing of your LAA under the procedure. With 2D ICE, in a way, I don't even measure anything. The sizing is not accurate, but with a 3D ICE probe, I want to show you that in the case here. So this is a case, I don't know, a couple of weeks ago we did. So it's not a tremendously difficult anatomy. It's just some kind of classical chicken wing with good, nice depth. Okay. So here you see the classical CT sizing. Yeah, you see already, so this case was planned now for a Watchman Flex. What we typically do is, we have some idea about the anatomical ostium, but of course, as most of you know, if you do sizing for a Watchman Flex, you don't want to measure the anatomical ostium, you want to measure the ostium, or so-called where your crown, your ostium of your Watchman Flex is going to be. Yes? So that's typically a couple of millimeters deeper in. So keep an eye on that. That's the size there is around 27 by 22 millimeter. Yes, that would be 27 by 22 and a perimeter-derived mean of around 25. So having this, I will probably go for a 31 millimeter device. That's how I do it at least. So I go for my not anatomical ostium, my Watchman Flex ostium, measure it. I have a perimeter-derived mean diameter of 25. I want 20% compression, so I end up with a 31 device. The 31 device is also larger than the maximum diameter, which is 27.2. So no doubt, to be honest. So this is then the optimal implant view. In this particular case, it's an REO30 cranial 4, so that's great to know. And then this is in the case here. So me and my colleague, there's a fellow on the background taking some pictures, it seems. And then that's not the usual setup. Typically, it's a fellow who executes the procedure, but this was a recorded case, so I was executing it myself. And then you see here, this is the eyes. We have a good tenting, and then we come, this is with the Versa Cross. It seems like we're playing there even with some CT fusion imaging. which we don't do standard at all. That's why there's also pigtail in that aorta too, because we have to use that in the Siemens to do the calibration well. So here the VersaCross comes out, VersaCross wire. I don't think this was the VersaCross Connect, because or maybe it is, I don't think so. This is the regular VersaCross. And then here is the injection. We clearly miss some counterclock still. It confirms indeed this is in the REO 30 cranial 5 or 8. Then we get the eyes imaging. Let me show here. So this is the 3D eyes, Philips VeriSight Pro 3D eyes. So we're gonna put the sector, and that's very familiar for those doing 3D TOE, I think. So it's exactly the same. You can do MPR there. So there the box is put on, and then let's take a minute to have a look on the sizing. You see there also the pigtail catheter going into the appendage. In a way, I know from my CT that which device I'm going to use, but this was also more to demonstrate. So here he can put his lines, as you see here on the top two windows. He has to put his lines correct where we think we have to agree on where I want to implant my device, and then he can put these lines there to measure where the crown of that Watchman flex, if you still call it crown, I don't know, but he puts it at the region where he wants to be. And then you see, of course, then on the left lower panel, you will see indeed at that plane, you see a cut, a slice through the appendage. So it's maybe not totally perfect. I'm not totally 100% happy, I think, about the left upper one. I think it should have been counterclocked a tiny bit more. But otherwise, I think this is pretty fine. So you see, again, we don't go for the anatomical ostium, but really trying to envision where the device should land and where I think as an implanter can... So you have to communicate, me and the imager, we communicate, and we have to agree upon where we want to implant the device. And then here, the sizing. So, and you see there on the right top corner, so he measures there 27 by 21, yes? So to remember, yes, so this was my CT planning. I had 27 by 22, so it's extremely similar. Yes, so that confirms that the 3D eyes imaging sizing is extremely accurate. It's exactly the same as I have on CT. I think that's probably the same if you do 3D TE imaging and sizing, but it shows that the value of multiplane reconstruction sizing of LAA, you can really match, and it confirms actually my device size for the 31. Yes. So then we move on. Let's see here. That's maybe the more boring part, but yes. So ring to ring. Make the click. This was some educational case we had to record, so I think we talk a little bit more under the procedure. Yes. And even also if you do eyes-guided LAA closure, I can tell you, I mean, this case is now cut in parts, but from puncture to closure, these cases nowadays typically take around, honestly, like 30 minutes max, I would say. They don't take longer, even with that one additional access and having the eyes. Also, the crossing of the eyes probe to the left atrium, that's clearly in the beginning the hardest part. The biggest learning curve is there. But if you've done a couple of hundreds of these cases, it goes actually really, really smooth as well, I would say.
Ole, while you're showing the case, can we get a question? Because we're like short of time.
Please do. I think it takes
Xavi,
just 1 minute.
You had a question or a comment?
Just thank you for the presentation, Ole. We are one of the few operators, we're doing eyes with most of our cases, but we need to acknowledge some of the limitations. And let's say that probably with 2D eyes, the quality of color, it's not good at all. So I think that most
the quality of
Doppler color.
Color for checking for leaks, you mean?
Yeah, that's it. So I think that probably the success relies more on the CT pre-qualification than the procedure itself. What's your opinion on that?
Yeah, I don't know. I mean, to be honest, if I compare my closure rates in my center with other published, it's far better, to be honest. So maybe it's just based on the CT, I would say. And I mean, how often do you really reposition? Because you see you have tremendous leaks. I mean, you see it also then with the contrast injection, I would say. So I'm not 100% sure if that's Doppler, color Doppler is really, for me, it's not a determinative factor to reposition devices very often, I would say.
Honestly, if we see a leak, we see it on CT post-procedure at 1 to 2 months.
Yeah,
So.
yeah, exactly. Yeah.
Any other question while, you know, like the watchman's getting...
Yeah, we're explaining.
I mean, Ole, for me, I'm from Germany, and I'm always impressed if I see that far over 90% of the TE-guided procedures are done under general anesthesia. So obviously the Germans are tougher because we usually do deep sedation and no general anesthesia.
No.
Laura, maybe you can add on that.
Well, I really like the case because it's highlighting how nice it is to can guide with 3D. That is the thing that we already do with the TOE. And on the other hand, I think it's not totally like true the comparisons that you show at the beginning, because it's always compare the eyes with the standard T guiding, that also for some centers they put a 3D probe, but it's not 3D guiding. And also you always talk about general anesthesia, but now with the mini probes, we're doing also with the patient totally awake. It's just anxiolysis. They talk when you finish. And we avoid to have general anesthesia there. We also don't have any arterial access. I saw there a pigtail. And I think the turnover...
Yeah, that's not a need. That's because of we were playing with the fusion imaging there. But
and the turnover of the room, it's the same as if you are using eyes and without less intervention. And regarding the cost, if you avoid general anesthesia, if you really spend less money using eyes, probably I need just to move to Denmark to work, because, you know, every eyes is quite expensive. You know, you can
but again, this is not a
money.
plea to do. Just, I mean, every setting is different. Spain is different than Denmark, indeed, or US. So, I mean, this is just one of the possibilities. It's just, I don't say this is the way to go.
No, but the only thing is that it's always the comparisons made with the standard T.
No, but indeed, I think we have to step away from these comparisons. I mean, you have to deal with the setting you have to work in, but this is one of the options. I mean, for us, eyes works definitely the best, and then 3D eyes, the benefit it gives the 3D eyes is really that you can do a proper sizing. That's actually what I just wanted to show, that if you see the CT sizing on the 3D sizing on the 3D eyes probe is exactly giving the same.
Yeah, and also the imaging, it's super good.
You see here also, it's extremely good quality. In fact, you see there, now we're putting also the color on it. We even make, I don't think if you have the time, but it will show some 3D reconstructed images. Even you see how much protrusion there is from the shoulder. There's a little bit of shoulder, but you can really precisely look at this. So, I mean, it really definitely has added value, I think. Yeah.
Ole, who is managing the catheter in your hospital? Is the
ice probe?
Cardiology, the ice probe?
Most of the time it's me. I'm doing the ice probe, and then the imager is busy with the console. Yes, but I control the ice probe typically myself.
Yeah. Can I add something as well? So I'm also an imager. I'm doing transvaginal echocardiography with the team, and I think that, so this is what I wanted to ask, if it's you who's manipulating the ice catheter or is your imager, because sometimes imagers will be very exigent with the cut planes. They want to have a stable cut plane, they want to have accurate measurements and so on. So I think it also depends, of course, on who's handling the catheter. Mm-hmm. And I think that your images are actually wonderful. They're very stable, they're very clear.
But typically, I mean, during an LAA closure case or even during tricuspid tear or so, I don't fiddle a lot around with that catheter. I put that catheter somewhere in a good position and I leave it laying on the table. So it's not that I'm very nervous running around with that catheter. That's a bad thing, I think, indeed. I mean, typically I find a proper position, and that's where you work from. Yes,
okay, so it's quite stable actually, because I've never used this, so I have no idea. So it's quite stable. You put it in the left upper pulmonary vein, you leave it there, you have the 3D image, and then your imager does all the measurements, and it's stable, right?
Yeah. Yes.
Okay, thank you.
Most of the time it's like that. Yeah.
So probably, I think that we need just to move on. I don't know if you have like a final slide of conclusion or you want to say something.
No, that's fine. I mean, you also
nice.
see here, this is the final result, so it's a perfect occlusion also, so I think the sizing was right. So I think it was just a demonstration of how you can work with eyes, with 3D eyes. The 3D eyes, for example, I use it for sure in patients who cannot have CT due to renal function typically, then I think this is a great add-on for me in my lab. But indeed, you have to see cost-benefit what you use. Yeah.
And maybe a final word, but Marek maybe come already to the podium. A final word, Ole, would you use eyes without pre-planning at the moment? Would you suggest it?
Yes, so if I wouldn't have pre-planning, then 3D eyes, yes, I've done cases like that. Yes, so I've done recently, the last 3-4 months, 2-3 cases which couldn't have a CT, and then no pre-planning, just go into the case, 3D eyes. With 2D eyes, I would never do that, to be honest. Yeah.
Thanks, Ole. Excellent presentation and excellent technology. It's really amazing. And we welcome to the podium to Dr. Marek Griguet. So he's going to talk about new advances in steerable catheters.
Okay, thank you very much for the invitation. So I'd like to show you something about the steerable sheet. Here are my disclosures. So the first thing, why do we need a steerable sheet? We need that steerable sheet because first to avoid the misalignment, and if you can get improved access by steering, then it's easier to get to the definitely much more range of LAA anatomies, and each of us had a case like that or cases similar to that or even more extreme when it's quite difficult to obtain the coaxial alignment. And when the device is misaligned, in many cases when you deploy the device, the situation is like here, that without steerable sheets, of course, it's doable, but then it's quite difficult. And if you are doing then a TAC test or you want to just perform a contrast injections without the steerable sheets, in many cases, you are pulling the device, but it's completely out of the coaxiality, or you are injecting a contrast, and instead of getting to the LAA, that contrast is getting to the pulmonary vein. So what we have? So everything started probably with a steerable sheet from the Amplatzer, which we had in our hands, I think 3 or 4 years ago. And there was in that sheet, there was a bidirectional steering from 0 to 120. There were different stiffness of the different parts of that steerable sheet. And I showed you it's somehow historical picture, but which I record in my lab, but you can appreciate how that steerable sheet was working, that in fact for me, it was just steering of the distal part of that sheet. Was it helpful? I would say that in some cases was helpful, but in some cases, especially that when you perform a puncture not in a proper orientation, for me, with that steerable sheet, it was even more difficult to perform the case than with that steerable sheet. So anyway, you need a perfect puncture. And there are, of course, some publications showing that with usage of that steerable sheet probably could be helpful, but as you are all aware, that steerable sheet is, as I am aware, no longer on the market. And then there is a true steer from Watchman, and for me, that true steer, it's a game changer. I started to use it 4 months ago, and from that time, I am doing all my cases of LA closure, all cases, with that true steer. Because for me, it's extremely helpful, and I don't know how to predict, or it's difficult for me to predict when I would need that. And if you switch from a traditional fixed curve sheet to that true steer, it's helpful. So you can see how that device looks like. that in fact the range of deflection is higher, and with balls created you are able to get to the different anatomies, and it's quite user friendly because there is that handle, and just by turning that knob you are able to move to the desired position. So instead of using these different types of sheets as it was in the past, you can use just that true steer sheet. And your hands, with the usage of that, behave exactly the same as you were be used in the past to the traditional sheets. So one hand on the left hand just on the knob and just to making a rotation, and the other one is just for the deployment. And what is also quite unique with that sheet, that there is, and Erik mentioned about that it's possible that during deployment, and on that movie you can see that there is so-called a mid-deployment steering. So in some anatomies, you can partially open the device and then perform that steering. So if you looked again on the video which I prepared, so you can see how that steering looks like. So with that knob, you can flex or extend, and of course there are still these movements which we used so far, so anterior and posterior movement, and with that steering you can quite easily get to some difficult anatomies. Are there any data to support that? To tell the truth, not so much. I was able to find only a few presentations. Here's one of the presentation in which they showed just 12 cases in which it was not possible to perform the LAA closure with traditional fixed curve, and it was possible to close the LAA with the usage of that flex steer. However, we will definitely have more scientific input from the studies for Watchman Flex Pro registry, which will be conducted in Europe. 300 of these patients will be patients which are will be treated with that flex, with that true steer. What is also important, it's a combination, a true steer with the Versa Cross Connect, and with that, then it's extremely easy to perform the procedure. And I will show you just one case which we did, I think, one week ago. So with the true steer and with the Versa Cross, everything together from the beginning, you can do a puncture, and then without exchanging with that Versa Cross, you can enter to the left atrial appendage with the tip of the Versa Cross. You can enter to the appendage or be like here, quite close to the ostium of the appendage. And then when you advance the ball, and if your position is not suboptimal, of course it's not difficult, the appendage, you can steer to be coaxial. And I would say that it's quite helpful in many cases. So in such cases, and also you can appreciate that by steering you can be coaxial, and for these for the deployment of the device, you can steer it in such a way that there is no let's say no tension on the disc, and I think that feature is quite helpful. Is it helpful in the procedure? I found one publication in which they compared the different approaches. The last one is that one with the true steer and Versa Cross, and not only it saves many steps of the procedures, but it's associated maybe not with the better results so far, but definitely with a reduction of the time of the whole procedure. Thank you very much.
Thank you, Marek. And thank you just to present on time. I mean, that helps a lot. I don't know if there is any comment or question.
Yeah, Marek, I would have a first question. So in how many of in your experience, in your lab, in how many patients do you need a steerable sheath to get better alignment of your device?
Yeah, I would say that it's definitely helpful in about, I would say, 20-25% of the cases. But if you use it on regular basis, as I am doing in all cases, because for me it's difficult to predict in which cases I will need it. And then exchanging from the fixed curve to true steer increase the cost. And for us in Poland, the price difference between these two types of sheets is not a big one.
Another question there.
I have used True Steer recently for a very retroverted chicken wing, but what I found is very useful was rather than getting, I mean, coaxiality is great, but when you release it, actually, if you reverse what you did, it will slowly, you'll be able to get the device in a better position. So sometimes it's very difficult to get the coaxiality. So, but once you are in, and then when you're slowly releasing it, actually that was really helpful in addition to getting the coaxiality.
Yeah, absolutely. So that let's say mid-deployment steering is extremely helpful, especially in the anatomies which you mentioned, that there is a chicken wing, then it's extremely helpful.
Thank you, Marek. I will also just support you. I'm also using now 100% the True Steer. I'm using it together with the VersaCross Connect. And I think that now has become very easy. Do your transeptal puncture with this system, go with a spiral-shaped wire directly into the LAA, and then advance the sheet, and you are just ready to deliver your device. So it's very easy. Yeah. And I think it's also a matter of safety, because you now can avoid changing your transeptal sheath to the delivery sheet. And every time we exchange a sheath, there is a small risk of air embolism, etc. So I think it's also a matter of safety. But and then the cost is a little bit higher, but you also have to take into consideration that you save the mechanical needle and the sheet for your mechanical transeptal system. So it's simplification and more safety, and we will get more anatomies, we will get better alignment, and in the end I am convinced that we will get better sealing as well. Mm-hmm. Still, one of the most frequent mechanisms for leaks with the flex device, it's malalignment and a tilted device, and this we can avoid this with the steerable sheet here.
Yeah, Jens Erik, fully agree, because we make a cost calculation, and if you, as you said, avoid this special, let's say, sheet for the puncture, needle for the puncture, stiff wire, every single one, it increased the cost of something like 150 euros in my case. So
Tom and Luis, and because we're like running out of time.
Briefly, I just also first want to support also the value of the mid-deployment steering. I think it's the game changer for this sheet. And not only for the difficult or otherwise impossible cases, but also for the so-called easy cases, to optimize the final 5% of the alignment to go from 95% perfect to 100% perfect. Having said that, as we start doing this, we're using the device for something it was not really intended for. We're using the device to push itself against the anatomy, and we haven't seen issues, but we also have not done a lot of cases. In your experience, is there any reason for concern of using the device itself to be pushed by the sheet against the tissue wall? I'm thinking of complication risks, of course. I'm thinking of why we started using the pigtail for sheet positioning originally, because there were perforation issues.
Yeah, I would not afraid. At the beginning, especially with the VersaCross, I was afraid to enter inside. But when I have a ball configuration, I am not afraid at all, because with a ball configuration, I feel completely safe.
Okay, Luis.
And when I have little experience with the VersaCross and the True Steer, but in one case we had problems to do the transeptal puncture because it was a floppy septum, And then when we have these cases, you usually bend your Brokenburg needle. But with this sheet, I don't know if you can steer when you are doing some tension on the septum, or you only bend the dilator of the true
Yeah,
stream.
with Versa Cross Connect, you can bend the dilator, and that dilator after bending keeps that curve.
But
so if I am not able to get the proper contact, I remove the dilator, bend it, and try once again.
Thank you so much, Marek. So we have to move on, but this was a great overview of the features of this device. And we are moving towards a completely different field, and artificial intelligence will be one of the drivers of future imaging. And Martin, you will give us some insights in your workflow, artificial assistant implant, from planning to execution. So you made it to the stage.
Yeah, I'm trained by now. So thank you for inviting me to giving a talk on this interesting subject. I think there are probably some other people in the room that might be even more advanced, but I just tell you my perspective, and congrats again also to the committee here for putting together such an interesting meeting. So what are the challenges with current LAAC workflow? If I think back of all the live cases that we did over the years, I think sizing is still a big issue, and missizing also leads to a number of problems that we have, including leaks and others. I'm completely new to the field of CT measurement, as we are in Germany, and we relied on TOE for such a while, so allow me to make you part of my learning curve. So when I started measuring CT, I got quite confused because it was different to the TOE measurements I did for some time. And so thinking about what we want to achieve and where to measure, actually I came up with this site where I put in something like a central axis, possibly also in the future guided by AI assistance. And then for me, the big difference, the learning curve, was to the CX, whereas for the Watchman Flex landing zone, and I'm purposely not talking about ostium because that's a lot of confusing things. What is the ostium and where do we measure? We have this other sizing. And that we are not perfect, I think, is something that's shown in this paper from the Copenhagen group and others, where if you are really critical to your own measurements, you see that we still, even with CT standard planning, which is the left side of the curve, so what we do maybe with Symentia, as far as I understand your paper and your workflow, we have critically speaking up to 40% at least partial leaks. And this is, I think, the first and real nice paper showing that on the right side, this is CT and simulation planning assisted by AI. You are able to improve that. We had the chance to publish a case report where we had also the option to use the FEOPS planning. It was a difficult anatomy because it was like an inferior chicken wing. And the FEOPS planning, both guiding us where to measure actually the landing zone, as well as what kind of devices would fit, helped us a lot. Because from TOE, I can tell you everybody would have picked the 28 millimeter device, which in the end, and you might have a look and judge on that paper, did not fit. I won't go into the details because this is meant to be a talk of where we are going and where AI might help us. I should add that FEOPS also has a tool to allow you to go for Watchman Flex procedure planning, which so far is done with either Symentia or this software called TruePlan, which is, I think, now distributed in the US, but it's less so well known in Europe. And you can also depict the sizing chart. Also, you can model the device in this software, but not as elegantly as done with FEOPS. I've been part of a development which I also think is quite interesting. This company aims actually to give us a virtual eye where 3D images from the echo are overlaid to the chest X-ray. And at the moment, we are testing it for pre-planning, but in the future, the aim is also to use it intraprocedurally in addition to the workflow that you have. You see the two of us there measuring different aspects of this LAA. You can look at it from many aspects. You can also model in some of the devices, particularly now this is meant for the amulet. And the nice thing is that you get a visual impression of what's doing. So turning to the intraprocedural challenges, some of this has been shown before. I think we still sometimes struggle with the correct location for the transeptal puncture, and to control the transeptal puncture you might be good, but then you slip somehow once you put in pressure. Navigating the left superior vein sometimes takes time. I'm still advocating this as a safety issue, not to go for the LAA. And then navigating the LAA sometimes is also difficult, particularly if maybe your transeptal puncture is not ideal. We got a new CAS lab beginning of last year and had the chance to implement the Echo Navigator developed by Philips now, I think, for 10, 12 years. I used an initial version back in 2013 or something and wasn't convinced, and I was quite surprised to see that this newer development we now have, once you have really done the really simple now alignment with your X-ray, for me is really helpful. Where is it helpful? Well, first, I like to use it now for transeptal puncture because you see this little red dot on the right side in the middle. That's depicted by the echo colleague to tell you exactly where you should aim for the transeptal puncture, and rather than the echo searching for where's the transeptal needle you really have on your X-ray in the right connection, it's more or less like playing on a computer now these days, and it works really well. Also, you can easily see that the wire that I put in there is above the left atrial appendage, so that is clearly in the superior vein. This is faster with this technique. Also then going for the left atrial appendage, as mentioned before, really the alignment is quite well, but I think this Echo Navigator really having an edge here over other pictures I've seen or even worked as a guest operator in other institutes, for example, for the Siemens 3D imaging. So again, you're quite fast into moving into the LAA. And I thought this to be short and more going on for discussion because we're a little bit behind time. So let me summarize. I think we all agree that an optimal LAA closure is a single device size, a single deployment, which will also always allow us to have less pericardial effusion and other risks, but also to have an optimal closure. We need to avoid device-related traumas by optimal depth and position. I think this is a big issue of the coming years, and it will be interesting to see the new data. I'm convinced that if we all together get our experience with AI-assisted device sizing, different to TAVI, I think it's interesting that in TAVI I'm quite good in navigating the inferior where the annulus is. This is different for the LAA. I think if you do have 3 operators, give a CT and measure where you land, you will have 3 different sizes. And so AI really may assist us here in this problem. And so thank you for your attention.
Thank you, Martin. Excellent talk, and just promoting the discussion. So one of my concerns, it's like, first we need to tell the intelligence, what's just the objective. So for me, it's difficult to know if it's better like a deep device with no leaks, or like a more proximal device with a minor leak. I don't know what's better. And like first we need to teach the artificial intelligence what's the optimal, because we don't agree here, and I think that that's probably so. And Jordi has a question that maybe we need to go. But let me ask Martin, then you go.
Well, this level, for example, working with FEOPS or working with Articore, still leaves you a lot of decision by yourself. You're playing around. It's not that you get a fixed image and the system tells you this is the device you're going to choose. Instead, and rather than playing around yourself with other things, you really have, let's say, a virtual planning, which is much faster, much quicker. It works much better into the workflow. I mean, you don't have time for an hour to sit down before you go on the table. Huh? You want to sit down maybe 10 minutes and then have a final clue on that.
But it would be nice just to have, like something that tells you, this is the best. And
but I agree on your point.
You can get it or not, but and maybe like Jordan, in that sense, maybe it's the answer is flow dynamics. So this is the best because that's the best flow dynamics.
Actually, it was not only in flow dynamics. So first of all, Martin, thanks to be brave for talk about artificial intelligence. But second one, I've learned from you, and I would like to be a little bit provocative. For me, of all the technologies that you have presented now, only Philips use real artificial intelligence. I think that all the thing that you present is okay about pre-planning, about simulation, but not artificial intelligence. And here I agree with Xavi. I think that when you talk about artificial intelligence, it's use a lot of data to speed up processes, to be able not maybe to say, okay, this is the best one, but here you have different suggestions real time because have learned a lot of data. And I think that if we want to talk about artificial intelligence, and this is my last comment, first we need to overcome a lot of problems that, for instance, you guys are finding with the Elaacc registry. I mean, you have a lot of heterogeneous data from different hospitals that they do it differently. How we put these together to learn how we do. For me, this is my opinion on what is artificial intelligence.
I have to say that I didn't dig deep into FEOPS and how they do it, so I'm not too familiar with the technique. Also, I think it's quite useful in using it, but I have a limited experience. Articore is definitely using something that is calculating on its own the central axis, which I think is quite helpful. Because then we talk the system, okay, show me a measurement orthogonal to the central axis. I can just run through it, which is much faster than I could do on a Schemenschu because always the axis is playing. So yeah, where is it just computational work? Where is it artificial intelligence? That's a discussion I fully agree to. And so far, where is this heading? I see some of my younger colleagues to be very skeptical to move forward at all. Huh? We just do it the way we are used to because it's fine in 95% of patients. I think that's not the way forward. I think we should be the driver in this field and obviously to tell the companies that develop these things by also interacting with them, maybe the direction that we think.
Thank you so much, Martin. I mean, I think we all agree that artificial intelligence will have an impact on our future imaging approach. So we move again to a completely different field. And Sergio, to be honest, I have no idea. I have never touched this area, remote proctoring. So please tell us what can be achieved with it, what are the purposes, the objectives.
Thank you, Nina. I want to share with you our experience on remote proctoring. This experience started a couple of years ago when we won an European project in cooperation with the team, Italian company, and with the National Council of Research. And the topic of the task was to be able to demonstrate that high-tech connectivity can be helpful for in the medical use. This is the steps that usually we follow when one center wants to start with a program of LAA closure. We start from internal training, we go ahead with several steps. And usually the pathways is concluded with the on-site proctoring. The proctor follow 4, 5, 6 cases. After that, the proctor say, okay, you're ready. It's time you fly alone. It is a very critical step for the operator because the psychological connection with the proctor is very strong, so the remote proctoring can cover this gap. Really, what is the remote proctoring and remote support? This sentence, when technology guides and expertise connect beyond distance, catch the meaning of the remote proctoring. The remote proctoring is a sharing of experience where the technology is, if important, is a tool. It's based on 3 pillars. The first is to have the availability of a device that must have some requirements, easy to install, certified for the use in the cath lab or in the operating room, completely hand-free, because the exchange of information between the proctor and the operator must be completely independent of the hands. It requires a stable connection with high-speed data transmission at, of course, a remote in the proctor, expert in proctoring and expert with this technology. I want to highlight the technical characteristics of the device. In our experience, we use the smart glasses by Roten's cone. It's important because the concept is that you see through the eyes of a partner. The technical characteristics of the smart glasses are that are completely unfree solution. You see in the in the small screen, the operator see exactly what the proctor see. The proctor can have a visualization, complete visualization of the equipment in cath lab thanks to the mirror R, and you see the region of interest thanks to the panoramic view, and the device allows a full two-way interaction. Basically, the proctor receives 3 lines of information, one from the echo, the angiography, and from the smart glasses, that is a bidirectional exchange of information. So the proctor and the operator see exactly the same things. We conducted our experience with a controlled high-speed data transmission, but recently Italian teams and also Ericsson are able to provide a stable, professional connection. During our experiment, we were able to monitorize all the velocity of and the stability of the connection, the delay, etc. But let's go in cath lab. This is the preparation of the operator. The device does impact with the standard preparation of the operator. And in yellow, you see what the operator and the proctor see. The interaction, you see that I am drawing to the operator my instruction because in this patient was a patient with this hostile septum, so I suggested to delay the septum with a small balloon. The operator is following my instruction. He delayed the septum, and you see that the proctor has under his control the fluoro, echo, and the environment view. Let's move to another procedural step. Now the operator is in the left superior pulmonary vein. I stop the imaging, and okay, you are here. You are in the pulmonary vein. Your appendage is exactly in this position, so you have pulled back the system, a counterclockwise rotation, and you will be in front of the LAA. And this is the phase when the operator is in front of the LAA, okay? This is the LAA, okay? This is your line of advancement of the device. Follow the red line, okay? There are a lot of tools. This is one of the most frequent used. And now another interprocedural step is to define the landing zone. Okay, your landing zone is here. Take care of my line, take care of the marker on the catheter, and this is the line that you have to follow for a correct alignment of the device. And also the interaction with the KIP is easy. This is the interaction with the specialist on the basis of the measurements during the planning and during the interprocedural phase. We discussed what is the optimal device. It's important that the communication, the bidirectional communication, include also the voice, the detailed information, the exchange of for the correct device. And finally, I want to show you the zoom effect. This is the very critical step of the procedure when the operator has to detach the device. Okay, I explained the rate of compression is fine, you can go ahead. My experience and my final conclusion are that the remote proctoring is an alternative, but is not an alternative, but is a natural extension of a current educational strategy. Our committee should be open-minded to new technology and new perspective to education and proctoring, because it provides a real-time support with a more accessible proctor and expert guidance, improved training, making it more flexible and collaborative, and it facilitates a gradual detachment from the proctor. And another very important aspect that we could think to a network where the proctor on demand support the colleagues if they have a complication or if they have to manage very complex cases. Thank you for your attention.
Sergio, fascinating new tool. So when I watched your image, which is real time on the right upper left, on the right upper right panel, if I would have to watch that, I would feel a little bit of dizziness. And if you have an operator, so I just talked to Javi and he said he's moving his head a lot during the interventions. Does this has an impact on the quality of what you see and what you have to comment?
That was a problem with the previous version of the smart glasses. Now they are equipped with a gyroscopic stabilizer, so the distance effect is not so strong, but we have to explain to the operator to avoid to move too fast, to stable view. And it's important that when you speak with the operator, okay, let me see your hand, let me see the device. This is especially important during the device preparation.
Yeah. Sergio, very nice talk. A question, I proctored a few times remotely, but without the features which you show. So these lines which you draw, the operators are seeing these lines and your drawings on their main screen or on some small screen? How it works?
No. When you draw, the operator see immediately what you are doing in the smart glasses. So the smart glasses, okay, yes, reflect exactly what the proctor is doing, and the proctor see what the operator is seeing. So when you want to exchange information, you stop the view, and you can draw or you can write. Usually I prefer to use the pen, the pencil for drawing the different color because it's more intuitive.
Yeah, but anyway, your suggestion is that the center is doing cases with proctor on site, and then for how many cases in your opinion should be done with proctors on site before moving to that remote proctoring?
I think that what we are doing currently, so the proctor on site will remain because the direct contact with the team is important. But one very critical step is when you say, okay, you are ready. The next case is your case. This is a very critical step where the operator is ready, but the psychological link with the proctor is strong.
Yeah, I completely agree because they need. Yeah, Philip, sorry. No, go.
Two short questions. First, the audio connection is sometimes difficult, especially when you're far. So how much you need the audio connection when you have the glasses and all this excellent network and system?
It's a technical problem. The smart glasses, the tools for connecting the echo and the fluoro are wireless. So the main problem could be I had one stupid problem with my administration is to send outside of my center data regarding a patient. But it's exactly the same problem we had when you do a live case. It's exactly the same situation. The second problem is to have a stable bandwidth. Recently, Italian team guaranteed that they have some professional band that you can buy for 2, 3, 4 hours, so it's not particularly expensive. And because the problem is the stability of the connection and the delay between the transmission and the feedback. Basically, with our dedicated band, but that was an experimental band managed by Ericsson, the delay was basically 0, but with the commercial band is close to 0.
Okay, I think that because you had like some very nice questions and we're running out of time, but I will do it the manual way. You know, just I would like to ask you and raise your hands. So who's in favor of remote proctoring, not for the first round of cases, but maybe for a second or third round of cases?
Xavi, it's important to highlight that remote proctoring doesn't replace the proctoring because
exactly.
Yes, it's an integration, is complementary to the yes.
Not replacement for a second stage.
Yeah, exactly.
So I like it.
And also important to create a network for a second opinion.
Yeah, exactly.
For complex cases.
It's for reassuring the operator. Yeah, exactly. Yeah. So let's, who likes?
No, they want to ask.
And who doesn't like?
Xavi, you want to vote? Or?
No, because we're super late, so we need to move on. So Sergio, you stay because we go to the next session and you are moderator in the next.
Sergio, I just hand the micro over, and I think it might be something good for the regions in the world where proctoring access is less favorable. Sergio, you need the mic.
Xavi, you are with me. Okay, we move to the next session. It's a very, very important session because we have to share 5 very interesting cases. This is one of the very important aspects of our community, to share our personal experience. It's something that is not able to find in a paper, in the book, but is our real life. So it's my pleasure to introduce the first speaker, Giuseppe Patti. Giuseppe, oh, thanks.
Good morning, everybody. Thanks, Sergio, for the presentation. And it's a great pleasure for me to share with you my most challenging cases. Thank you for the invitation. And this is a case I performed in my institution, Novara, in northern Italy, together with Sergio, I believe 2 years ago. The patient is a 77-year-old man with a very high CHA2DS2-VASc score, with systemic hypertension, chronic renal failure, and atrial fibrillation from 2 years before the admission. The patient suffered from stroke 2 years before admission. complicated by hemorrhagic transformation, and after LAAC initiation, the patients suffered from an intracranial bleeding 2 months after edoxaban initiation. Echocardiography showed the normal left ventricular ejection fraction, a cauliflower-shaped left atrial appendage, spontaneous echo contrast in the left atrium, no thrombosis, and importantly, you can see that the patient had a membrane in the left atrium. The drainage from caval veins and from pulmonary veins was normal. The patients underwent a first attempt of LAA closure, unsuccessful, and therefore we attempted the second time to close the appendage. You can see the echo images. You can appreciate the membrane dividing the left atrium in a superior part and in an inferior part. The membrane was incomplete with an open portion in the posterior part of the left atrium. CT imaging showing in anterior view and in lateral view the membrane. We performed the procedure with a septal puncture above the membrane at the site of the fossa ovalis. You can see the catheter introducing in the left atrium above the membrane. We used an Agilis 8.5 catheter after the puncture to access the left atrium above the membrane. You can see the angiography through the catheter in the superior part of the left atrium above the membrane, but with this position, we were not able to access directly the appendage. Therefore, we used an extreme flexion of the Agilis catheter. On the left side, you can see a rough scheme, handmade rough scheme of the trajectory of the catheter and of the wire along the posterior left atrial wall, and to positioning the wire in the left atrium. This is upper view, and this is on the left side, lateral view. But at this time, we were not able to advance the Agilis catheter in front of the left anterior appendage. Therefore, we used a mother and child system using the Agilis catheter and a 6 French multipurpose catheter and a stiff wire inside the left ventricle to reinforce the system and stabilize the catheters. Then it was crucial to perform a counterwise rotation of the catheter to advance it forward and anterior in front of the left atrial appendage ostium inside the inferior part of the left atrium. This is the echo image with the catheter in front of the left atrial appendage ostium. We performed the angiography inferior to the membrane, below the membrane, and we selected the origin of the left atrial appendage. With the pigtail catheter, we directly accessed from the inferior part of the membrane in the left atrium, we accessed the appendage. With a stiff wire, we advanced the delivery sheet with the stiff wire looped into the appendage. Therefore, the procedure was smooth. We performed the measurement of the landing zone, 18 millimeters and 19 millimeters confirmed by echo. We selected the Amulet device 22 millimeters. We performed the device deployment and the release of the device. You can see these echo images, and this is the final release. Dear colleagues, in my opinion, key points of this clinical case is it's very important a comprehensive integrated left atrial assessment by cardiac CT and TE echo in patients complicated as we encountered in this case. It's important pre-procedural simulation of angiography projection based on CT reconstruction. We used a steerable catheter to facilitate the navigation within the left atrium and used a strong system with a mother and child catheters and a super stiff gyre to access the left atrial appendage occlusion. Thank you very much for your attention. In this slide are summarized possible key questions, and although I don't know if we have time to address these
it's
issues.
Very nice. So we don't have that much time, but at least one question, and if not, I will do it. So do you have any question? Yeah, sorry.
I guess the diagnosis here is core triatriatum. Is that correctly understood, with the extra membrane and a fenestration in the membrane? Yeah. And secondly, it looked like your transeptal puncture was very high, but that was maybe because you wanted to go on the superior side of the membrane.
We first attempted to perform an inferior puncture, but we were not able to access the left atrium below the membrane.
Yes, Erik, when I discussed the case with Giuseppe, the problem is that in this case the membrane in the anterior position is between the superior with the superior vena, pulmonary vein, and the inferior in the inferior chamber where the LAA. So, but toward the septum was a continuous. Toward the septum, there was a hole close to the posterior vein. So we did exactly the opposite to what we do. We go posterior, we enter in the hole, we go in we went in the second camera, in the inferior camera, and then we moving ahead. This is an extreme meanings of what is the pre-procedural planning.
So we have a last question from Professor Tondo.
Giuseppe, wonderful case. I mean, just learn a lot. Actually, even the surgical approach could be not really easy to do. Maybe someone can raise the question: why don't you think the lariat? But even with the lariat, even the actual, lariat probably could be just quite, difficult just to use it. So I think that is a great way just to do it.
Thank you, Giuseppe. This is the first time that I see a case like that, so congrats.
Thank you.
And we move to the next one. Dr. Luis Nombela from Hospital Clínic of Madrid will present another challenging case.
So thank
you very much for the invitation. I don't know if it's the most challenging, but ones that I look for it. When I was preparing the case, we were doing this case like 2 months ago, and I say, okay, this might be a good case for the meeting with an Elaacc 4, but a very contractile appendage and asymmetrical shape of the osteum and the landing. But finally, we closed it directly with only one attempt, so I couldn't get this to present it. So then I review all the cases and check the time that we were doing. Most of them are combined procedures, and some that I had to change the device, but at the end I have these difficulties also to cannulate the appendage. So I choose this case, which was an 81-year-old female with anemia problems, a previous David procedure for an aortic stenosis, and also a TAVI that it was done in another centers. Unfortunately, we didn't have the pre-CT TAVI, so we screened the patient with the TE, and you can see here the morphology of the appendage, a chicken wing with an osteum with a landing zone of 16 by 17. So we were in between the 22 and the 25 amulet device. This was the beginning of the case. So we did the transeptal puncture in an inferior and posterior way. We thought by the 3D TE that it was good, that the septum, the trajectory was fine in that view. So we continue with the procedure, and we saw this smoking at the end of the appendage. So because of this, so we were thinking about this smoke at the end. So we changed to place a sentinel device, and then it was very when we advanced the sheath after placing the wire in the superior vena. Pulmonary vein, we were struggling to engage the appendage. We tried with pigtail, multipurpose GR, and we couldn't get insight into the appendage. So we moved the regular sheath to the steerable sheath, and after this, you can see here the wire in the superior vena cava, and then in the pulmonary vein, and the pigtail in the appendage, and at least we engaged the appendage. And when we were trying to advance the steerable sheath, at that time we had available this sheath. You can see that how we didn't have any support of to advance it. So we placed 2 pigtails with the wire inside to give more support to the system. But again, also when we were trying to move it, it jumped, so we couldn't engage the appendage. So probably we need steering more at the base of this catheter or close to this transeptal puncture. So we step down and we move again. We leave a stiff wire in the appendage. We don't usually do this because we are changing the pulmonary vein, but in this case we change the steerable sheath with the regular amulet sheath, and we exchange that in the appendage. And finally, after 35 minutes of fluoro, we have the sheath in the appendage. So we thought that it was the amulet 22, it was going to be fine, but as you can see here, the coaxiality of our sheath was not good. We would like to have this coaxiality, and this is where we have measured for the 22, but our seed was going that way, so we have a very a leak in that zone. So we had to exchange the to change the device for a 25, a bigger device, and to do a sandwich technique for this appendage. And well, finally we did the tag test. The device was stable, and you will see when we release the device that the coaxiality of the catheter was not good. Finally, the disc covered this lower part of the appendage, and we succeed to close. We did a CT analysis for in the follow-up to see if the closure was good. As you can see here, the transeptal puncture was quite inferior, but it was not very coaxial with the axis of the appendage, which was that, and probably well, we couldn't get, or at least in that image, in the procedural planning, probably with a CT, we could have planned this procedure and get a better image of that. So I think that the embolic protection devices, in some cases, they can be useful, or at least to better feel for the operator if you have any complication. In this case, the stable seat helped to engage the LAA distal, but then the softer standard seat was useful to advance the delivery seats into the LAA closure. As I will mention also, how can preprocedural imaging better predict these cases? Probably CT better than TE, which is, for me, it's difficult to orientate or to get this coaxiality from the TE. And also I think that sometimes eyes can see or can guide you better to get a very inferior puncture than TE. I don't know if these are the open questions that I have for the discussion. Thank you very much.
Thank you, Luis. Erik.
Thank you for presenting this very difficult case. I think it is nice to see that, you know, the Elaacc score, one of the complexity parameters is low takeoff of the LAA, and that is what you had here in this case. And I think even your transeptal puncture here was very inferior and very nice, and I think it would be difficult to do it much differently, the transeptal puncture. So this is just a very difficult anatomy, and I'm sure that a steerable sheet could help and can help us in some of those cases. But nice to see the Elaacc score in action here.
Actually, Luis, can we go back to the presentation and calculate the Elaacc score in that appendage? That would be nice. I don't know, Laura, if you want to do it, the Elaacc, because I'm... So can we go back to the presentation and, you know, the echo? The other thing that I would like just to ask you, Luis, it's just, and also Marek, because it's related to the steerable catheters. My feeling is that in most of the cases, the steerability, of course, you know, for fine tuning, not, but when you really need it, it's because the transeptal, you know, it's too high. And sometimes you cannot go lower because there's no fossa and you don't want to force. So if you would like, you know, to have, you know, a steerable catheter that can turn, you know, at the tip or can turn, you know, of course, you know, both would be the better, or can turn at the level of the septum, what would you choose?
Well, for this case, that's what I was
Not for
saying.
this case, I mean for in general, because I think that if you get, you know, just a low access, you know, just with the curve, with the standard curve, you can, you know.
Yeah, I think that if they can correct the transeptal puncture, I think maybe it would be better, but because then the tip you can correct it with your rotation. Yeah.
Okay, Laura, can you?
Xavi?
Yeah. Or
no, just a question. When you have so much difficulty to enter the appendage, probably because of the low position, I wonder sometimes if a more anterior puncture is not more useful. And the second thing, do you check sometimes for the position? Because sometimes you think that you're inferior, but when you puncture, you're higher than what you think because it moved from any reason. Sometimes going for just a new transeptal puncture can make you gain a lot of time. Although in this case, probably it will have not
Yeah,
make
we
a
thought
difference.
about that, but because we reviewed the level of the puncture, then we saw that it was inferior, but maybe moving to more anterior, but also the appendage was quite anterior, and the chicken wing was also anterior. So.
But the good message is always to check, because you think you're inferior, but sometimes you're really higher than what you think.
No, regarding the LAAC classification, at least it will be a 2 because it's extremely bent. We don't know about contractility and also the low takeoff of the ostium. We don't have here the relation with the mitral, but probably it's also a low takeoff. So
between 2 and 3, eh?
Yeah.
Okay, so just so maybe the problem here it's what you were saying yesterday. It's the axis of the transeptal that here it's making things difficult.
I think that the point is that, in my personal experience, a good steerable catheter can't compensate and not correct transeptal puncture because the alignment is mainly due to the position of the transeptal puncture. So the message in our community should be, okay, take care and take your time for doing a correct position of the needle when you do the transeptal puncture. This is essential.
Okay, thank you, Luis.
Okay. Okay, we move to the next case. Laura? Okay. I suppose from the title I cannot close this LAA. This is a very complex case, I suppose.
Okay, so if I can have the slide. So this is a very recent case that we made with Xavi in the hospital, and we think that have several points that we can discuss. So this was a female, 64 years old, smoker, hypertension, HFpEF, persistent AF, and the indication was GI bleeding with chronic anemia. But let's move to the anatomy. That probably is the most important thing. This is the echo that we made in the cath lab, and for these patients we didn't have any previous planning, so it was the first look at the appendage. So we made the intervention with the patient with the mini TE. The patient was only with some anxiolysis. She was awake, and this is the images that we get. So I was thinking, okay, I think this appendage, it looks quite small, but I don't know if maybe there is any lobe or any bending that we are not seeing. Also with the 3D just on face, it looks quite small. So we just opened the 3D just to make the measurements and also to make some rotations just to be sure that it's not a chicken wing that is hiding any way. And in these first measurements, we found that the landing zone was 11 by 17, so extremely small, with a working depth of 8 millimeters. So I was telling Xavi, I don't know if maybe we can close or not this appendage, because it's a very difficult appendage. If we review the Elaacc score, it has a long pulmonary reach, also high eccentricity. Just I go back, you can see there in the landing zone that was quite oval. We also have a short depth of working depth, and also was a hypercontractile appendage. So it's an Elaacc 4 that in our experience is not so common. So this is a very difficult appendage. And what regarding devices that we can use for closing this appendage? So in our hospital, we have these 3 devices just available in the hospital. Because of that, sometimes we do the screening just in the table. And for the majority of patients, we can find a device that can fit our patient. But if we look here in all the tables, there was none of that devices that can fit this very small appendage. So we were thinking, okay, we need to stop here the intervention or not. But just because it was a very contractile appendage, we thought just go with the transeptal and just have a look also to the pressure of the left atrium. So we went with the transeptal, and we don't use 3D for transeptal, but also was quite challenging just to obtain a direct view of the fossa to do the biplane for the standard transeptal puncture. So we made also the transeptal puncture with 3D, so it's inverted because short axis is on the left in the bottom, and bicaval view is in the right, but we can have a very inferior transeptal and quite posterior side of puncture. And also, because this appendage was so uncommon, we decided to also do an angio, just to be sure that there is no anything else. And you can see here that the appendage, it is what it is, what we were seeing in the 3D, so the correlation was quite good. It was only that very small lobe that was going up, but nothing else. So we make the measurements of the left atrial pressure. And we found that the left atrial pressure was 6 millimeters of mercury. So we just add, half a liter of serum, and the final left atrial pressure was 12 millimeters. So we repeat the measurements at that moment. And these are the measurements after the liquid infusion, and now we have a landing zone of 13 by 8 millimeters. So with this landing zone, we can fit there a small amulet of 16 device. So here is the implantation that also was not so easy. The transeptal puncture, I will say that was quite good, but let's see if it's moving. Yes. You can see here that we just advanced the catheter inside the appendage. We were opening the lobe in the triangle conformation in the middle, but when we open it, you see there that in the bottom right, that is like a 135 degrees view of the appendage, but just coaxial to the 60 degrees, you can see there that the lobe was just turned. Okay, so we just try again, and here what we made is that Xavi was pushing a lot with the triangle conformation just to make room to accommodate the lobe. And you see here in the middle how the lobe is totally open and it's well sit inside the appendage, and there you can see that we were covering everything with this quite nicely. So, because it was so contractile and we have this initial problem with the positioning, we just make a quite, I will say, aggressive tube test just to be sure that everything was fine. And here you can see in the echo how Xavi was pulling. So we decided, okay, we just release the device. And this is with the device release. And this is quite scary for me when I saw it because it was not attached, because it looks like it's floating. But you saw at the end of the imaging that suddenly it changed the position. This is with the cable attached. You see there at the end, plop. So it changed from this scary position to a quite nice one, and the end was quite nice fitting of the device. This is the final result. And we were quite happy with the result in this quite challenging anatomy that we didn't know if it was possible or not to close. So, as case learnings, I will say that if we have a small hypercontractile left atrial appendage, the measurement of the left atrial pressure is super important. You see here how it changed to an appendage that was not possible to close to an appendage that was doable. And if you have a very short depth, I think it's quite interesting, the triangle position of the amulet, just to push and try to accommodate the device. And also, my concern in this case was the aggressive pull test that we made, that at the end I think that the appendage was invaginated and just accommodate at the end and just maintain this positioning. And that's it.
Yeah, I don't know if there is any question or comment.
Just before the session before, we talked about the amulet 2, that you should maybe oversize more to cover the anatomical. So I think this is a typical case when you have this prominent ridge like this, you don't see exactly where is the ostium. So really you have to rely on the circ. The circ is your marker, and the lobe must be placed distant to the circ, otherwise you get an embolization for sure. So that's what you did actually, but this is a typical case when you should focus more on securing the lobe somewhere in a good position than be obsessed about the ridge.
Well, but in this case it was impossible to cover.
Even not to be true,
Yeah.
the safe position.
But it was not just for covering, it was just for safety, because, you know, like the appendage was so extreme that I was concerned that it was not, you know, like just stable. Here, you know, of course, you know, amulet 360 would have worked much better. But remember that the implantation depth was 8. So this feature about, you know, this device that you can push and you can create maybe 2 or 3 millimeters, those extra 3 millimeters, by pushing, you know, the wall of the appendage, they can, you know, make the case possible or not. So with amulet, it was with a triangle. Now with, you know, amulet 360, it will be, you know, more, you know, but there's no distal pin, so I mean, it will be safer.
Xavi and Laura, can I ask you, because I have a problem, if there is such a small appendage, such much contracting so much, I have always a problem in my mind with the amulet with large hooks, because I always afraid that if the appendage is contracting so much, these let's say, long hooks may perforate. Is it, am I thinking?
I think that, like it might make sense, again with the second generation, I hope that it doesn't, like the risk is going to be minimized. But anyway, in this case, the pulmonary artery was just really, not close. This is something that you can measure. If it's less than 1 millimeter, I mean, you might think of. But in this specific case, no problem at all. The patient was discharged and, we did the control 3 months later and nothing happened.
Just a question for both. If you had a CT scan for the planning, the situation.
Yeah, I think it's a good question because with the scanner, we don't know if the patient was, in theory, they are not fasting, but maybe if we made the scan in summer, patient can be dehydrated and we can have this very small appendage and thinking that it's not possible to closure. The nice thing of using the 3D during the implantation is that you can check this landing zone and the measurement, and also you can recheck after the proper left atrial pressure. So you ensure exactly what is the real landing zone of this appendage. But I think that especially if you have a hypercontractile appendage, you always need to make the measurement of the left atrial pressure and again to make the measurements. Because,
what was the pressure in the left atrium at the time?
It was 6 and then was 12.
Yeah. Just last question, please.
So if you had a CT, don't you think you would have got the correct measurements? But when you give fluids and you make artificial measurements, you make it bigger, but when the left atrial pressure may go down, and then it might become smaller, isn't it?
Well, the thing is that a healthy appendage, that because of that I'm so concerned with the healthy patients, is that one of the properties is that it changes a lot the dimensions with the fluid, intravascular fluids of the patients. But the thing is that you need to be sure that the patient is euvolemic, and sometimes when they go to the cath lab, they are hypovolemic because they are fasting from the day before. And also you need to also have into account if it's very hot outside, in patients that came from a house or something like that. But at the end, if the appendage it's the size that we make the measurements with the euvolemic patient, I think it's not a problem if it reduces the volume inside the pressure inside the atrium, because at the end it's like a elastic thing that that the distension is that size. So I'm not concerned about that.
So what I'm saying is CT would have given you the correct size. I don't think CT will undersize it.
Yeah.
Okay, thanks, Laura. And we move to the next speaker. Fabian Niel-Dispatch will present us another challenging case of a giant LAA. Thanks.
Thank you very much. I have to change the title a bit. It's not multiple devices to close a giant LAA. It is just 2 devices to close an LAA. I show you 3 examples where 2 devices were necessary. I have to disclose that I did a few Watchman and lumbar and ultraseal cardiac cases. Then I actually switched to just amulet alone. Not because I didn't like the other ones, but because I felt that I can close all LAAs just with 1 device. But I have to disclose that maybe for some cases, lumbar users would say that their multiple lobes LAA, the lower ones where they have small lobes but huge discs, would have solved the problem. So I think that could be a solution in these cases. So first case is really giant LAA. This is a case that I did in my former institution, so I don't really have all the videos available. But you can see this patient had previous mitral valve surgery and had severe recurrent mitral regurgitation and had this giant LAA. So here you can already see on the right-hand side that there is a small lobe next to the other lobe. So this was at the time of ACP, not amulet. I put in the biggest amulet, and then you can see there was a small lobe still uncovered where I put in a second device. I apologize that I don't have more images, but this is one indication for putting 2 devices if you have a giant LAA. I think there is also another indication where you have no neck and 2 lobes. And this is a case that was combined with a mitral clip. And you can see, first of all, that the puncture is not ideal. It's a high puncture. It's the puncture we used for the mitral clip. But if you manage to steer your catheter such that you get into the lobes, you can see that there are 2 lobes, one a bit further anterior and one more posterior. So I closed the one more posterior because the sheath was fitting in more easily. And I don't really recall why we stopped here and wanted to bring back the patient another time, which was a mistake, and I will come back to that later. But maybe it was also because of some people were saying that we used enough devices for the hospital in one setting, and they were not happy to use a second LAA occluder. I don't recall that, but unfortunately, the patient didn't want to come back for the second procedure, so this left atrial appendage was left as it was, and the patient is still in oral anticoagulation. Now, this is another case. It was done combined with TAVI, and you can see that it's again the same anatomy, no neck and double lobe LAA. So I always just go into the lobe where I get into first, and I put in an 18 millimeter amulet, and then I steered a bit more anterior. I got into the more anterior, posterior lobe and put in a 16 millimeter amulet, as you can see here, and this is how it looked at the end. So I think there are some procedural decisions you need to take if you put in more devices. The first decision is whether you want to do a one-stop shop or whether you want to do it staged. I showed you why you probably shouldn't stage the procedure, but I could see 2 reasons why you would stage it. Maybe there are 3 reasons. One is a financial reason, if you have a big pressure from your hospital administration. The other reason would be if you're in doubt if the first device is really stable, you don't want to manipulate more in that area, you want to grow it in, and you bring back the patient maybe a month later. Or in case of severe kidney disease, talking about a GFR of 15 or something, and you already used enough contrast for the first device. The other procedural decision is, do you use one delivery system? That's my standard. I actually never did it differently. But if you want to use 2 delivery systems and deploy them either simultaneously or serially, you also need to decide, do you want to do 2 transeptal punctures or just 1 transeptal puncture? I really don't see an indication for this. I think it makes the procedure more complicated than needed. And then the last question would be, you have post-procedural anticoagulation. Would you just go with the same post-procedural anticoagulation, whether you have 2 devices in place or 1 device in place? You go for DAPT or you go for something else. I choose just to go for aspirin as with all the other devices. Well, this was a very short excursion to double device closure. I think it's something that you really need very rarely. And yeah, maybe people who have experience with lumbar, I would be keen to learn how they would have managed this case with the double lobe. Thank you.
Thank you, Fabian. We have a comment, question?
Just a comment. Just I refer to the first case. I think this is a really good example when the surgeon, didn't finish his work. I mean, just that there's a really big appendage. There's a cardiac surgery. and the stroke risk is really high, so cut off the appendage and that's it.
I fully agree. I'm not so sure whether the stroke risk actually is high in such a huge appendage, whether it's higher or not. Somehow, if the appendage grows, it just becomes part of the left atrium. And it wasn't very trabeculated, but I 100% agree with you. It belongs cut out during the surgery.
Fabian, nice cases. Just quick comment about lumbre. I mean, as you know, there are the special lumbre, so you can have this with a small umbrella and a big disc. So in some cases, you can use this type of devices. And also, we publish a short series with double lumbre. What is nice of lumbre is because you don't have the lobe, you have the umbrella. We try to use two devices at the same time, so simultaneous, two transeptals, so one to go posterior, another one to go anterior, and you are able to deploy the umbrella and know the disc. So before releasing the device, you are able to know if you have nice result or not. When you decide to do it sequentially, sometimes it's not so easy to get into that other lobe that you have not covered. So it's another possibility.
So you would still use two devices even if you use lumbre. So then there is really not a huge advantage. I was always concerned if you would use the one with the small lobe and the big disc, then you fully rely on the disc to close the second appendage, which the second lobe, it doesn't really seem so
of course, it depends on the anatomy. Probably the first case you saw, you are able to do it with the special lumbre. Probably the second that you saw is not so easy because they are far away. So in that case, probably you can try to use just one special device, and in case that you cannot do it, you do a second transeptal and you use two devices at the same time.
Okay. Laurent?
Thank you, Fabian. It's a nice approach for bilobar anatomy. The only thing we usually do is we keep the cable attached to the first one so that the disc is not out already, just to guarantee stability of the first one. And the second comment is in the last 10 cases we did, we had 30% pericarditis, so you need to be aware that the risk is probably a bit higher, and you just give them colchicine on the way.
Tom?
I just wanted to ask, in these, if you plan to do double devices, do you think there's an argument to be made for plug-style devices rather than lobe and disc devices to avoid interactions, or do you think it doesn't matter? And I mean, clearly you are successful with the disc designs. Do you worry about disc interaction, and do you care which one sits on top of which one, or do you just put them as they go?
Well, I have, let's say, maybe a more pragmatic approach to LAA closure than many people do. So this always is for me a surprise if I find it during the procedure. I don't do pre-procedural planning. So if I see this, then I always do it again in a pragmatic way. I just close the lobe that I get in first, that I think where you just land with your sheath, and then you approach the second lobe, which is actually never really a problem. It's really either you turn counterclock or clock, and then you're in the second lobe. So with regards to interaction of the two, I think there may be cases where this becomes a concern. I didn't encounter one so far. I think the main concern could be tissue overgrowth, right? And that's why I think maybe if the patient tolerates dual antiplatelets, then I would maybe put these patients on dual antiplatelets, whereas usually I would just use aspirin alone. But yeah.
Tom, do you have a question? No. Okay.
Okay. Thank you.
Thanks so much. We move to the last presentations. I invite Domenico Della Rocca, a large PDL requiring percutaneous closure.
So, good morning, ladies and gentlemen, and thank you for being here, and thank you to the scientific committee for the kind invitation. So I slightly changed the title of the presentation because I want to talk about a clinical entity that is very clinically relevant to me, and irrespective of the size of the leak, and this is the fabric edge leak. So what is a fabric edge leak? It is a leak that results from a misalignment of the appendage with of the device with the appendage. And so what happened, basically the frame of the device is not completely, that is exposed to the blood pool, is not completely covered by the fabric, and that's the result. So it's like a leak that even if it's like 2 or 3 millimeter involves like a big part of the device, and also why is clinically relevant? For two main reasons. First of all, because there is significant residual flow, but also turbulence. And second of all, because there is no coverage of the device, of a part of the device by the fabric, and so this device will never completely endothelialize. And so this is the case that I want to present. I want to thank Rodney Orton for this. I had the privilege of working with him for many years, and he is the brain and the hands of the majority of these cases. So this is like an 81-year-old male with hypertension, coronary artery disease, and pulmonary hypertension who had a stroke and underwent a Watchman flex implantation, 24 millimeter flex implantation. And so this is the baseline. Sorry, I don't know why it's not. The second image doesn't. But so the device here is, as you can see already at baseline, the position of the device is not optimal, so probably it's a little bit oversized, this proximal, but then, there it is, okay. So we have already some shoulder on the mitral side, and then 45 days later, we have this device that already seems a little bit rotated. And then on T, you can see that there is a fabric that is not completely covering the frame of the device with a significant leak. So here, like if you rely on the size of the leak, this leak is probably 2-3 millimeter, but then still, as we said, like the flow is significant inside the appendage, and there is no thrombus inside the appendage. So these are other images. And so here you can see at the base, we are approaching with a kind of multi-purpose catheter from the base of the appendage to enter inside between the fabric and the tissue and the appendage os, and then here like first angio, so you can see like full. Like completely empty appendage, maybe some thrombus here, and also with the turbulence that this leak creates, that these patients have high risk of thromboembolism. And then so we use coils and an Amplatzer vascular plug 12/9. And so this is the final result. So first of all, we took care of filling the appendage and beyond the device with coils, and then we placed the Amplatzer here. So first of all, we obliterated, we occluded the appendage, and then we took care of covering the fabric that was exposed to the blood pool, the frame, the nitinol frame that was exposed to the blood pool in order to promote endothelialization in the long term. And this is the acute result. So you can see here the device. If we change the projection, the device that is on the side of the appendage, and this is the follow-up. So the appendage is occluded, there is no residual flow, and this is the device that we implanted. So this is like a little bit of a workflow that I put together in order to a kind of decision-making for the device leaks of different sizes. But then I want to underline this part that is, so the intermediate peri-device leaks, 3 to 5 millimeters, there are some sizes and some features that need further evaluation and eventually oral anticoagulation reinitiation. And this is another case that we had, and I would like to see if there is a chance for a discussion about this patient, because this is another patient that we had, and the leak is small, so the operator who did this device stopped anticoagulation, and the patient had a thromboembolic event 2 months later. Thank you.
Thank you, Domenico. To understand the mechanism of the PDL is essential for deciding for the right strategy. Question from the audience? Claudio.
Yes. Nice, Domenico. Maybe you can mention also for those who are not electrophysiologists the use of radiofrequency, just to close up some small leaks. This is something that it could be considered that just an option.
Yes. So we published like a few years ago, especially for borderline appendages, borderline leaks, so 3 to 5 millimeters, in patients who were planned for an ablation after appendage closure. You can target the appendage side in order to promote like shrinkage of the tissue, like fibrotic shrinkage of the tissue, and then we saw that we are quite effective in closing like these borderline leaks also. So like if you have a patient with some borderline leak, like not talking about like uncovered lobes or other things, but like leaks, and the patient is planned for a redo procedure, I think it might be an option for that.
Yeah. One second, there is Laurent and Fabian. Oh, Fabian.
Thank you very much. This was a brilliant case where you closed the leak. My question is, why did you put in the Amplatzer device? Wouldn't it be enough just to close the appendage with the coils, and thereby you clot the entire space, and it cannot provoke any further clotting there, or?
Yeah, so that's the tricky part of like the fabric edge leaks. So in this case, you see that you have the nitinol frame that is not covered by the fabric. So that part is never going to endothelialize. So you still have a certain degree of DRT because of that. And the reason why we decided to put an Amplatzer is just to promote DRT endothelialization of that part. So not only have an obliteration of the appendage, so we took part of the thromboembolic risk, but also put like an Amplatzer in order to promote endothelialization on that part of the appendage.
How many months after the first procedure was it done?
So in this case, we generally wait at least 6 months. But for this kind of appendages, there is like a very, very limited change. So I think, like especially if the patient has a thromboembolic event, we tend to intervene sooner. So in this case, I think was within the 6 months, but generally for other kind of leaks, we wait for at least 6 months, because there are also these longitudinal studies showing that there is a reduction of the leak in the long term.
And why the vascular plug 2? I mean, you need a way bigger sheath. Wouldn't it be wise to use the vascular plug 4, where you can go just with the diagnostic for French catheter? Wouldn't that be safer, instead of wiggling a big sheath next to the device? I've no experience, I'm just asking.
But, so the first step was getting inside the device, because then like that's the first part that you need to get to put coils there. If you just plug outside, and then there is still some risk that you are leaving something behind, and so there is still some risk of a flow. So with the rotation, you have like a big part of the device that is exposed to the blood pool. So sometimes you don't cover enough of this fabric, of this frame. So you need to first get inside, put the coils to obliterate the appendage, and then, so that's why like was a step-by-step approach, and we were already there, and that's why we decided for a.
Okay, Jens-Erik.
Thank you. We also published a series of this fabric edge leak, and what we did the cases guided by ICE, had either just a transeptal sheet or a steerable sheet, and inside that 8-French coronary guide catheter. And that takes up to a 16 or 18 millimeter AVP2, and we only put the AVP2, the distal disc and the middle waist inside the intra-device space of the flex device, and then had the outer disc covering the entry to the sub-fabric or the edge. And in the series we had, we got complete closure just by using the AVP2 itself without using the coils. So I think it works pretty well. And it's thanks for showing the case, because I think it's one of the most frequent mechanisms for leak with the flex device. And again, also, yeah, you could say this is a small leak, 3 millimeters, but you see the flow washing in and out all the time, and it will never close. And I think it's something we need to, we cannot leave those types of...
But I think, so I chose this leak because I remember last year when I did my presentation on leaks, we had this discussion on what would you definitely close, and I think this is the leak that I would definitely either recontinue, like not discontinue anticoagulation, or close in case there is a possibility.
Yeah, Adele, last question, please.
That was my question. So, how do you state that it's a significant leak? Okay, I understand it's a very interesting mechanism, and I see it more and more when I retrospectively analyze some of my cases. But sometimes CT, even small, small frame not covered can give LA patency, but difficult to quantify if it's significant or not. So, as Erik said, it can be relatively common. So the question is always where to go for it.
So, but then, like, if you look at the effect of the leak on the appendage, so if you see those appendages are completely empty. So, if you consider the effect of the leak on like thrombus formation inside the appendage, sometimes as you see that there is like 3-4 millimeter, there is some thrombus, then it evolves, then you see that it's obliterated, and so like that's worth waiting. But for this kind of leaks, you never see really thrombus formation, and you actually see even with 2-3 millimeters, like a significant flow with turbulence, and I think that's a way to say, okay, this is a failure of the occlusion somehow.
Domenico, I mean, it's easy to follow your ideas, and I agree, but do you have any data that a fabric edge leak is really more dangerous than a side gap leak?
We don't have data because it's something that, so we have this large series that should come out soon in Jockey P, and we have 300 appendage closure, like leak closures that we compare with patients with a closure at the baseline, and we have a higher risk of thromboembolic events. And unfortunately, like it's kind of a heterogeneous population. So we have fabric leaks, we have traditional, we have uncovered lobes. It's hard to correlate directly this with a possible risk. But if I see the effect on the appendage compared to other leaks, I say also like in terms of DRT, like you have a nitinol frame that is never going to industrialize in that point. So potentially, based on what we know, there is a higher risk of DRT also in this patient. So maybe the thromboembolic event is not strictly related to the leak and the thrombus moved from the appendage, but rather some thrombus forming at the interface with the nitinol frame and the appendage. So like there are all the components that are associated with a higher risk of thromboembolic events in these patients.
Okay, and please, quick question, quick answer, and we need to go to lunch, okay?
So just a quick question, these leaks, do you only notice after 45 days, or did you notice at the stage of the implant, or could you have done something differently on the day? Or is it because the device rotated, or is it...
That's, I think, like probably 90% of the leaks can be prevented at the time of implant. So I think the most important message here is like if something doesn't convince you, like try again. Even like try again with another transeptal, because one cause of this leak is that you have a high transeptal, and so you are rotated compared to the axis of the appendage, and so the inferior part is kind of like coming out. I think it's important in these that there is a nice collaboration with the imaging support, because this is something that you see going from 125 and above. Or like if you have eyes, take some time to do a transmitral view, that is where you see it. But then definitely if I see the implanted baseline, definitely that was a suboptimal implant.
Okay, thank you, Domenico. One thing that is important, before lunch, we're going to take, a photo group. Okay, so don't leave, just to check out. So stay, it's just very quick, 5 minutes in the lunch area. So we have lunch and we meet again, sharp at 2 p.m. Please. Thank you. Thank you to everyone.
Thank you, everyone.
You know that I won't be untrue. You know that I won't be a liar if I was to say to you, boy, oh, we couldn't get much higher. Come on, baby, light my fire. Come on, baby, light my fire. Try to set the night on fire. Try to set the night on fire. The time to hesitate is through. No time to wallow in the mud. Try now, we can only lose. And our love becomes a funeral pyre. Come on, baby, light my fire. Come on, baby, light my fire. Come on, baby, light my fire. Try to set the night on fire. On fire. The time to hesitate is through. No time to wallow in the mud. Try now, we can only lose. And our love become a funeral fire. Come on, baby, light my fire. Come on, baby, light my fire. Try to get this night on fire. Try to get this night on fire. Fire. Come on, baby, light my fire. Come on, baby, light my fire. Light it up my fire. Come on, baby. Come on, baby, light my fire. Won't you give me so much higher? Light my I can see you're disappointed by the way you look at me, and I'm sorry that I'm not the woman you thought I'd be. Yes, I've made my mistakes, but listen and understand, my mistakes are no worse than yours, just because I'm a woman. So when you look at me, don't feel sorry for yourself. Just think of all the shame you might have brought somebody else. Just let me tell you this, then we'll both know where we stand. My mistakes are no worse than yours, just because I'm a woman. Now a man will take a good girl and he'll ruin her reputation, but when he wants to marry, well, that's a different situation. He'll just walk off and leave her to do the best she can, while he looks for an angel to wear his wedding band. Now I know that I'm no angel, if that's what you thought you'd found. I was just the victim of a man that let me down. Yes, I've made my mistakes, but listen and understand, my mistakes are no worse than yours, just because I'm a woman. No, my mistakes are no worse than yours, just because I'm a woman.
Arms around, I got a fever that's so hard Everybody's got the fever. That is something we all know. Fever is such a new thing. A fever started long ago. Romeo loves Juliet. Juliet, she felt the same. When she put her arms around her, he said, Julie, baby, you're to blame. You give me fever. When the kisses, fever when you hold me tight. Fever. Here's the point that I have made. The cramps are born to give you fever. Be it Fahrenheit or centigrade, we give you fever. When we rock you, fever till you live and learn. Fever till you sizzle. But what a lovely way to burn. What a lovely way to burn. Oh, 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 what a lovely way to burn.
is here. He is her. She is here. He is her. Change the way the world might be. He is her. She is her. He is he. She is he. He is her. Change the world and end all fear. He is her. She is here. Change the world and end all fear. Put yourself in final gear. He is her. She is here. Turn the wheel. And this way steer. She is here and he is her. Identity does not exist. She is here and he is her. Hidden in a lost world's mist. She is here and he is here. Embrace the future with a kiss. Kissed, turn the wheel, and this way steer. End all gender, mist, kiss, mist of a jungle. Nothing short of a total gender. Nothing short of a total gender.
We met in the springtime when blossoms unfold. The pastures were green and the meadows were gold. Our love was in flower as summer grew on. Her love, like the leaves, now have withered and gone. The roses have faded, there's frost at my door. The birds in the morning don't sing anymore. The grass in the valley is starting to die, and out in the darkness the whippoorwills cry. Alone and forsaken by fate and by man, oh Lord, if you hear me, please hold my hand. Oh, please understand. Oh, where has she gone to? Oh, where can she be? She may have forsaken some other like me. She promised to honor, to love and obey. Each vow was a plaything that she threw away. The darkness is falling, the sky has turned gray. A hound in the distance is starting to bay. I wonder what she's thinking of, forsaken, forgotten, without any love. Alone and forsaken by fate and by man, oh Lord, if you hear me, please hold my hand. Oh, please understand.
I feel for you, baby, like a bomb. Now my love that started with a look. I fell for you, baby, like a bomb. Now my love's gone up in flames. My head is full of smoke, heart full of pain. That tender love is gone, gone up in flames. You should have shot me, baby. My life is done. You could have shot me, baby. Shot me with a gun. I hear those sirens scream my name.
for my family. We're hungry, beware of our appetite. Distant drums bringing news of a kill tonight. The kill which I share with my passengers. We take our fill, take our fill, take our fill. I stand firm for our soil. Liquor I come forth, and they juice me, seduce me, dress me up in stitsy. Confused by different memories, details of Asian remedies, conversations of what's become of enemies. My brain thinks bomb-like, so I listen. He's a calm type as I grow.
Just a kiss, just a kiss. I have lived just for this. I can't explain why I've become Miss Chatelaine. Just a smile, just a smile. Hold me captive just a while. I can't explain why I've become Miss Chatelaine. Every time your eyes meet mine, clouds of calm burst into sunshine. And just a sigh, just a sigh. Words, my love, just reply. I can't explain why I've become Miss Chatelaine. Miss Chatelaine. Just a smile, a smile, hold me captive just a while. I can't explain why I've become Miss Chatelaine. Every time your eyes meet mine, clouds of warmth
restless heart would never want to roam. I've never been loved the way you love me.
We make a voting of the best one, and that is also thought to connect and maybe to reach out for collaborators.
Yeah, it's the best that we can do.
But actually, I was thinking, I think at a certain point we should really ask also for money from the registry, because we should have a data manager, and you know, now that slowly people are starting entering the data, it's...
Yeah, or at least to have some kind of auditation what we are doing. I mean, even random cases just to check that it's working, something like that.
Somebody should take professionally care of it.
Yeah, otherwise.
A bit of pity that it had to be in the hotel yesterday.
Which?
The dinner.
Ah, yeah.
It would have been nicer to go.
Because once you are in Rome,
Yeah.
it's just a bus, go anywhere.
The last one, right? No, I think no, the second last. Sergio is the last. So is one. No, he wants before Bergman's because his flight is.
Because I need to leave at 3.
Okay, so we also.
Yeah, because
then here.
Yeah.
Here.
Somewhere.
Yeah. The third. Is that okay?
Yeah, third should be okay. Yeah.
Let's
just a very quick flight. So we say to these guys that they will change the order?
No, I think it does not affect.
No, for the presentations.
Ah, yeah. Start. So welcome back after this nice lunch. This session is entitled ELAAC Research Session, Registry and Future Studies. Let us make a small comment what the rationale for this session is. It is not only to give an update on the ELAAC registry, but also to provide a platform to exchange research ideas. Obviously, we are not yet in a position to provide grants. That would be an ideal setting, but that's not possible. But what we can provide is a platform first for an interactive discussion to get input by experts. So you're kindly asked after the individual research proposal to speak up and to make comments how potentially the proposals could be improved. And then, of course, the second idea is really to connect. So if you are interested in a particular proposal, please directly contact the speaker to see how a potential collaboration could be established, and that would really be a great aim. We, at the end, also would like to make a grading of the 5 proposals, obviously not of the Elaacc registry presented by Xavi, but of the 5 research proposals that will be presented. You can choose one, and then we will tell you which one is graded best. That's it. I think it's clear for everyone, and we of course thank already now every speaker that submitted a proposal. That makes it very lively, and we highly appreciate it.
Thank you, Laurent. So Xavi is going to present the Elaacc registry. Thank you, Xavi.
Sorry, I'm gonna try to go fast to catch up some time, and try to explain again, you know, not the registry itself, but you know the way that it works and the way that you should adopt it or you can adopt it. So again, you know, special thanks to Jens-Erik and Anders and the rest of the ARUS team, because that, you know, was, you know, like the initiative at the very beginning in the database has been built by them, and they were the first to adopt that. So again, like the Elaacc registry works through REDCap. So this is very important. REDCap, it's a platform that it's free, it's secure, and you can apply, your institution can apply for that. So you can use REDCap in a safe and a legal way to keep, you know, just the database of your patients instead of using Excels or using anything else. And this is legal, okay? You know, it's the way that it is. It's secure. So there are just 3 ways that you can use this REDCap platform or the Elaacc registry. So use it as a database for you. I mean, every single patient, I use the Elaacc registry, the database, just to keep, you know, to have my patients, and then, you know, if I want just to check, you know, mortality, want to check, you know, for my own auditory, so I can do it, and it's very easy to use. Okay, it's friendly, it's tailored, and Jens-Erik yesterday actually showed it. So the other thing that it's online, this is also you know, strength, because you don't have to be, you know, in the hospital. You can fill it from, you know, anywhere, and you can have control access and 2-step check. So I mean, you can just like actually increase, you know, the level of security to go through this. And again, you know, this is a secure environment. So this is the way that it works. In this case, you know, you put my name, of course, and the login, like from my institution, and then it goes, you know, just to this 2-step verification. So I need just to verify that it's me. And then, you know, we have like the Elaacc research registry, and then we have, you know, like the patients, and as Jens-Erik showed you yesterday, so we can just go, modify, edit, and we have like everything there. Then, again, you know, this can be like something institutional. I mean, we have REDCaps not only for LAA, we have REDCaps for TAVI, we have REDCaps for TER, and we're building more REDCaps because it's actually, again, it's really useful tool, because you can have like multiple projects. It's valid tool to evaluate procedural outcomes for, you know, again, you know, your own audit, no cost for the institution, no need for any specific application, available in most of the universities. Probably you don't even know that maybe it's available at your institution, so you only need to ask. So you can, again, you can have multiple users, and it's secure environment. And finally, and it's, you know, why we're here, again, it's a very powerful research tool, and probably you know that some of the studies that maybe you're participating, they're using REDCap as, you know, like just a CRF, you know, system. So what we want with this Elaacc platform or registry to have a common Excel format. So, all this data will be transformed immediately, from Arus, from me, from anybody of you, in the same language, same format. So by clicking one, so we can merge all together. But you still have the control. So Erik has my patients. He's going to have my patients if I send to him my patients, because it's my own database. So that's important, because from the ethical perspective, this is a point, because the owner of the data needs to be the institution in most of the cases. So this is again really important. And at the end, what we want is that we're using exactly the same format. So, and actually we were pushing a little bit, last year. Not too much, because last year we made the last modification of the Elaacc registry, so we didn't want just to implement it because there was like a new version coming, so probably it's around 8 months. And here you can see that this doesn't mean that it's adopted. This means that Anders has sent, the blueprint that I will tell you what's the blueprint. So the blueprint means that, it's I would say it's the codes or the more technical orders just to create this Elaacc registry in the REDCap platform. So all these centers, this blueprint have been sent, and of course, some of them they have implemented and some of them don't. Anders asked, through email, and we got some response and some, no response. But at the end, this would be more or less the situation. Just don't take me wrong, because I didn't put, of course, I know that Switzerland, it's north from that, but it was just to see it well. So, and we have in theory, 6 centers in Spain, six centers in Belgium, then, Denmark, 3 centers that, of course, Arus and some other, UK 1, Switzerland 1, Italy 1, and Germany 2. At the end, just 1,200 patients from, Arus, you said that, Erik, yesterday, and probably from the rest of the countries and patients, probably some, 1,000, 1,200 more, okay? And so far, and this was presented yesterday, so the drafted projects were the reproducibility of the LAAC anatomical classification in pre-procedural computed tomography for LAA closure, and the derivation and validation of a prediction model for percutaneous LAA closure that was run by, or led by Erik and Lawrence, and probably they will end up, with a publication. So at the end, and this is important, so if you want just to join that, please, or make a photo or just write down, my email or Anders' email. So we will, of course, tell you the instructions, and we will send you the blueprint. The thing that it's important to adopt that is this, because there are kind of 3 options. First, you need to check if you have institutional REDCap, that I tell you that most of the centers will have it. If you have it, it's fine. It's the best situation, because then we send you the blueprint with some instructions. These instructions, I will also ask, maybe the industry, to also maybe help with this, because sometimes, if you're not a little bit, familiar with this environment, it could be a little bit difficult. So it would be nice just to have somebody, to always consult for more technical stuff. But anyway, so we send you the blueprint, and then with this blueprint you generate the Elaacc registry that you have it local. And you can use it as a database, and you can, have your own data and audit. And then, for the projects that you're interested to collaborate, you can send, for this project, the patients that you want to send, or the full database. Second thing is that you don't have it, so you can request. Your institution can request for a REDCap account, and then it takes a little bit of time, but, it's not so difficult. So if that happens, then you go to the point 1. And Erik, the other thing would be use, because this has been in some centers, so they're really nice, and they offer, their database, just to open from, that site, open a new account, a sub-account for your hospital. So if you ask for that to Jens-Erik or Anders, so you will have your own database coming from the Aarhus hospital, but you're not going to have access to any other hospital. You're going to only have access to your data. Here, the only problem that I see, it's the ethical. Like you should ask probably to your ethical committee, because you're going to transfer, and it's like a study, no? But you run it like a study, and that's fine, just to run a study for a limited time. But at long term, I think that the best option it's the option 1. So I would like to propose you. It's over my time, but I would like to propose, as we said yesterday, that we put a deadline that it will be October 1st. So we're going to be, Anders and me, we're going to be really open and active, just to all, you're welcome to try to help you during this process of implementing. But we will close, the deadline in October 1st to do the first analysis of the patients that will be included, okay? So you can do it prospectively. I mean, it would be nice to have like some retrospective data. You can implement whatever you can. I mean, it's not necessary that everything is implemented, because then we will share, like the data that we have. And I make this proposal. So any question, anything, so is welcome. Thank you.
Thank you, Xavi. I don't know if there's any question. I think it's clear what we need to do. So, yeah, there's a question there.
So if in the future, if you publish any manuscript, how you decide on the authorship? Is it depending on the centers or the numbers, or because it would be good to have a transparency and clear from the outset?
That's a superb question, and like since we are not having like so many patients, this is something that we have not defined yet, but definitely we should just discuss about that in a group. Of course, if you are just putting one patient, I mean, and it's a big publication, so you're not going to get any authorship. So I think that like something like 50 patients makes sense, but this is something that will need to be discussed. And once we have all the centers that will participate, then we will share this information. Yeah.
So just a couple questions. Did you have a session dedicated to ERA? I missed ERA this year, but it'd be worth like trying to see if you can get a dedicated session at some of the interventional and EP meetings to talk about the registry, just kind of do this very same informational thing, but in a broader audience that, this is sort of your capture audience, but try and see if you can broaden the scope of things. And then also, we have our first paper that was in JAC 2020 from the registry. And so it might be worth talking to European Heart Journal and Europace sooner rather than later to let them know this is coming and this is a trans-European effort, and we're hoping the output will be important over decades.
You're very welcome in that sense. Like you what you said yesterday, we'll probably make a first, work, showing the registry, and that second stage would be with the patients, no, 1st of October. And you're totally right about, like having, meetings, maybe, Philippe, EuroPCR, we can have like a meeting, with like the people that are attending, just to reinforce, the Elaacc registry. Yeah, I don't know. So, Philippe, here?
Yes, of course. Thank you, Xavi. We have a lot of sessions at EuroPCR now and PCR London Valve. We are partnering with them as Elaacc, as a group, and I think it's a good opportunity to have such meeting and discuss where we are with these trials.
Yeah, thank you.
Okay, if there are no further questions, we now open the session on the abstract presentation. The first speaker, we changed a bit the order to respect the departure time of the individual participants. So the first talk will be by Martin Bergmans, and the title is, or the proposed project title is Establishing a 3D Sizing Chart for LAAC Pre-Planning by CT. And I just remind you how it will be executed, the session. There will be the presentation with a project proposal, followed by a Q&A session where you can constructively criticize and give your impact, and then at the end of the session we will make a voting. Thank you very much, Martin, for presenting your proposal.
Well, thanks for the chance to share my ideas. As you know, we've been a late starter with using CT and LAA sizing, and I tried to identify a good sizing chart as I'm used to use for TAVI. In TAVI I have one chart that I use, I think, for 10 years to go for Evolute or Sapien, based on the area, respectively the perimeter of a 3D reconstructed face at the annulus. So I thought that we need something in our field of LAA closure, because the IFUs of both these devices that we use regularly refer on TOE and the maximum diameter. And as far as I understand from industry, they won't take the effort to change the IFU, which always means a lot of hassle. And so this is something I think that might be or should be done by investigators. The number of patients that we need to validate that, I have not been able to calculate it precisely, but there are other papers out, like the one cited here, where already with 100 patients it was possible to get significant results in comparison to what we have. The endpoints have also been described before. I think if we just record, as I think would be possible with the registry data set that was just presented, the device size changes, the number of repositioning maneuvers, and the leaks, we have the key endpoints that would show this sizing chart that I propose to be working or not working. Obviously, the whole field is based on this publication by some well-known and respected colleagues here out of the group. I don't think we have to go through this in detail, but what for me as a beginner of measuring that, I still struggle how to exactly identify the plane and the ostium. It's clear on the one side we measure at the CX level, but the upper side is something more clear. I showed this picture before. I'm thinking of this area to be measured orthogonal to something like a central axis of the LAA. And what I did, obviously there's a special sizing chart that we need for the chicken wing with a special approach that is used for the amulet, where then the disc becomes more of the defining chart than the lobe. But in general, for all the others, this should work. So what I did in preparation was that I thought of the LAA ostium to be an ellipse, and that when we know the maximum diameter and we agree that more than 99% of our orifice will have a minimum of 50% of the max diameter to be the other area, we can calculate an area. And this is what I've done. With the help of some algorithms I used with ChatGPT, because actually if you start to look at the details, it's not that easy. So the two lines below are the ones that are calculated as a CT mean average diameter, and the landing zone, which obviously also has an overlap between the different devices. Whether to include already possibly an Amulet 360 sizing chart, as you mentioned that the sizings have changed, would be an issue of discussion, but I guess we could do that. I've done the same thing for the, the headline wrong is here, this should be Watchman, and for the Watchman I also calculated a perimeter and a perimeter derived average landing zone that we have. So the first step for me would be to validate the sizing chart, possibly in a retrospective design when we have already CTs and the investigators have already chosen a device. And the second step would be a prospective trial, possibly as part of the large registry Elaacc is running, to get some data on that. Thank you very much.
Thank you, Martin. Very interesting proposal. Any comments, Claudio? And also Elizabeth.
Martin, I noticed that the sizing chart is intended just for 2 devices. Is there any idea just to make the chart uniformly adopted for even other devices? Maybe just in the future, new devices is coming. I mean, just and.
Well, I think every device is different. The overlap is different that we have for the device. For the amulet, we need a much more precise sizing than we do for the Watchman. So I think actually these charts have to be device specific. But obviously, if this proves to be working, like from the ellipse we can calculate the area, then we can transfer this algorithm to new devices if the companies come up with a sizing chart. But as I learned today already, some of the new devices come up with a CT sizing chart, maybe then already being part of the IFU, so that would make things a lot easier. But at the moment, we are stuck, I think, with that.
That's another question there, Elizabeth.
So I think it's a good idea. I also thought, why is this not available? Why do the companies do not invest in this? But now I saw you were always taking perimeter, but the way I've been doing it is always on the max diameter. So maybe it's also interesting to investigate which is the most correct one to use. Not only, maybe you can also check max or perpendicularity as another characteristic.
Yeah, obviously there are some estimates in there. What I did, I can send it around and share it, and happy to have any input. I really thought that we need to define like the overlap between the 2 devices, and by that having a uniform, let's say, chart by that. But happy to work on that chart before. Yes, Erik, I'm interested.
We have looked at this in a retrospective way, actually both for the amulet and for the flex device, and we published on the amulet device. So looking at all the amulet implants that were successful, and then went back to our pre-procedural planning and looked at maximal area-derived and perimeter-derived mean diameters, what was the best. And for the amulet device, it was perimeter derived or just simple maximum plus minimum divided by 2. That also worked good to predict the device we actually put in and had no leaks. And we did the same thing with the Watchman device, and we actually came to the same conclusion that using the mean or the derived diameters was more precisely in just using the maximal diameters. And of course it makes, as you have also highlighted here, makes more sense the more oval or eccentric your landing zone is to work with, not just the maximal diameter. But we didn't do it in a prospective way, so I think it should be very nice to do it in a prospective way, and you could discuss what will be your control group. Will that be a one where we just use the classical maximal diameter, or I don't know?
As mentioned, I think so. I'm thinking myself of like a test object. Obviously, not having that much of experience as you guys have in AROS or so, and I think we will see many people getting into the field, EP people doing more LAAC. So to come up with such a simple sizing chart where you just measure an area or as perimeter, as you suggested, and then they can read what they then will have better results. And I just know from the good old evolution registry, obviously not done with the flex, but that we would have 80 or 75% of the procedures to have one size, one release. And my aim would be, rather than to go for retrospective comparison to other series, that, I mean, if such a sizing chart allows us to go like to 90%, one size, one shine, and the same for the amulet, we have achieved our goal. That would be my proposition, so to go for these kind of endpoints.
Thank you, Martin. Last question for Laura.
No, that I was going to say that the matrix sizing chart for amulet was already published based on retrospective, but 3D TOE and CT, and is accepted by the company already, so we can use it. And that it will be also a problem that the device is changing, and it's totally a different device, so I don't know if today, this year, it makes so much sense to put so much effort in the sizing of the amulet if we are going probably to change the device in 1 year.
Yeah, exactly. So I think if we start that, as far as I heard, maybe beginning of next year we get Amulets 360 available, so we would need to adapt it to the sizing chart of Amulets 360.
And the other thing is regarding the watchman, that you need to also keep in mind the maximal, derived from the 3D measurement, also because when you make the deformation of the watchman, it doesn't increase this maximal diameter of the watchman, because it deformates without increasing the maximal diameter, so you cannot put a device that it's smaller. So even if you work with area, you need to keep in mind also
you still need the maximum diameter.
Exactly.
So that was some of the thinking why I thought it's not that easy just to have max and min and divide it by 2, but rather to go for the max and then have maybe an area that's still in line with the IFU that we have.
Or maybe that the number that give you for the device cannot be smaller than the maximal diameter, or something like that at the end.
Yeah. Okay, thank you so much. We need to move on. So next presenter is going to be Claudio Tondo is going to talk about the comparison between left atrial appendage isolation and occlusion in the context of AFib ablation.
Thank you. This is partially just following my presentation this morning, and it's probably much more EP oriented. This is I understand, but what we are trying to figure out is whether or not possible just to reduce the ratio of leaks by using ablation. In the past we used a RF, and now we have a PFA. We don't know whether or not PFA is much more effective in reducing the leak, and by electrically isolated, especially in patients with long-lasting persistent atrial fibrillation. This was just a slide of our experience in the past. And if you look at the prevalence of per device leak in patients with appendage closure with or without the electrical isolated atrial appendage, just forget the success rate of catheter ablation in terms of maintenance sinus rhythm, but it seems that we have a tendency just to have less leaks as opposed to patients without the electrical isolation. This is just the paper that I show you this morning. Apparently, in a patient treated with a PFA, there is a reduced rate of a PDL, even though it didn't reach a statistical significance. So we don't have randomized clinical trial looking at this issue. I just show the preliminary data. This is from Germany, from the Ronald Thiel's lab, who presented, preliminary data concerning the isolation of appendage versus, without isolation, and you can easily appreciate that there is a trend to have less PDL even less than 3 millimeter, or between 3 and 4, or more than 5. So, in the practical terms, what we are, going just to do, just try to design a trial in one-to-one fashion, patient to be included just with or without the elliptical isolation of the appendage. This is something that obviously needs just to have more patients included and more groups who intend just to explore, investigate the issue about the peri-device leak. That's it.
Thank you very much. Are there questions? Did you make any assumptions on the sample size you will need?
Not yet. No, not yet. Probably we need just to have quite a good number of patients included, just to have the one-to-one randomization, because we need just to collect a lot of data, especially just patient with a persistent atrial fibrillation. This is probably the patient who had a higher recurrence rate, and therefore, especially when we do quite an extensive ablation, as we mentioned this morning, probably we have already isolated partially the appendage. So.
And which would be the endpoint? Yeah.
Just a PDL. I mean, just a
PDL.
This is a
Any, and with which method would you? So T, CT, and at which time point?
Well, usually we use CT. Yeah, this is the aim, just to include just the CT scan here.
Jens?
Yeah, I know that Devineia and Vivek Reddy in US, they are already running this study, and I think the concept is very nice, that you inhibit contractility, you get very, very slow flow, and you get very fast thrombosis behind the device. That's the theory behind having less leakage and better sealing. But I don't know if their study, it's probably, I think it's Watchman Flex. I don't know if that's the plan here, or if it's more different types of devices. Or
Different types of device, I mean, just, but the concept behind it is, if you look at the concept of the cutting out the appendage with the surgeon, that obviously you don't have, contractility, you don't have the appendage anymore. So, the rationale is just to investigate whether or not this can add an advantage, I mean, just rather than, occlusion alone.
Following that comment on the complete occlusion, did you observe so far an effect on the flow into the device? So not only on PDL, but also patency behind the device?
Yeah.
Do you have any idea, or from Registry?
Already, yeah.
So that would be part of the endpoint, or not?
It would be part of the investigation.
Then, because then you would probably not need too many patients, because the frequency will be 40% at 3 months by CT, which would make it more attractive, no? Yeah. If you believe in the concept.
If you believe it, right.
Are there questions? And which device? Is that of any consideration, or you would be...
Yeah, sure.
Okay, if there are no further questions, thank you very much.
Thank you. Thank you, Claudio. So, next speaker is going to be Jordi.
So the title is Concomitant or Sequential AF...
No.
Sorry, Jordi.
Yeah, so it's
Elaacc, Federated Imaging and Clinical Data Ecosystem for LAA Profiling.
Whatever it means.
So actually I'm a little bit afraid to bring up this topic after yesterday's discussion, because I want to talk about patient profiling. Actually, not alone. On behalf also of Professor Oscar Camara, cannot be here, and Philippe from the Institut Cardiac of Paris-Sud. So, to be honest, for me as an engineer, it's amazing all these LAAC registry, so congratulations to Jens Erik and all the other participants, because I think that it's amazing to have this kind of data, but from my point of view, there are two bottlenecks. One is that we are leaving behind all the anatomical part on the images. As you know, in the REDCap, you can submit information about your patient clinical data, but not imaging. It's true that then what you can do is, okay, let's do the measurements, and then manually you bring it in the REDCap, but for me still this is the second bottleneck, because as I was talking with Ali yesterday, I mean, you physicians, you're very busy, you don't have time to do research and clinical at the same time. So in that sense, I think that we need to improve that if we want to do proper research and find what variables are statistically significant. So what we want with this proposal basically is to solve the privacy problem that Xavi also came up with this, and take into account also all the information that you can extract with the imaging. So our idea would be to put all the algorithms that allows you to extract the data automatically in each hospital, and then perform the anonymizing there, and use it then to do this profiling and analysis. Of course, this is very easy to say and very difficult to do. Here, please forget about REDCap, hemodynamics, and federated. Now thinking about it, I think that it's better if instead of REDCap, it's clinical data. So we want to use clinical data, anatomical, that it would be the CT, and then the functionality that here can be substituted by hemodynamics, to have like the whole image of the patient. And to do that for the clinical data, and I think that all the variables that you have in the REDCap, it's enough. Then we would like to have this information from the imaging, that we have the capacity to extract it directly on the site in the hospital, and then you don't need to upload it anywhere. And the same with functional data, that it would be basically echocardiography. So this would be like the goal, but of course it's like very difficult to perform, because every hospital has a different software to obtain the CT, and have a different software to obtain the echo data, and all the forms for the clinical data. So our idea would be in the first year just to go, depending on the funding obviously, but each hospital and engineer, and to install everything you need on locally, so you don't have problems of data privacy, and then be able to link this with a REDCap. So extract all the anatomical features from the imaging and link it with a REDCap with the ID that you already have there. So as I said, you don't have problems with anonymization. Then the next year would be not only to run simulations, but to put together and homogenize all the data, and try to doing some analysis, which are the features that we were discussing yesterday that they have to take into account to do that. And finally, then once we have, all the features that we know that can help to, or that they have an impact and they are not redundant, try to find a way to profile these patients. And then there is the last phase, that is just to test it. It's just to see if we can do one, for instance, hospital that has no CT, but has all the data of the patient. You have the data, you upload it to REDCap, and then you look for an atlas. So you look for the closest match, and automatically you get like the optimal position, device, and size for each patient. So this would be the idea. Of course, this is a lot of work, as you can see here, and the first idea would be to start only with 3 and 5 hospitals, just to obtain at least 500 cases, if it's possible more, of course. But it's important that it's more than 2 hospitals, just to avoid bias on all these artificial intelligence algorithms. And then, of course, I would love to scale that, not only to use the register of Europe, but of any hospital around the globe that wants to use it. So, yeah, that's all. Thank you very much, and feel free to ask any question on the project.
Thank you, Jordi. really interesting. Any comments, any questions? So, Jordi, as you know, at least in Spain, we have a lot of problems, legal problems, for this type of projects. Do you think that you can overcome these legal issues? Because I know that you come from the technical point of view, but sometimes legal departments are not so friendly.
I mean, I cannot say, okay, 100% sure, because I like to be very transparent, but I'm quite sure that yes, because the imaging is not leaving, the hospital at any moment. I mean, what you extract from the imaging, for instance, is the 3D model, but without any clinical data, and then it's linked with ID that you already have. The same with the echo data. You only extract the measurements, and that's all. So any imaging is living, the same with the property of the images, and the data is yours, is from the Elaacc or when you have the repository. So.
Jordi, Thomas from Aarhus. Very exciting. We are currently working on Appendage, a database where we're collecting clinical data on patients and then doing a core lab analysis on the CT, both pre-procedure and post-procedure. And my shoulder is hurting from doing all that core lab analysis.
Exactly.
Yeah, the software you're talking about to doing this analysis, how far along is that? Can you talk about a bit about that software?
So actually, it's not like a software per se. It's like to having an engineer that knows a little bit how to automatize that. So the process that we have, that we obtain a CT, we extract like all the data, not only the anatomy, all the parameters. The same with the echo, it's already done. With the data, would be easier if we standardize like all the process on how the hospitals gather the data. I mean, for each hospital we work, we try to do it also automatically, but some hospitals, they have it in a PDF form, others, in an Excel. So this part is the one that we need to figure out, that it would depend more on the hospital rather than if we have the technology.
So for imaging measurements, it will still be an engineer doing manual measurements with
No. It just, we need someone that can set up like the server inside, that's the problem, inside the hospital, and then it just connected with packs, with every machine that you have or software with the CT, and then automatically it takes the image, extract all the data, and send only the data in the ID that is assigned in RedCap.
Can you characterize a bit what you understand by digital twin? Is this a software-based simulation, or is it a true silicon model that you would produce and then make measurements on this one? So what's the definition of digital twin in your proposal?
Well, if you go to a simulation or let's say engineering congress, this is a huge debate. I just put digital twin to make sure that it's like personalized, and actually you can adapt it for each patient. But what you are asking, so all is not based on simulation. I mean, what you obtain with the simulation is just part of the variables that you cannot extract from, a simple measurement on the CT. So the idea of doing simulations is only to extract more variables, but then be able to, using, I think that it was Sergio Berti that was saying yesterday, using deep learning algorithms to detect which are the best features that actually matters on this profiling, and then you only perform, your research based on this. You know what I mean?
Yes, now I understand that it's not silicon that you produce, and because we do the same with coronary anomalies, but there we produce true silicon models. Exactly. and two flow simulations, but that's not what you do.
No, so actually we use just this, for instance, flow simulations and mechanical simulations will be only one part of the whole analysis.
Okay, and the ultimate aim is to get, for example, flow variables that with that data set, newly created data set, you could predict then DRT.
So no. Actually, my final goal would be what is the best device size and type of device for each patient. Actually, the flow is just to avoid, DRT. But avoiding DRT is one of the part of device selection. So the final goal is not only, DRT. We could do that is like the best optimal position and device size.
And Erik? Can we have a microphone? And then, yeah, sorry, I missed you. Jens Erik, please.
Okay, you want it retrospectively. It can be okay just to have it retrospectively, pre-CTs and post-CTs, or do you want your study being done prospectively? That's one question, and my second question is, how dependent will your analysis be on very properly performed mitral, Doppler mitral curves? Because, I mean, a transthoracic echo before an LAA procedure, it's not really focusing on flow across the mitral valve. So I would be afraid that the quality of the Doppler that you will get is probably doubtful. And in that respect, you might better do it prospectively.
No, so yeah, I think that here there are two parts. Obviously, first you need to do it retrospectively. At the end, if this went well, at the end you will have to do like a prospective just to validate it, you know, in a proper way. But just to start, it can be retrospective. In the second part of your question, I mean, you're right, but I think that it's very important to distinguish that this is not only focused on flow simulations. I know that always I put the face when there is flow simulations, but this is only of the part generating this. And this also is the reason that I want clinical data and I want anatomical data, because I think that it's not the only factor. And if one echo is not well done, I can have like other 400 cases that are covering that. You know what I mean?
One question there. Roberto here from FIOPS. So a lot of you know already FIOPS, and I would like to complete also the information that was shared here. So what we have done already in the past, and we are doing now, so we deliver those services like this, so the anatomical analysis. So we take the CT, and from the CT, we apply AI for the anatomical analysis. And this is what we are doing today. And also for the security, we have already this, I will say, certificate about privacy. And also to go in this direction, so there is two things. There is the anatomical analysis and the simulation. And so on a humble way, if we can bring some information and help you in this evaluation of the anatomical analysis, we will be pleased to share what we are doing today with you.
Okay. Thank you, Roberto. So thank you, Jordi. We will need to move to next presentation.
Next. Now we move to Xavier Armario, and the title is Concomitant or Sequential AF Ablation and LAA Occlusion, the Timing AF Study. You already have an acronym for the study. Great.
So good afternoon. Thank you for the opportunity to present this research proposal in this meeting. So it all started when the option trial was published. As you all know, in this trial, patients undergoing AF ablation were randomized to get an LAA occlusion additional or just keep our anticoagulation, and it demonstrated that in patients undergoing LAA occlusion, the primary safety endpoint and the patients that underwent LAA occlusion, sorry, I'm a little nervous, were the primary safety endpoint, so there were no big differences between both groups. So once the trial was published in our hospital, we said, okay, we have these patients, we can start doing this kind of patients in our hospital. And the first thing we said, okay, should we do them concomitantly or sequentially? We checked the option trial. There's like a 60% of patients which were done sequentially and a 40% of patients that were done concomitantly. But we tried to dive more on this data, and we didn't have much information in the option trial. So in our first protocol, we said, okay, we leave the option for both sequentially or concomitant. and then we can decide on more logistics things. Then a sub-analysis was published and presented, I think it was at TCT last year. But it's important to remark that this trial was not designed to compare concomitant versus sequential. And this sub-analysis was not intended to compare these two subgroups. So what they did here is, okay, we have the concomitant group and the sequential group. So they checked that the outcomes that they got in the overall population, they were similar in the concomitance group and in the sequential group. But they were not trying to compare. And this is the baseline characteristics of both groups. There are some significant differences between both groups. So at the end, we cannot do a direct comparison between the two groups. Then they did the analysis for the concomitant, then the sequential, but again, they were not intending to compare both strategies. If you check the numbers numerically, I know they cannot compare, but in the concomitant group, the all-cause death, all stroke, or ischemic stroke, the numbers are twice the sequential, but we cannot conclude anything solid from that. So at this stage, we said, okay, we have the sub-analysis, but still we don't have the answer. So in our hospital, what we're doing is deciding more in logistics or patient preference, but we cannot tell the patient that the concomitant, we mostly do concomitant because of this, but we're not sure if that's the best option for the patient. So that's why we came with this research proposal. We think that the concomitant option is probably better than the sequential, but we don't have this data. So the primary objective of this research proposal is will be to evaluate the incidence of ischemic stroke, systemic embolism, and major bleeding within 36 months after LAA occlusion. And secondary objectives will include the incidence of device-related thrombosis per device leak at 3 months and 12 months, and then the incidence of cardiovascular death or death for any cause in this period of time. So this will be a prospective, multi-center, I hope multinational, open-label randomized clinical trial, which will include all patients with non-valvular atrial fibrillation undergoing AF ablation and LAA occlusion. Patients will be randomly assigned one-to-one to a concomitant strategy, which we define as performed in a single procedure, or sequential strategy, which is 2 different procedures. In all cases, as the option trial, the AF ablation will be performed before the occlusion. That's the first draw of the protocol, and of course many things can be discussed, but for a moment we will leave that both procedures are performed according to the standard clinical practice at each center. And that's another thing to be discussed. That's what we do in our hospital. We only included patients treated with the Farapulse and the Watchman Flex device, but that's something that can be discussed. So once the LAO is performed, patients will be assessed with TOE or CT and at 3 months and 12 months, and they will be followed up clinically as well. And then after that, until 36 months, they will be followed up in person or with telephone visit. So this is another important topic that can be discussed. That's what we're doing in our hospital, but so we have 2 protocols, one for concomitant, one for sequential. If you check the concomitant, that's basically what they were doing in the option trial. So once the LAO was done, if it was concomitant, they were doing DOAC for 3 months plus aspirin during this period of time, and then keep aspirin for 1 year. We have left like this so far. In my hospital, we're not doing this. We're doing DOAC for 3 months, only DOAC, and then keep aspirin for 1 year. But that's one of the things I would like to discuss with you. If we would go for sequential, usually we leave at least 2 months, because that's what the European guidelines recommend of anticoagulation after AF ablation. So we would do ablation, 2 months of DOAC at least. We usually do the LAO at 2 or 3 months after the the ablation, and then we propose aspirin and clopidogrel, but I know that it's not the most common use, so it could be aspirin alone or aspirin plus DOAC. For me, that's the most important thing to be discussed. We propose if device-related thrombosis is observed at 3 or 12 months, that it should be treated with a P7 2.5 until its resolution by TOE or CCT. And then the primary endpoint will be a composite of safety, which is major bleeding, and efficacy, defined by ischemic stroke and systemic embolism within 36 months. When we say major bleeding, we have decided for a moment to include the procedural bleeding and complications, because one of the options could be that concomitantly you have less or more procedural complications compared to the sequential. And secondary endpoints would be the individual components of the primary endpoint, all bleeding, device-related thrombosis and peri-device leak at 3 and 12 months, and then the cardiovascular death and death from any cause. So some definitions: ischemic stroke would be defined as a CHA2DS2-VASc, the bleeding score according to the Hasbled, defining a Hasbled of 3 or more as a high bleeding risk, and then the bleeding with the Barr criteria. The study population will be any patient with non-valvular atrial fibrillation, which is considered suitable and candidate for AF ablation and has a high ischemic risk, defined by a CHA2DS2-VASc of 2 or greater. We have not calculated yet the sample size because we have to be sure about all the outcomes. And once we have the protocol clear, we do the sample size calculation. And the inclusion and exclusion criteria for the moment are quite soft. It's just patients, as I said, non-valvular AF that are candidates for AF ablation and have a CHA2DS2-VASc of 2 or more, and not important exclusion criteria, just some allergy to aspirin and clopidogrel and other indications for anticoagulation. So I would be happy to discuss any. For me, the most, or the 2 topics that we have thought more is, should we include more devices like Amulet or other brands, or just keep with Watchman? Because we said Watchman because that's the option trial. And another kind of AF ablation techniques like radiofrequency or cryoablation. And the second question is the treatment. Once we decide which devices we include, because we want to be sure that the treatment, the antithrombotic therapy that both groups receive are equivalent, and the differences that we might observe are not justified because of that. So.
Thank you, Xavi. Very interesting. I don't know if there's any comment.
I have a first question. Is this a superiority or a non-inferiority trial? Yeah. And what's the hypothesis you have? Which is your hypothesis?
We said the hypothesis is that the concomitant is superior, and the reason why is if the study is done with the Farah pulse or the pulse field ablation, theoretically the edema is less, so we don't expect the patients to have more leak or DRT compared to the sequential group, and potentially we could have less complications because it's only one procedure, but we don't know, but that's the hypothesis. One transeptal access, so potentially could have less complications with same efficacy.
Yeah, I don't know if Ole, you have a question. Anyway, Xavi, I think it's a key point, the sample size, because otherwise, I mean, it's a huge study and probably really, really expensive. That is probably the problem that you can face if you propose this study. I don't know. Ole, do you have a question? Or?
No, it was also about the hypothesis.
Yeah.
Your sample size calculation, because, I mean, an endpoint, a clinical endpoint, you're going to need more than 1,000. I mean, I'm a bit worried about your endpoint. It's a clinical endpoint to show there's something, whether it's non-inferiority or, I mean, you're going to need more than 1,000 patients probably. So did you do some realistic sample size calculation there? No, isn't it easier to look for some more imaging endpoint like leak, or that would be maybe easier? And
so that's one of the options, because we said, okay, if we keep the strong endpoints, clinical endpoints, maybe we need too many patients to check that, and other option could be check for more soft, I would say, endpoints or imaging endpoints or DRT or per device leak.
I mean, the idea is great, but I also agree that it's not feasible because you just need too many patients, but it's a good momentum to include surrogate endpoints, so a mixed endpoint where you, for example, consider PDL, maybe even quality of life of the patient, and not only major bleeding, but also clinically relevant bleeding, and also death, obviously, because in both you have LAA occlusion. So,
Tell me.
Yeah, I completely agree with you because I think that you need to start with, like just maybe, like something smaller and something like a complete or optimal closure, and it makes sense, no? Because, like since the like the EP intervention, it's, kind of, altering the anatomy. It makes sense, to see if there is difference. So I think that makes sense and probably will skip, a lot of, your sample size. And the second, asking or answering your question, I would keep, DOAC, in both groups, so just don't put that. So DOAC.
DOAC alone, or plus aspirin.
If you're doing the ablation, DOAC until the intervention, and then DOAC if you want aspirin, like DOAC and aspirin, because it's like a non-bleeder population. But, just keep, after the intervention, keep the same treatment in both arms, because otherwise, if you have DRTs or you have anything, then you will have, like just a problem because you don't know where they come from.
Yeah, that's another question there.
Yeah, so I completely agree with that comment. I would stick with DOAC alone, even without aspirin. There's really not great data for adding the aspirin, and I think it makes the trial design much simpler. And I also agree with the comments. I would shorten up the time horizon. You could go with a very short time horizon and really look at acute procedural outcomes, and because that's really what you care about. You're looking at, are you doubling the rates of vascular complication, anesthesia-related complications by doing 2 procedures rather than 1. And the other thing is, I guess you'll have to start looking at outcomes after the first procedure, because there's this issue of survival bias if you have to wait for both procedures before you start assessing outcomes. So you have to think a little bit about that as well when you start assessing outcomes. But I think it's a really important topic.
And speaking about DOAC, I mean, you mentioned that you would go for the Watchman because of option, but actually I would see it in a diverse way, because what is unknown is how the amulet performs in the context of DOAC therapy. So if you want to provide novelty, it would probably be a good momentum to study, at least as part of, as a subgroup, also amulet and not Watchman, where the performance is actually well known.
So it would include
you
both.
might be able to get funding from Abbott for that, because it's an important question for Abbott.
Yeah, I will not.
Yeah, that totally makes sense.
Any other question? If not, we proceed.
Yeah, let's move to the last presentation. So, Sergio. Sergio is going to talk about establishing a 3D sizing chart for LAA occlusion, pre-planning by CT.
Okay. When we published our paper, a couple of months after the publication, while I was reading the paper, I thought it would be great to have an automatic tool for applying the classification. So I discussed it with our AI team, and we started to think that a neural network could be a possible solution. So we realized a neural network equipped with the 2 graphic process units. The system is based on 3 steps that are the 3 main pillars of the AI: the training, validation, and testing. And we started to train the system using the CT scan dataset of our patients. During the training phase, the machine was trained by 2 expert operators, 1 imager and 1 interventional cardiologist. After that, we go ahead with the validation step. The validation step is the output that the neuronal network provides on the basis of what it learned. And after that, the testing. The testing is the phase of is one of the steps of AI training where you provide to give to the system new cases unknown to the system. We published the architecture and the preliminary description of the system, and for the application of our classification, we find the first problem. At this point, we described the angulation of the LAA. We discussed it with our community at the time of the publication, but at that time, I didn't have in my mind one possible solution, but speaking with our team, probably this is a possible solution. Basically, the orientation of the main axis of the LAA according to the axis of the catheter is a composition of two angles, one equatorial angle and one polarization angle. That exactly are the orientation on the base of the anterior, posterior, lateral, and the polarization, the deviation of the angle from the main axis. These two parameters identify exactly the orientation in the space of the main axis of the LAA. So, where we are now, we are in this situation. The first part of the neuronal network is trained. If we upload one CT scan, it provides a volumetric analysis of the left atrium, because we know that the volume, the maximum expansion of the volume is generally around 40% of the cardiac cycles, but not in all cases. So identify the maximum expansion and start to analyze the patient. The system is able to do an automatic segmentation and the reconstruction of the left atrium and the position of the circumflex that we identified as a marker for the ostium, and automatically provide an extraction of the left atrium and fossa ovalis and the ostium using a numerical segmentation based on the CT scan data, and provide a morphometric analysis on the base of what we state in our paper, and allocate the patient on the base of our classification. The machine has been trained on the base of all we state in our paper, the definition of the ostium, the definition of the LA, what is the LA, etc. And the system is provide an automatic process, is operator independent, is very fast, 3-4 minutes for a complete analysis, is modular and scalable. That means that in the future we can improve the quality of the training on the base of what the Elaacc community will decide. Now we are here. The system is provide an automatic segmentation of the left atrium and of the LAA. It excludes all the other structure. It provides a localization of the fossa ovalis and the anatomy of the morphology of the left atrium, and it is able to identify 3 essential points: the center of the fossa ovalis, the center of the ostium of the LAA, and the main axis of the LAA. At this point, we can apply the spheric angle to the trajectory from the middle center of the fossa ovalis to the center of the ostium of the LAA, and we can calculate exactly the spheric angle is exactly for the main axis, the center line of the LAA. We use the Borodoni theory, that is the equidistance among all these points in the circumference, and basically we can obtain the orientation in the space in terms of two angles of the main axis of the LAA according to the axis that came from the center of the fossa valis and the center of the ostium. So we have a lot of possibility, but each patient is classified on the basis of the spheric angle that I mentioned before. Basically, the result is this one. We can have the different position of the orientation on the base of the anterior posterior and the deviation, the angle that is the deviation from the main axis. That is an indicator of a complexity. In this patient, two patients, where one is anterior posterior with the minimum deviation from the main axis, and the red point is the patient where the main axis of the LAA is deflected posterior inferior with a big angle, so it's a complex case. We trained the AI system with our 400 CT scan of the patient that we treated with LAA. What the proposal is create a data sharing for the Elaacc classification and validation using pre-procedural CT scan, post-procedural, and procedural outcome. In my mind, this tool should become a tools in the hand of our community for a automatic classification or application of our classification. So it should improve our capacity to classify the patient on the basis of our publication and the further version of our classification automatically. Thank you.
Thank you, Sergio. Amazing proposal. There's one question, Jordi.
So, amazing. I think that it's wonderful work. I'm just curious, and I can ask Simona otherwise, but do you know how difficult it is? Because did you train this on dynamic CT, right? Or just the static CT?
This version is trying to classify the anatomy of the LAA, but it is not tested, not now, for different devices. But the main structure of the neural network it has been conceived to be scalable. So we can train in the future for different aspects. In my mind, the next step will be to train the AI system using the CT scan post. So you have pre and post, so you have the success rate. And because this is not conceived for a preprocedural, not only for the preprocedural planning, we have a lot of instruments for preprocedural planning. The point is to have an open source version of an AI tool for research. So it's basically one piece of the project that you show it.
That's why I'm asking, just because I think that is amazing if you can compute the Elaacc score just automatically. But that's why I was asking if this is based on just a specific frame, you know what I mean, of the cardiac cycle. So the CT that you are extracting this is, for instance, in arterious phase or a venous phase, you know, because then if you are in the arterial phase, the CT, it's easier to extract the morphology.
Is trained to identify the maximum expansion of the left atrium and consequently the maximum expansion of the LA.
Okay.
So the analysis that we do is based on the maximum expansion. Usually when you analyze the CT scan, by default we analyze 40% of the cardiac cycle. but we know that a relevant percentage of patients, in a relevant part of patient, percentage of patients, the maximum expansion is not 40%, but it depends if the patient has atrial fibrillation or other valvular disease. The deviation could be important from 40% of the cardiac cycle.
I think we're advanced in time. Maybe the last question from Lisbeth.
It's super cool to see all those images. Very interesting technology that you and your team have developed. I have, I think, 2 questions. I'll make it short. So for the axis that you are trying to calculate, is it a reverse or an anterior or posterior axis? So you're using one line from the middle of the fossa to the center of the ostium, and then as the next one to define your axis, you would use from the center of the ostium in the middle, the center line of your appendage neck. Is that correct?
It's a good point. To identify the middle of the fossa ovalis is easy, because basically it's a circle. To identify the centrum of the ostium is relatively easy, because it's another more or less oval, or it's a circle. The point is how to define the center line of the LAA, because really graphically it seems a line, but really it's not exactly a line. We apply the Varadoni theory. It's not easy to explain, but basically it point by point is able to calculate the equidistance point from all the part of the circumference in that point. And basically you have this situation. This is the axis between the fossa ovalis and the center of the ostium, and this is the orientation of the LA. On the base of the orientation, each position of the orientation can be calculated with 2 spheric angles. The angle, the deviation from the main axis, this is the polar angulation, and the equatorial, that is the orientation on the base of the anterior, posterior, lateral, left or right. And each patient has a precise orientation of each LA. Has a precise orientation.
We need to move because we had the poll and we have been told that the coach is going to leave at 4:30, so we need to move. Sorry about that. So
it seems to be a very attractive proposal.
Thank you so much. So can we run the poll?
So the rules for the, maybe first, can you show the QR code so that everyone can scan it? Please dial in. Yeah, that's good. And then actually what we propose is that you just pick the most appealing proposal. So you have 1 vote to select 1 proposal. We go through the presented ones. Federated Imaging and Clinical Data Ecosystem for LA Profiling, Concomitant or Sequential AF Ablation and LAO, comparison between left atrial isolation and LAO versus to LAO and left atrial isolation in the context of AF ablation by Claudio Tondo, and then establishing a 3D sizing cohort for LAAC pre-planning by CT by Martin Bergman, and then the AI for LAAC and Elaacc score by Sergio Berti. So 5 options. Please just make your 14 votees. So we have at least 30, I guess, attendees. Yes, you can only.
When we see it here, it's 1 centimeter priority.
Aha. No, I was promised you can only vote on 1. Is that not correct?
No, it's not correct.
Ah. But so how is it now? Because I did not.
Generic is like a priority order, so the one you.
So you need to select, but.
Select and bring it to the top.
Aha, you need to bring. Okay. I think 30 seconds remain, and then it will not change. So we have still some. So it seems that the AI-based proposals are the winning ones. We congratulate Sergio for leading the ranking for his AI for Elaacc score proposal, and then followed by the Federated Imaging and Clinical Data Ecosystem by Jordi, and third is concomitant or sequential AF ablation, and then the 3D sizing chart, and finally the LA isolation. So congratulations, and let's see what we can make out of it. And with that, I think we hand over to the final session.
I think this last session is going to be half an hour max. At 4 o'clock, I think we have to stop, and at 4:30 there's transport to the airport, I think. So, Ignacio, I'm going to invite you immediately to start your talk about key insights and voting outcomes from the 2026 program.
So, in the next few minutes, I'm going to try to summarize what we have done in these last two days. So, first of all, I would like to thank you and to express my gratitude to all the board members. I know the amazing job you have done in this last few months. And also, of course, I want to thank all the attendees, all the speakers, moderators for a great job. So the first session yesterday was the welcome by Philip and Nina. And also we asked what are the type of attendees that we have this year. As Philip explained yesterday, we are more than 100 people here in this meeting, and most of us are cardiologists, and most of us are left atrial appendage occlusion implanters, but also we have several left atrial appendage closure imaging specialists, and also industry. I think that the numbers were around 40 people from the industry. So we set up the framework for this meeting, and we discussed a little bit what should be the consensus theme for this year. And as Nina explained yesterday, we have moved from procedural excellence, so we have discussed about imaging, anatomy, all these kind of things, now move to patient selection. That was our pick. But anyway, we asked the attendees, what do you think about this? So people say that all of us, not all, but I mean, almost all of us, 96%, agree that this year should be patient profiling left atrial appendage occlusion. And also we discussed what we consider consensus or agree, and it was or 50% or 66%. So most of you think that 66% should be okay. After that, we discussed clinical trials and new data on left atrial appendage occlusion, and both registries were presented, the US registry by Dr. Freeman and also the Elaacc registry. So we discussed which are the differences between both registries. Of course, there are a lot, but in the discussion, we decided that these are complementary registry, and also we discussed potential projects, mainly based on the difference in clinical practice between US and Europe. As you know, there are differences in which are doing the cases in US or Europe, interventional cardiology or EP. Combined procedures are quite popular right now in US, and also there are big differences in post-treatment. Another point that we discussed is that in the Elaacc registry we have data to predict or try to predict ERT, and in the US registry they have long-term follow-up based on the Medicare data. After that, Xavi present what we have done or what we can do with the Elaacc registry. So he proposed to have some kind of quality of life paper, and also he discussed, and probably we are going to discuss later with Adele, if we need a dedicated score for this type of variables. And also Dr. Freeman proposed, and also we have discussed this today, a general paper that probably makes sense just to describe what we are doing, which is the LAAC registry without the patient. I mean, just to show what we are doing right now. We have also a voting in this session, and we propose several topics for the LAAC registry paper for this year, and most of you think that antithrombotic treatment after left atrial appendage closure should be the topic that we should address, so we should do this. After that, Philip presented the LAAC initiative, and also he discussed what is going to be the LAAC 2 initiative, because mainly we need still to address some of these variables, so we need to discuss, and we have been discussing this for the last 2 days, patient profile. Also, probably we need a definition of dedicated high bleeding risk population. We still need some information about management of concomitant procedures, sex-specific outcomes, and of course, and now this is a fancy topic, integrated prompts in our results, and probably additional methodological and clinical gaps need to be defined, so this is the LAAC 2 initiative. After that, it was a great session because we discussed what we have, the new data. This is quite interesting, and initially Tom presented the alone AFib trial, and we have again here several poll voting. So based on what Tom presented and the data of the alone AFib and the Ocean trial, 82% of the people here believe that we can skip oral anticoagulation post-ablation in patients with low risk, so CHADVAS 1 or 2. And also we consider that we should not skip oral anticoagulation in patients with previous stroke. The last question we did was if we should monitor for recurrent AFib and which method, and most of us think that Apple Watch or similar should be the way to go, so it was almost 60%. After that, Carster presented closure AFib. I think it was a great presentation, really nice presentation. And also he made 2 comments that I think is really worth to take into account. So probably dual antiplatelet treatment is not the way to go. We have discussed this during the whole meeting. And also he presented that if procedural bleedings are excluded from the analysis, the results are not so bad for left atrial appendage occlusion. So we have 2 questions here. One was if now we should change after the results of closure AFib and forget about left atrial appendage closure as a stroke for prevention strategy. Of course, we say no, so 95% of the people say that we still, even we have the closure AFib results, left atrial appendage closure should be a strategy for stroke prevention. And of course, and it was a big point of discussion, we know that this is a selected population, so we should take this into account. After that, champion AF was presented by Jens Nielsen, and we have a lot of results. He presented that probably the difference in stroke, that was one of our major concerns, was only 0.33 per year. So we consider, and this was not, it was only 60%, that we, based on this result, we should make self-decision-making approach for stroke prevention in this patient. There were 32%, so it was not a big consensus that probably we need to wait for the 5-year follow-up results just to think what we are going to do. The session 4 was about patient profiles and emerging indications, so we discussed left atrial appendage closure in hemodialysis patients. And we have another questions here. What was the preferred approach for stroke prevention in hemodialysis patients with atrial fibrillation? 50% of us said individualized decision. Also, we discussed that there are several trials, and we really believe that most of these patients should be included in trials, so we will have data, strong data in the near future. And as you can see here, again, based on the results, almost 50% in both questions asking what we will do in a patient with end-stage renal disease and no prior bleeding, or with prior bleeding. Anyway, we said that individualized decision because it was 50% and 50%. Also, we discussed about breakthrough stroke under adequate oral anticoagulation. We discussed these 3 trials at LAO by Sabi, Elaacc by Laurent, and also LAOS 4. And these are the 2 questions that we did yesterday. So first question was, should stroke despite adequate anticoagulation be considered an indication for left atrial appendage closer, 53% say yes. But on the other hand, when we ask what is your preferred approach for secondary prevention of stroke despite oral anticoagulation, 97% of the people say additional left atrial appendage closure with or without oral anticoagulation. And most of us agree that oral anticoagulation, even if you perform left atrial appendage closure, should be continued. We talk also about patient preference and not compliance. There was a comment about, I think it was Domenico, saying that in patients that don't want to take oral anticoagulation, one possibility is offer also ablation. And this is the question that we did here. If the patient refuses to take oral anticoagulation, what will we recommend or what we are going to do? And most of us, 72% say left atrial appendage occlusion. The last session we had yesterday was about the development of a novel scoring system, and we discussed a lot of Elaacc registry and also Elaacc classification. So I think Jens did a nice summary of the session. So we have 3 topics here. One is anatomical score, so the Elaacc score can predict complexity, so probably we need to analyze time, recapture, things like that, not just PBL or DRT, because for PBL and DRT probably we need something more sophisticated. We can say, I don't know if with the tool that Sergio has presented, we can do that. And also we discussed a lot, and Adele is going to present this. We consider we need to develop a clinical score. So we performed several questions about which variables should we integrate in the clinical score. I'm going to make a quick summary. So most of us agree that age should be included, and the cutoff is 80 years. Also, we discussed about frailty, and we consider that the ETF score more than 3 or 3 should be included. Also, chronic kidney disease with a GFR less than 30 should be included. LV ejection fraction, and the cutoff we decided was 35%. Of course, we say that we should include prior bleeding, mainly major bleeding, as you can see there, and also body mass index. Here the question goes just for less than 18.5, but also we discussed that probably we should also include patients with very, very high body mass index. We say that diabetes should not be included. And also, and this is for me at least quite surprising, after all the discussion that we have about futility, we consider that the cutoff should be more than 20% mortality at 1 year. Now it's going to be faster. This morning we discussed LAA closure and EP-oriented considerations, so we have several discussions, and also I will present this concomitant versus sequential. And Claudio Tondo present the possibilities of isolation of left atrial appendage occlusion, as he has also discussed. After that, we have the session about left atrial appendage closure devices. So we present the Amulet 360, the Flex Pro, the Conformal, and the Zenith. About the Amulet 360, we discuss about the change in the hooks and safety. Mainly for Flex Pro, we discuss about DRT and the new cover that it has. It was a very nice presentation by Ole about the Zenith device, and one nice feature that this device has is that you can inject through the device before releasing, so you can check if there's any leak. And also we discuss about the AcuFoam and the early complete sealing as a nice tool. We also discuss new tools and techniques, so just quick summary, we talk about ICE 3D, we talk about the stable seat, we talk about artificial intelligence, and also we discuss about remote proctoring. There was not a really poll, but we raised hand, and most of us support the use of remote proctoring after a few cases or second opinion or complex cases. We have a nice session about challenging cases, and we discuss the possibility in some cases double device, steerable sheath, and how to close leaks, in which cases we believe that we should close these leaks. And the last session, that was just before this session, we have reviewed all these proposals for the study, and as you know, finally the proposal of Sergio seems to be the most attractive for much of us. So thank you so much for being here. It has been a great, great meeting. Thank you.
Thank you, Ignacio. You did a terrific work, like summarizing all the brainstorming and the beauty of this meeting, which is definitely not like other LAA meeting, I mean, with all this discussion that we have. So we go straight forward to you, Adele. Based on this voting and consensus that we get, you have to draft the steps and the next consensus paper on patient profiles.
Thank you, Philippe. So this is episode 2, because yesterday I didn't have a lot of time to talk, but it's the same today. But yeah, I think one of the things that we want every time for each meetings to end up with a consensus about what has been discussed during the meeting. So we have discussed a lot about, because of the new trials, Champion AF, Closure AF, all the data that we have, recent data that we have to deal with. We have discussed a lot about in which patient will benefit or will not benefit from this procedure. And I've talked yesterday about these early mortality issues, which can be high in some registries, and we said that we have to try to find out in which patients the procedure will be futile. So futility is a procedure that carries a risk, but insufficient time to benefit from the selected procedure. Then we talked about Closure F. There's a big discussion about the patients that were included in this randomized trial, and the answer was to better select the patients. And at the time being, we don't have a clinical score to assess in which patient mortality will be high and in which patient we estimate that the procedure is futile. So that's we discussed yesterday. It's just a project at the time being, and of course that will be also be included in the consensus as a future project. So to identify clinical parameters associated with high risk of mortality after LA closure. I've shown that yesterday, but I would like to show again that in some registries, you have patients at low risk, again, like in Champion AF, like a randomized trial showing a low mortality, but in some randomized trial or some registries, mortality, 1-year mortality is extremely high. And just going back, I showed again this registry because we have already like independent predictors. We see that they have included like a little bit more than 800 patients in this Spanish and Canadian registry, and there is a 15.5% death within 1 year. So they had enough events to calculate 5 independent predictors. Very importantly, the procedural success, something that we need to agree on, is that you can have a good procedure, but the patient will die from comorbidities. So the procedural success will not determine the 1-year outcome, in my opinion, but we can still discuss that. So here there were like 5 predictors: age, which here was dichotomized, BMI, diabetes, EGFR, and heart failure, previous heart failure. And there's already a risk score already available in the literature that we could, this is discussion that I just had with Xavi now, that should we validate this one or should we go and try to find out a new risk score from the Elaacc registry? So that's a question that is open. And you see here, for example, if you add 3 risk factors or you go to 4 or 5 risk factors, you end up with mortality at 1 year above 30% or even close to 50%. So really a patient that you will treat that will die with a high likelihood of dying during the first year. And the same group, as I said, showed yesterday, also assessed frailty score, a very easy one, the essential frailty tool, which is relatively easy to perform even at the bedside of the patient. And they showed also that on top of the clinical variables, this score was also associated, when it was high, more than 3, at least 3, with a very high mortality as compared to patients who were not frail or just pre-frail. And this is also important. So as Ignacio has shown, there was 2 large consensus. So the first of all is that the consensus should define which is the best patient profiles for LA closure. And the second thing is that the clinical score on top of the anatomical one is needed. So now, the consensus statement, it will focus on patient profiles. So this is a mix of evidence and expert agreement that we have voted all together. So which will try to define the document, the typical good candidate for LA closure, which profiles we should avoid because the patient has too high risk or a high risk of mortality. We will, of course, develop the emerging indications that were developed during the meeting, and the consensus rule that we needed at least 2/3 to have a strong agreement within the group. The next step is to end up with this kind of clinical score and should be data-driven. Maybe it could be registered as part of the Elaacc registry or any kind of multi-center registry that you are able to perform. We need to derive the 1-year mortality from the Elaacc registry. There was a big discussion yesterday about should we include already dichotomous variable or just continuous variables. I would show you that in the tri-score they did it like a mixed, a hybrid approach. Then we need, as a classical statistical approach, internal validation to do the score, external cohort, and you need to define the threshold, futility threshold, sorry, for 1-year all-cause mortality. Just showing back because there was a big discussion yesterday, and I just want to show that it's difficult to see, but on the variables that were put in the tree score, you see that they put continuous variables, but also dichotomous variables in the same way to analyze the independent predictors. I think the LAAC field just faces the same challenge, and we need a clinical score because we have a very heterogeneous population, high variability in outcomes, so we need that kind of clinical score. This is just an example. This is the tree score. So just they ended up at least not with continuous variables, but with dichotomous variables. And all these dichotomous variables were included in the score. You see there was a cutoff for age, there was a cutoff for INEA functional class, there was a cutoff for example, daily dose of furosemide. So all these dichotomous variables were included in the score, and this brought actually a very high prediction for mortality in hospital and 1-year mortality. So there is pros and cons, but I think we should include both. I think we should call it all variables as continuous and derive the model with continuous variables and dichotomous variables to end up with a simple bedside score that we can back by a rigorous validation. So that was the result of the vote, which dichotomous variable we want to include in the clinical score, and this is just a glimpse into what could look the clinical score in the future. We end up with very simple clinical parameters that we can really do easily. We can collect easily at the bedside, and we could end up with like kind of risk bands, you know, going from low, intermediate, high, futile, every time with a predicted mortality. And you see, for example, if it's a high, then we should envisage the procedure with caution, with shared decision making, and we should set up a threshold when we see that the expected 1-year mortality is too high to consider the procedure. And the vote yesterday was that this futility threshold, this 1-year mortality that we should not accept, it was 20%. But you see that it was the consensus was for this threshold, but still some people say that 30%. So can still decide what will be the threshold for futility when you should really not go into this procedure. So how can we validate this score? I think we can use either what was published before and validate it in the Elaacc registry, like Xavi said, but you just had this discussion like 5 minutes ago, or use the Elaacc multi-center registry, either for recalculating independent predictors or for validation. The only thing is that the study I showed from Spain, they had a high rate of mortality, so they had enough events to calculate independent predictors. So we should end up with a population with enough events to have those predictors. If it's a very low mortality, then we need a lot of patients. So let's see what we get from the registry. And also it's very important that we decided to include a frailty score, and this should be collected prospectively. And so that's another point that we need to decide upon. Ignacio has already shown that the other agreement within the audience, and I would just summarize the next step. So the consensus will be the patient profiles for LAAC. That will be the focus of the next consensus paper. And the future will be to dedicate a clinical score to assess which patient benefit the more from this procedure, try to define a futility threshold and use whatever we have. But I think the Elaacc registry is really the good tool to validate and to assess this clinical score. So thank you.
Thank you, Adele. That's brilliant. I think it's the best way to reconcile all the data we had this year with all these trials, champion, closure, and all, and we will proceed. Ole, you have the task to invent the future with the community, so.
No, maybe first still on Adele, I mean, I think it was brilliant what you showed. It's really something what is needed. But I want to ask here in the audience, like who gets referrals, yes? Who of the referrals for LAA closure, at least 10 to 20% of these referrals refuses therapy for these patients? Who does that? Yeah, if you get a referral for an LAA closure, you make some selection, and let's say 20% of the referrals you get referred to you, that you say, no, this patient he would be too high on the score here for fertility. I don't offer, I say no for this patient, I bounce him back. Like, few.
But 20, I mean.
At least 20%. But I think, look, if we come with this, you have to be open to this, yes? I mean, we, even in Copenhagen, we say no to 30% of the referrals we receive, or even more, close to 40%.
Because you have a lot.
No. Yeah, but that's the bad spirit. So if you just treat the patient because you want to do the procedure, that's not the way to go, yes? So you have to be open. For example, all these patients with an eGFR less than 30 millimeters per minute, I mean, probably, don't start with it. These patients are nearly dead. They're half dead. Yes. So, treating these patients, that doesn't serve anything. You see also in the closure RF trial, 25% of their patients have severe renal function. That's like a patient who has one foot in the grave already. You just before he dies, you put in a closure device. That doesn't. That's not the way to go. But anyway, so I think if we work on that, we have to be also open and realize that in the future we will have to say to a significant amount of our referrals, no, we're not going to close your appendage. So you're going to lose volume by that.
No, yes. That's for sure. I completely agree. And the thing that I also wanted to mention, and going back to the Elaacc registry, that apparently we need to add just 2 variables in the registry. One is the frailty. Okay, so I will speak with Anders. And the other one that I don't know if we should also implement, diabetes is in the chat box, but insulin dependent, it's not. So should we put it, or it's, just...
Okay, that can be worked on later offline also, I guess, but indeed we have to discuss this.
No, frailty for sure, so, we will...
Yeah. But I want to hear also, yeah.
Ola, I very much like what you're saying. I am completely supportive of the idea, but I also want to say that we should be careful not to push it too far. I disagree with the idea, for example, that a GFR 30 patient is half dead.
That's now said indeed in extreme, but yes, we have to be very critical.
But the point is, the patients we are seeing for referrals are not healthy patients to begin with, else they would not be referred. And we are treating cancer patients with monoclonal antibodies for a few million euros for an extension of survival of 2 months.
But
if we can
with
offer
closure
a
RF, it seems
reasonable quality of life for 1 year, for me is an acceptable indication. 1 year quality of life is okay.
But with these cancer treatments, typically you try to make the patient still better. In closure RF, it seems there's even a signal we damage. We harm the patient more than we...
There needs to be a threshold for sure. And if you will not survive a year, I agree. But let's...
No, but indeed, it was a little bit...
That will be the beauty of having a score, because if you take the variable individually, maybe you have less than 30, but you are in a good shape and so on. And that's you add on top of that dementia and very old age and blah, blah, blah. And then...
frailty.
Then the risk is super.
Okay, it's going to be interesting too. Also, if you work on a consensus document, I don't know, it's just to throw in the group as well. I've been involved now lately in the last year in 2 consensus documents to get it really in a decent journal. What they ask and demand is, but it's mandatory that you use the Delphi method. I don't know if you... So just coming up with a consensus document these days that doesn't... The journals don't pick this anymore. So the Delphi method, it's something like you have to be, among experts, have to have 80% agreement. If not, you have to rephrase your statement until you have 80% agreement. So there are some strict rules for that now these days for journals to accept consensus papers in that way. And then maybe for the future, for next year, I think another idea I want to maybe throw in the group, if the Elaacc registry would come to run, I think this could be an ideal tool to do some cluster randomization. I don't know if somebody has heard about this, but we're going to start using this in the Nordics for the TAVI. So there's some connections between different centers in the Nordics where we use the same REDCap database. And what you can do is cluster randomization. So that means you, for example, easy topics. Let's say you want to investigate for TAVI, for example, is a bifemoral approach for your pigtail or for your radial. Yes, you could cluster randomize, or which antibiotics for infective endocarditis prophylaxis, or is aspirin as good as clopidogrel or double antiplatelet? And the great thing is that you don't need consent of the patient. Yes, so you can just do this, and then you say the cluster randomization will decide, for example, if you treat the patient in an even week or in this month, then you will have to do all this kind of arm of the randomization. In the other week or the other month, everybody who participates will have to fall into the other arm. So in that way, you can do in a big cohort without consenting patients. And so you can do this. So I don't know, is that something which some people are thinking of using? And I think this would be excellent, because in that way we could really produce prospective, randomized data and results, and we could really contribute to the field, not just on some 100 retrospective study again, which is very selected bias. So I don't know. Because it's cluster randomization. You have to, of course, it should be standard therapies that people use anyway. Yes, it should not be something completely new, experimental. But if, for example, sometimes you use aspirin or clopidogrel, that's kind of equally perceived in the clinic. You do that already. So ethical committees, in the Nordics at least, they approve this, that it doesn't have to go through ethical committee. You don't need consent from... Sorry? It's a European law. Okay, so it's a European law. So I think this is where we could really make a difference, you know, in the Elaacc registry. If people participate there and you say, we cluster randomize, you click in the registry, okay, I participate in this cluster randomization for let's say, clopidogrel versus low-dose DOAC. You can click on these things, and then, of course, you can put some criteria that your patient should fulfill on certain criteria. Then you could do really randomized prospective trials in a very easy way. Yeah, so I think this is something we should really discuss and consider doing. And then for the last 5 minutes, I want to hear, I'm not going to talk, I want to hear what should be the focus for next year. So this year was more the patient selection. The year before was more on imaging. So what should be the focus for next year? What is the appetite and the interest in the group? Can somebody voice out what he or she would like to see being discussed most focus on? Back to the procedural, some procedural aspects, or what is the appetite? Nobody wants to? Tom, what would you like to see? What focus?
Intuitively, when you said it, I was thinking back to something procedural or something more on the technological aspect, because we covered patient profiling, we covered imaging. I think it's worth going back to device innovation. There's a lot of stuff coming out. I think it's worth focusing on...
Or steerable sheet, not steerable sheet. I mean, that was my thought too. I mean, going back to basics to what there's many implanters. There's also imagers here, of course, and we had a big topic on imaging last year. So maybe going back to the real technical aspect could be attractive for me, but I don't know. Yes, Lisbeth?
Now that I'm just thinking out loud. What I learn most, especially from the last hour, is that we learn so much from non-physicians, from engineers. They have a completely different mindset of thinking, and if you put a doctor together with an engineer, you get these nice images of Sergio and of Jordi. I think we can still learn a lot about patient selection and anatomy, device selection, based on new technologies, new software. That is not something we are familiar with, but we need to collaborate, I think, with non-physicians, with very smart people, engineers. No, gaining new insights based on AI models that calculate Sergio's model can show us this patient should be treated better with this, or this big left atrium should not be treated with an appendage closure. You can leave him without an appendage closure, for example. I think we should think outside of the box than what we are used to, and have more AI, it's a stupid word, but more other technologies coming into our field. Because otherwise we're always talking about the same things, while I think there's much more potential out there.
Yeah, and
Okay.
linking with
Ole.
the last comment,
Yes?
probably maybe we need to integrate also the atrium, you know, because we focus a lot in the
Integrate the
appendage,
what?
in the patient selection, and maybe with treatment we are going to give the patient afterwards, based not only in the appendage, also in the atrium, because if you have an appendage with an atrium that is not moving with low flow, it's not the same as small one that it's contracting. So I don't know, just integrating in what Lisbeth was saying, that probably with this AA tool we can also put that.
And also with all the Elaacc data, I'm sure that we will gain new insights based on the clinical data if we let the machines decide
Okay, so
which
maybe
criteria are
I
good
hear
or
an
not good.
appetite to go on to the AI. What can it really contribute? What not? What is AI? Because I mean, there's even, I think there are a lot of discussion. Some people interpret some things as AI, which is not AI. It's just computational, something further pre-planning. But so that could be good to make us wiser about that topic. Yes, I don't know. Yes. Yes,
Yeah,
Erik?
I think we have now the two large studies, Closure AF and we have Champion AF, and it's just the initial primary publications. There will come a lot of sub-studies from both Champion and I suppose also from Closure AF, so we can get a much better understanding on the strokes that are in Champion AF, for example. So I think there will be a lot of clinical data still to need our interpretation.
Yeah, okay.
And I hope also for next year we will have the simplified trial. That will be probably some of the most valuable data for post-procedural medication. And so I think we need to have still the clinical data in focus for next year.
Okay, so more, okay, good. That's your proposal, to go more in depth on the data, the clinical data that's going to come? Yeah. Okay, Sergio?
I have a proposal. I think we could send a call for ideas, 2 weeks, for send one row with the proposal, so everyone will have time to reflect and to send a proposal. After that, we have a list of proposals and we decide.
Okay, that we ask the participants to say what they want to hear?
An email to everyone, to all the participants.
They can email. Oh yeah, yes, yeah. And then a poll. Okay, so you want us more to get some topics, the topics that were mentioned here, I'll try to memorize them.
Just few words with the topic.
Yeah.
AI
okay.
or what else.
Okay, that's a good thing. Like a poll, we can do that with the topics that have been brought up here. All right, that's good. I think, okay, Philippe is gone. So I thought he was still on the point. No. Okay, no, but good. I mean, we will do that. Then we can hear and adapt, hopefully, for next year, the program a bit in that, in the direction you ask us to go. So with that, I think I want to, complete on behalf of everybody, because I'm not talking for myself, but I'm for the whole organization, Alexandra, the whole organization behind, and also the faculty and all the participants. Thanks for being here. Also for the company supporting this meeting, of course. Without them, we couldn't do this. So thanks for everybody and safe journeys back.
Okay, thank you everybody. If you are interested in getting a bus transfer to the airport that will be leaving very shortly, please make your way with your luggage to the foyer area just out where the registration desk for the meeting was within the next 5 minutes, because we're going to try and make the bus leave as soon as possible, because some people have got flights in 2 hours' time. So thank you so much and safe journeys. See you next year.
Okay, you can sit.